and evaluate emerging technologies across the globe. We accordingly welcome you to join us and witness the advances in this field together. The conference has attracted delegates who have come from all over the world across the continuums, and the subjects of the conferences is surely of global importance. UCG thanks all the individuals and organizations who have worked to make this conference a grand success. UCG Program Committee has put in long hours with many creative efforts. And finally, I would like to extend my appreciation to the participants of this conference. We hope you enjoy the conference and that our participation will contribute to our professional development and relationships. And the note here, speech timing for speakers will be 13 minutes, and the speech timing for keynote speakers will be an hour. The certification of this Congress will be provided on November 1st, 2021. I take the immense pleasure of introducing the keynote speakers at the 9th World Breast Pathology and Breast Cancer Conference. Dr. Michael Retsky, University College London, USA, Dr. Ali Mukhtar, Noruzpur Diagnostic Laboratory, Iran, Dr. Lulab Al-Quraishi, Certified Pathologist Assistant, Sipardin, USA, Dr. Jayapal, President, Cancer Foundation Trust, India. Thank you all. We will now begin the session. So let's start with our first speaker, Mrs. Andrea Nelson Tuacar from Romania. So I am passing her the stage to deliver the speech.
Hello, good morning. Thank you very much for this opportunity. I'm very happy to be here. Please excuse my voice. I'm recovering from the well-known disease, and I'm still left with a bit of voice. Again, thank you so much for this opportunity, and considering the fact that we are in 2021, I thought to present today an interesting topic about digital pathology, especially when it comes to diagnosing breast cancer. And if you allow me, I will start share screen.
Yeah, sure.
I think I have to be, I think the host needs to enable participants to screen share.
Yeah. The host now is, I think, UCGConferences.
Okay, it's working.
Yeah,
it's working now. Okay, can you see my screen?
Yeah.
Yes.
Yes.
Okay. So as I was saying, my name is Andrea Nelson Tuacar. I'm a fifth-year medical student at the Faculty of Medicine in Ovidius University in Constanța. And today I will be talking about digital diagnosis in breast cancer pathology. So first I will try to offer you a bit of background about breast cancer. It's the most frequent cancer worldwide, and it is also the second highest cause of cancer-related death. Histopathological diagnosis, which guides therapy and prognosis, is the cornerstone of a breast cancer examination. However, as we learn more and more about the complicated nature of medicines, about the complicated nature of cancer, and medicines become available, the chances for improving diagnostic precision have emerged. Parallel to this, improvements in artificial intelligence and the increasing digitalization slides of pathology slides for primary diagnosis offer a very viable way to address the demand for a more precise detection, categorization, and prediction of a breast tumor behavior. Since the first reports of telepathology have become available, there is a growing interest in the potential to conduct remote diagnosis, which is one of the benefits of using digital pathology. Basically, specialized pathologies, they have access to remote areas. A pathologist examines these glass slides under a microscope as part of the diagnosis process. Thanks to digital pathology, experts can now operate remotely and interact with other experts when, for example, they need the second opinions. In this study, I will discuss the numerous advantages to incorporate digital pathology into clinical practice, as well as its limitations. Despite the fact that this has long been recognized, the use as a diagnostic tool is still limited among pathologists. For example, some of pathologists, they estimate that the future use is still far away. Furthermore, this study also looks at several types of digital pathology implementation methodologies that have been used in clinical practice, as well as what can be learned from a larger healthcare experience of adapting and maintaining innovative healthcare solutions. In this slide, I've decided to present you the changes in time when it comes to the acceptance of digital pathology. For example, we can see that from 1986 until 2019, at which the data was no longer available, this shows a literature search for the most commonly used phrases, such as digital pathology, telepathology, and whole slide imaging. We can see from these slides A and B. For example, in A, we can see the results of the number of publications containing search items like the ones I just mentioned in all publications in picture A, and in picture B, publications also included implementation. So, for example, we can see that the digital pathology search over the years has increased, as well as when we included the word implementation, which kind of shows the trend where we are heading. When it comes to the conventional role of the pathology, nevertheless, it's extremely important. The gold standard for cancer diagnosis is pathological examination, which also includes clarifications of the origin, pathogenesis, clinical pathological correlations, and prognostic. The Scarf-Bloom-Richardson grading system for breast cancer was developed using microscopic observation based on tubule development, mitotic activity, and cellular pleomorphism. Tuber diameter, axillary lymph node status, glandular formation, and the proportion of intraductal growth were found to have prognostic value for up to 5 years in a long-term study for over 464 patients with breast cancer. The mitotic index was significant for the first 2 years, but histological grade and morphometric nuclear factors had only short-term value. Digital pathology has grown into a thriving industry with the commercial release of whole slide imaging. The capacity to scan a full pathology glass side has been transformative, creating a trend of therapeutic, educational, and research uses. As a result of continual technological advancements in optical imaging technologies, it is now possible to generate enormous amount of microscopic data quickly. The first digital microscope systems cost around $300,000, and scanning a single slide took over 24 hours. These technologies have come a long way in the last 20 years. Today, whole slide scanners can produce very high resolution images that look exactly like glass slides. Large whole slide imaging data sets can now be processed thanks to major advancements in storage and computing technology. Depending on the scanner, they can store a few slides from a few slides images or up to a few hundred slide images at one time. The pathology scanner will also scan slides and reproduce images into a software. This software compresses these large data files into readable and transferable sizes. Now, when it comes to regulatory requirements for using whole slide imaging, whole slide imaging devices have evolved into major diagnostic and scientific discovery tools in pathology. As a result, as I said, when it comes to requirements, the scanners are currently approved for their use in European Union and under the European Commission's directive for in vitro diagnosis. Different manufacturers of scanners and software, such as Philips, Hamamatsu, and others, have received the proper certification for this. Starting next year, so as of May 2022, all in vitro medical equipment, including slide scanners and digital pathology software, must apply for European Commission approval and to receive proper regulation. When it comes to devices, optical and digital microscopes, a primary difference between these two is the magnification. With an optical microscope, the magnification is found by multiplying the lens magnification by the eyepiece magnification. Since the digital microscope does not have an eyepiece, the magnification cannot be found using this method. Instead, the magnification for a digital microscope is found by how many times larger the sample is reproduced on the monitor. Therefore, the magnification depends on the size of the monitor. The average digital microscope system has a 15-inch monitor. And this results in an average magnification difference between an optical microscope and a digital microscope of about 60%. 3D measurement is achieved with a digital microscope by image stocking. Using a step motor, the system takes images from the lowest focal plane in the field to the highest one. Then it reconstructs these images into a 3D model based on contrast to give 3D color image of the sample. From these 3D model measurements can be made. For this 3D model measurement to be made, their accuracy must be based on the step motor and depth of the field of the lenses. In this slide, I wanted to show you a few images, a few pictures with digital scanners. And like I said earlier, there are different manufacturers. Basically, using a specialized loading dock, as you can see in picture 1, for example, the whole slides are loaded into a component. And also, we can actually see in picture 1, 2, and 4 and 5. So the slides are loaded into a compartment, and the slides are digitalized into files. These scanners contain a much more specialized camera equipment to make sure that every single detail is transferred into the image scan. like I said earlier, that depending on the scanner, these digital scanners can store from a few slides, 5, 6, for example, up to a few hundred slides at one time. The pathology scanner scans the slides and reproduces the images into a software. This software compresses large data files into readable and transferable sizes. On picture 6, I added picture 6 because later on I will be talking about artificial intelligence. And for example, one of the features of these digital scanners is that it recognizes certain histopathological structures, as you can see them highlighted in green, and it takes them individually and it is analyzing them, offering possible diagnostic. When it comes to digital pathology in breast cancer, as I said at the beginning of my presentation, breast cancer is the most frequent cancer among women all over the world. Early diagnosis and better therapy have significantly improved patient outcome in recent decades. Diagnosis by histopathology has proven to be crucial in guiding breast cancer treatment, but new problems have emerged as our increasing understanding of cancer over the years has been revealed its complicated nature. We face an urgent need for more precise biomarker evaluation and more accurate histopathological breast cancer diagnosis to make better therapy decisions as patient demand for individual breast cancer therapy develops. Through computerized image analysis, pathology data has been digitized, allowing for faster, more reproducible and more precise diagnosis. In 2020, there were 2.3 million women diagnosed with breast cancer and over 685,000 deaths globally due to this tumor. At the end of 2020, there were 7.8 million women alive who were diagnosed with breast cancer in the past 5 years, making it the world's most widespread cancer. Breast cancer patients' prognosis is highly diverse depending on the number of prognostic factors. Breast carcinomas are classified into several histologic subtypes and have a wide range of morphologic characteristics. Breast carcinoma starts from the mammary epithelium and generates ductal cancer in situ, which is a premalignant epithelial growth within the duct. However, cancer cells may develop the ability to break through the basal membrane of the duct walls and invade nearby tissues at some point. When this happens, it's called invasive carcinoma. How can digital pathology help when it comes to this tumor? Basically, sorry, here are some features of different ways of diagnosing breast cancer through a light microscopy or digital pathology. When it comes to light microscopy, the examination of tissue sections is performed manually, and of course the grading tumor is performed manually by the pathologist. The histologic grade of a tumor has been proved to be a powerful prognostic indicator, and it is included in every breast cancer specimen's pathologic report. Bloom and Richardson method for histologic grading has been recently modified by Elstone and Ellis. Invasive breast cancer are graded using 3 morphologic features, such as tubular formation or glandular differentiation, nuclear pleomorphism, and mitotic counts. Each of which is assigned a number of from 1 to 3. The combined score determines the overall tumor grade 1 to 3, which is known as the Nottingham histologic grade. When it comes to digital pathology, personalized breast cancer therapy will need complex investigation at multiple levels, such as the tumor's genomic makeup. Correct biomarker assessment is critical for making accurate therapeutic decisions in breast pathology. The complexity of histopathologic breast cancer diagnosis is growing as the equipment requirement for its accuracy. However, in most regions of the world, pathologists are in short supply. Computerized image analysis in breast tumor histopathology has the potential to improve breast cancer diagnosis and assist pathologists save time by reducing time-consuming procedures like biomarker assessment. So we can see, for example, that digital pathology can reduce time, very precious time, in diagnosing this disease. Now I will be talking about a concept called deep learning, which is currently, right now, is the most used method for supervised data learning. In recent decades, however, a wide range of machine learning models have been presented. Many of these techniques are now used in diagnosing medical imaging. In classification tasks, for example, a decision tree is utilized for supervised learning. Basically, it works by breaking down the decision-making process into a series of tests that must be completed in order. I'm just gonna move this so we can see the full, okay. Each decision correlates to a node in this tree-like structure of testing. Starting with a single root node, each node performs a test in the input sample and then transmits the sample to one of its offspring higher up the tree based on the test results. When a sample reaches a leaf, which is a leaf is a node with no further nodes, so that's where it stops basically. The sample is assigned the decision associated with that leaf. Decision trees are very efficient in both training and interference, but when the model grows overcomplicated, sometimes it fails to generate new data. To make this learning more resilient to data variances, a random forest employs an ensemble of decision trees. Basically, on this image on the slide, shows the difference between traditional machine learning, which is A, which is the top of the image, and deep learning, which is B. In A, as we can see, in this traditional machine learning, several steps require human knowledge, require expert human knowledge, so it cannot be done using a computer. And the human, which is the pathologist in our case, is required to recognize cancer in images. First, image processing, such as segmentation, corrects the image and breaks it into manageable parts. That's at point 1, image processing. At point 2, feature extraction. Handcrafted measurements are extracted from each part. And then at point 3, a machine learning algorithm is provides these features as a vector, which is used to learn a predictive method. At B, we have deep learning, which is an end-to-end approach to learning, takes raw images as input and directly learns, provide the model to produce them into the desired output. Deep learning uses biologically inspired networks to represent data through multiple levels. of simple but non-linear modules that transform the previous representation into a higher, slightly more abstract representation. The nature of the architecture allows deep networks to form a highly complex and non-linear representation of each layer. The result, this provides a result of the image analyzed. Basically, only a few, however, despite all the advances in this area, only a few pathologist laboratories have embraced a digital workflow in routine breast pathology, which has limited the use of digital image analysis. However, there is evidence that automated image analysis improves biomarker assessment reproducibility. It won't be long before digital pathology becomes the norm, such as, for example, radiology. By recognizing common patterns in distinct molecular subtypes of breast tumors, deep learning algorithms for computer-aided prediction may soon be able to obtain similar predictive data, such as gene expression profiling. Deep learning would be a much cheaper and faster alternative to gene expression profiling, for example, in this scenario. However, there is still a number of obstacles to overcome. Deep learning can be fully utilized if the lab has a fully digital workflow, which is evolving quite slowly due to the high cost and reliance of a good IT support system. The issue of annotation persists. To what extent they are required and how can they be standardized, especially because we saw in the image before that the tree can become quite busy with many leaves. Although complete tumor section have gotten a lot of attention, diagnostic problems might still arise with core needle biopsies, which have only a little piece of tissue in which the primary diagnosis is frequently given. Ductal carcinoma in situ can be difficult to distinguish from actual invasive tumor cells when there is only a little amount of breast tissue available. Machine learning could assist the pathologist in making this vital judgment. Furthermore, the problem for machine learning is not to detect tumors or metastases in images, because qualified pathologists can do this quickly. It's much more than this when it comes to machine learning. Deep learning is most useful for predicting therapy response and tumor prognosis, as well as combining or complementing genomes and transcriptomics for patient satisfaction, stratification. This is the true problem, and making individualized cancer medicine easier will be much more crucial. For the development of appropriate algorithms and computer-aided prognosis, there has to be collaboration between computer scientists, bioinformaticians, and research pathologists. This is critical if we want to achieve this. Furthermore, I will present some of the results of this study. Breast pathologists are under increasing strain in terms of case number, case complexity, and the necessity for fast examination and review in order to reach cancer diagnostic and therapeutic targets in clinical pathology. The use of the use of full slide images for diagnosis of breast biopsies has been the subject of a number of digital pathology validation studies. In a previous study that evaluated 100 breast biopsies, Al-Janabi and collaborators found a 93% concordance rate. which is quite impressive. Another study conducted by Campbell and collaborators showed a 95.4 agreement between 3 pathologists that examined digital and glass diagnosis sample of 85 breast samples. These 3 specialty breast pathologists completed training in the use of digital microscopy system, and they were exposed to different challenging cases. Following this, the 3 pathologists view a total of 85 breast samples, but actually there were a total of 694 slides. All primary diagnoses were made on digital slides with immediate glass slide review and reconciliation before final case sign out. There was almost a complete clinical agreement between the glass and digital diagnosis. In only 1.2% of cases, there was a significant difference in diagnosis between the glass and digital slide reads. The discordant diagnoses were found in both studies mentioned, Al-Janabi and Campbell with collaborators, for a small number of diagnoses. Mainly, these differences they refer to the distinction between hyperplasia and atypical ductal hyperplasia, the differentiation of benign phylonodes tumor from fibroadenomas, and the identification of microinvasion or lymphovascular invasion centers. So most of the differences in diagnosis referred to this. Another study conducted by Reyes and collaborators discovered that digital versus glass variation in diagnosis. The result of this study found that between 1 to 4% there were differences in diagnosis, and most of the cases, most of the differences referred to the distinction of ductal hyperplasia from atypical hyperplasia. In this slide, we can see that all the participant pathologists, the study conducted by Campbell and collaborators, identified a proportion of cases for which they preferred to use glass slides over digital slides. So we can see, for example, that the pathologist number 1 preferred more digital slides as opposed to glass slides. We can see that pathologist number 2 almost, when it comes to all the slides, most of the slides he preferred to look at were the digital ones, and the pathologist number 3 preferred more the glass slides. And the 3 of them were roughly the same, preferred glass slides. Another study conducted by Shaw and collaborators revealed their findings after analyzing glass and digital breast cancer slides from the breast cancer cohort research. 9 pathologists gathered data from digital slides of breast tumors, then re-examined the glass slides at a later time. The digital slides diagnosis performance was comparable to that of the light microscopy. When digital slides were used instead of glass slides, there was more agreement between reviewers, between the 9 reviewers, on the degree of tubule formation. This backs up the claim that the whole slide perspective offered by digital pathology allows for a better assessment of the lesion's architecture than light microscopy. In another recent investigation, 4 pathologists examined the readings of 299 breast cancers and found no discordance when using digital microscopy versus light microscopy. In clinical, as a consequence of this validation, the study conducted by Campbell and collaborators, the three breast pathologists now report all cases on digital slides as standard, reverting to glass slides only after they examine the digital slides and only for cases fulfilling set criteria, such as invasive cancers, for which differences in mitotic score could affect the overall grade. Cellular fibroepithelial lesions, cases with radiological confirmation of calcification, but no calcium identified on digital slides, and any challenging case which is not encountered in the validation phase. As a result of this, Leeds teaching hospitals in the NHS Trust made the decision to pilot digital pathology for the primary diagnosis of breast histopathology specimens using a novel validation protocol that offered participants, histopathologists, digital microscopy training, exposure to challenging cases, and the risk mitigated early conversion to a full digital slide workload. When it comes to this study and to this area, there are certain limitations. In clinical pathology, breast pathologists are under increasing pressure in terms of case volume, case complexity, and the rapid evaluation. Integrated digital pathology procedures and interpretation are still rare in today's labs. This is in contrast to radiology, for example, which has been digitalized in most countries during the last few decades. For more than 20 years, radiology departments have had picture archiving and transmission systems in place. As a result, medical image analysis research has mostly concentrated on digital radiography data, resulting in significant breakthrough in clinical applications. The images in histology can be up to 10 times the size the size of those in radiology. High resolution whole slide imaging scanners convert histologic glass slides into digital images. Image acquisition, storage, and administration, annotation, and viewing or sharing all steps in the process. Whole slide imaging scanners are being integrated into everyday workflow of certain pathology labs in an effort to digitalize the diagnostic workflow. However, finding solutions that provide adequate store capacity at reasonable price remains a difficulty. Even though pathology labs are not in the direct line of fire during COVID-19 crisis, we need to establish new ways of operating to adapt to the virus dynamic circumstances. It's necessary, taking into consideration that autopsy is potentially contagious. Staffing shortages are becoming increasingly common as the incidence of infection rises, and other hospital departments may seek pathology employees to perform more urgent tasks. Furthermore, social isolation and lockdown tactics forced many people to stay at home and work from home. During the crisis, it became more important than ever how valuable digital diagnosis may be in keeping pathologists, residents, molecular biologists, and pathology assistants involved in the diagnostic process in a safe environment. Digital pathology has the potential to revolutionize the delivery of breast pathology services. Individual training and validation for digital primary diagnosis allows pathologists to develop competence and confidence in their digital diagnostic skills and aids safe and responsible transition from the light microscope to the digital microscope. Rapid image transfer across geographical boundaries allows for more efficient pathology task dispersal image transfer across geographical boundaries, allows for more efficient pathology task dispersal between linked hospitals, and makes the great use of pathologist time. Rapid access to second opinions in difficult cases, as well as enhanced communication among pathologists on cases, may result in considerable increases in quality of diagnosis. Individual pathologists, many of whom have decades of experience reporting on light microscope, should engage with the new technology, educate themselves on its limitations, and actively learn how to use software and hardware efficiently in order for digital pathology to be adopted for primary diagnosis in treatment in a department. And here are my references. And that was my presentation. I would like to thank you very much.
Thank you so much, Ms. Tawakar, for your nice presentation. And if there is any question, just let us know or write in the question box so we can read it out. If not, we will go to the next presentation. Okay, so the next speaker is Dr. Sagarika Mahapatra from India, and I am passing her the stage to deliver the speech.
Hello, everyone. Good afternoon. I hope you all are having a good day. Okay. I hope my screen is visible.
Yeah, it is.
Okay, thank you, ma'am. So I am Sagarika Mahapatra. I am second year postgraduate student in RRMCH Bangalore. Today I'm going to present a very common topic, that is uterine leiomyomas. It's actually a very common disease in our part of the world. In Western countries also it is high in incidence. So there are very few studies where this uterine leiomyomas and endometrial changes have been compared. So I'm going to discuss an oral paper regarding the how uterine leiomyomas they bring about changes in the endometrium. Uterine leiomyomas, they are actually benign tumors. They account for the majority of benign tumors in the perimenopausal women. Rapid increase in incidence occurs after the age of 30 years. Mostly because of use of oral contraceptive pills and also time-related changes, time-related hormonal changes. This occurs in about 70% of the women worldwide, with the true incidence being highly underestimated, as many women remain asymptomatic. They don't present with any kind of symptoms. They do not present with any kind of symptoms. And after certain age, the leiomyoma starts growing in them, and they can manifest with dysfunctional uterine bleeding, pelvic pain, pain during urination, and even when it progresses, it can lead to infertility and other life-threatening complications, including intraperitoneal hemorrhage, which is a very life-threatening complication. Okay, so these mostly obese women and those with a family history are strongly predisposed. Obesity actually the excess of adipose tissue, they will increase the estrogen content, and so they predispose the women to leiomyoma. An increase in 10 kg can predispose a woman to 30% more chances of having leiomyoma, and those who have family history are 2.5 times more predisposed to have this disease. They are basically hormone-dependent neoplasms of unknown etiology, and they are composed of smooth muscle cells and varying amount of fibrous connective tissue. They arise from myometrial transformation as a result of specific physiological and pathological conditions. Both the endometrium and myometrium are under the influence of hormones like estrogen and progesterone. These hormones can increase the mitotic rate, which can cause which predisposes them to have somatic mutations, and they can go to leiomyoma. Even leiomyomas have cytogenetic predispositions. Mechanical effects results in endometrial changes. Mechanical changes will occur due to the leiomyoma mass and their location. Those mechanical effects, they can affect the extracellular matrix, which can create stress effects in them, and they can result in endometrial changes, which includes proliferation or hyperplasia of the endometrium and other associated pathological findings. So basically, the aims of my study were to study the incidence and distribution of leiomyomas in the uterus, to study the histomorphological patterns of leiomyoma, to study the endometrial patterns associated with the leiomyoma. Now coming to materials and methods, our study was conducted over a period of 2 years from January 2019 to 2021 in histopathology section of Rajarajeshwari Medical College. 102 hysterectomy specimens having leiomyomas had been considered for the study. These formalin fixed specimens were examined for the number and location of leiomyoma, the endometrial thickness, and then they have been processed and the standard grossing protocols had been followed. The tissue bits were taken from the representative areas, processed routinely, and stained with H&E stain. The sections were then examined for endometrium, for their morphology and architecture of the glands, and for myometrium, that is for leiomyomas, secondary changes if present in the leiomyomas, and for adenomyosis. So now coming to the results, we found that based on location, intramural leiomyoma accounted for about 68% of the total number of cases, 66.6%. Then followed is the subserosal and intramural. Okay. Second is the subserosal and intramural. Total cases were 17 out of 102, which accounted for 16.6%, followed by subserosal. Subserosal were 13, which accounted for 12.7% of total cases. Then was submucosal plus intramural and subserosal, which accounted for total number of cases, which accounted for 2.94%. Then was submucosal, which accounted for 0.98%. We did not find any cases of submucosal as well as intramural. Endometrial and myometrial changes. In the endometrial changes, we found that proliferative phase was the most common change in the endometrium, which accounted for 36 of total number of cases, which accounted for 35.2%, followed by secretory phase, which accounted for 13.7%. Then is the endometrial polyp, which accounted for 10.7%. Then is the atrophic endometrium, which accounted for 7.84%. Then disordered proliferation, which accounted for 4.9%. Then endometrial hyperplasia, which accounted for 2.94%. Endometrial carcinoma accounted for 1.96%. And then is the benign endometrial stromal nodule, which accounted for 0.9%. Here I would like to tell that there are very less number of studies correlating endometrial carcinoma with the leiomyoma. But yes, leiomyoma can be a very important predisposing factor which can cause changes in the endometrium, leading to endometrial carcinoma. So it should be considered for the study, for further studies. In myometrial changes, we have adenomyosis, which accounted for 22% of the changes, accounting for 21.5% of total number of cases. Then we made a study regarding endometrial changes specifically present in intramural leiomyoma. Out of that, we found that proliferative phase was again the highest, which was present in 38 number of cases, accounting for 55.8% of total number of cases. Then followed by secretory phase, then disordered proliferation, which accounted for 8.8%, atrophic endometrium, which accounted for 7.3%, endometrial polyp, which accounted for 5.8%, Endometrial hyperplasia, which accounted for 4.4%, endometrial carcinoma, which accounted for 1.47%, endometrial stromal nodule, which accounted for 1.74%. Endometrial carcinoma and endometrial stromal nodule both shared the same statistics, so they can equally be present in case of intramural leiomyoma. Endometrial changes in the subserosal leiomyoma. Most common was again the proliferative phase, which accounted for 61.5% of total number of cases, followed by endometrial polyp, which accounted for 15.3%. Endometrial carcinoma was more commonly associated with the subserosal leiomyoma. And secretory phase also accounted for 7.6%. Endometrial hyperplasia also accounted for 7.6% of total number of cases. Now coming to leiomyoma showing secondary degenerative changes. The cases showing secondary degeneration accounted for 14.7% of the leiomyoma, and the cases showing hyalinization was 2.94%, with the hyaline change being the most common secondary degenerative change in leiomyoma. Now coming to discussion, the advances in the pathogenetic knowledge of fibroid led to the study of endomyometrial junction. Endomyometrial junction is the interface between cyclic endometrium and myometrium, where important vascular and physiochemical phenomena seem to take place. The endometrial, subendometrial, myometrium unit disruption disease is a very new entity, and it is very much different from adenomyosis, that is merely the presence of glands in the myometrium. But endometrium myometrium junction unit disruption disease is a new entity, and it has to be studied for pathogenesis of leiomyoma. It is expressed mainly by pathological thickening or abnormality of the subendometrial myometrium, which is the possible site of origin of submucosal and intramural fibroid. The mechanism underlying the zonal myometrial differentiation is very much unknown. Evidences suggest that the ovarian hormone actions are mediated by cytokines and neurotoxins locally released by basal endometrial layer and endometrial myometrial T lymphocytes. Fibroids can alter the uterine cavity contour through the mechanical distortion and are responsible for an abnormal uterine contractility. Local inflammation associated with the presence of fibroids can give rise to a hostile endometrial environment that impairs the sperm transport and embryo implantation. Excessive concentration of inflammatory cytokines can have a negative effect on embryonic development and implantation. They also affect the Hox-10 gene, which is important for implantation process. Uterine cavities with the fibroids showed increased levels of matrix metalloproteinases, interleukin-1, and tumor necrotic factor alpha. 2G matrix metalloproteinase 1 genotype is a potential marker of myometrial and endometrial hyperplasia, and they accelerate the leiomyomata growth. Many other genes are also involved in endometrium and in leiomyoma, including the estrogen, which affect the estrogen progesterone receptors, including the HMGA2 gene, the MET12 gene, aka P50, P30, and others. These degenerative changes in leiomyomas are considered due to the inadequate blood supply. They occur due to inadequate blood supply. This type of degenerative changes depends on the degree and rapidity of onset of vascular insufficiency. Because these leiomyomas, as they grow in size, they compress upon the uterine vessels, causing the inadequate vascular supply, leading to degenerative changes inside them. Hyaline degeneration is the most common type of degeneration, which has been correlated with our study, followed by myxomatous changes, cystic changes, red degeneration, calcification changes, fatty degeneration, and even sarcomatous changes. In our study, we found that intramural leiomyoma, 66.6% is the most common presentation with respect to location, and proliferative phase is the most common associated endometrial change of leiomyoma. These findings are consistent with the studies conducted by Vani et al. And Rajeshri Ingid et al. Predominant myometrial changes associated with leiomyoma is adenomyosis. That means that mostly when you have adenomyosis, you are predisposed to having leiomyoma. Similar results were obtained by Najma Khan et al. Hyalinization is the most common secondary degenerative change. Hyalinization is the most common secondary degeneration associated with leiomyoma, which is consistent with the study conducted by Vani et al. Now, coming to the I shall answer the questions later. Okay, now coming to the normal endometrial junction. These are the presence of endometrial glands. And this is the myometrium. Okay, I'm having network issues.
Yeah, that was a bit of disconnection.
Okay,
now,
but
I think that's fine. That's fine. Yeah.
Okay, is it coming?
Yes, a bit slow, but yes.
Okay, ma'am. So now coming to the proliferative endometrium, they are round to oval and the stroma is compact. This is a proliferative phase endometrium. In proliferative phase endometrium, we can also see certain mitotic figures and all, but here I did not find, it is not present in this slide, but we can find. Then coming to secretory phase endometrium, H&E stain, this is under 10x where we can see the tortuous gland. They are very much dilated and tortuous. Here under 40x, we can see the supra and subnuclear vacuolations. And sub might also contain secretions. Here coming to secretory hypertrophy, here we can see the back-to-back glandular arrangement of endometrial glands. That pattern is very much appreciable. And here we can see the secretory phase of the endometrial glands where they're having supranuclear vacuolations and they are very much dilated and tortuous. Now coming to the different, these were the normal endometrial changes. Now coming to pathological endometrial changes, we can see here is the disordered proliferative phase, which shows the lytic endometrial glands. Is a disordered proliferative phase. We can see the lytic endometrial glands. Here it is very much more appreciable, these lytic glands. Then coming to simple endometrial hyperplasia without ectopia, where back-to-back glandular arrangement is present. I have taken these pictures under 4x and 10x. Then coming to adenomyosis, endometrial glands in the myometrium. This is under the scanner view, and this I have taken under 10x. Then coming to endometrial polyp, usually a polyp should have an epithelial lining on 3 sides, and usually the glands which will be present in the polyp will be different from those present in the normal stroma. So here there were different glands of the polyps which were different from that present in the endometrial stroma. Here is a picture of senile cystic atrophic endometrium under H&E stain. We can see the cystically dilated glands, and also some of them are lined by the cuboidal epithelium, which happens in senile cystic atrophic endometrium. The glands are the cystic changes are present. And the stroma is also becoming loose. Here is a picture of endometrioid carcinoma with squamous differentiation. We can appreciate the squamous component. Then coming to leiomyoma, H&E under 40x is a spindle-shaped structures which we can see of muscle fibers arranged in fold pattern. Hyaline degeneration in the leiomyoma, H&E stain, and hydropic degeneration in the leiomyoma. Cystic degeneration, we can find a cyst in the leiomyoma, H&E stain under 40x. So now coming to the conclusion, the endomyometrial disruption, endomyometrial junction disruption plays a crucial role on fibroid-related infertility, uterine bleeding, growth of submucosal and intramural leiomyoma. The clinical aspects are related prevalently to the number, volume, and intrauterine localization of nodes. As compared to the number and volume, they can vary from any numbers, and based on the location, their clinical manifestations vary. Since many patients remain asymptomatic, consequent histopathological examination should be made mandatory and is of paramount importance for confirmed diagnosis, optimal management, and surveillance of the concerned patients. Thank you. These are my references. I'm open for questions.
Thanks, Dr. Mahapatra. If there are any questions, just ask us or write in the chat box.
Okay. There are many questions in chat box. J. Premlata ma'am is asking, treatment modalities for early and late stages. Ma'am, treatment modalities, it can happen with medications also. They give GnRH agonist, and there is a new drug discovered by the name of elagolix, and they give a tranexamic acid for the medical management. For late stages, you can go for uterine artery embolization and myomectomy. Most commonly, myomectomy is a procedure done in our country for the treatment. Yes, ma'am. Infiltration of lymphocyte can be an indication of severity of leiomyomas, because leiomyomas can have secondary infections in them, which can manifest in the form of fever and other conditions. Ma'am, any more questions, ma'am?
Just a note here, if possible, please, if there is any question, post it to all, not just the speaker, so everyone can see the question and can understand the answer, because I think that I was just sent it to you, Dr. Mahapatra. So that was...
It's fine, I can repeat the question. Okay, ma'am. My first question was, is infiltration of lymphocyte indicative of severity of leiomyomas? Yes, it is an indication, because leiomyomas, secondary infection can occur, which indicates that the leiomyoma is becoming more severe. It is an indication of severity of leiomyomas. It can manifest as fever and other reactions. What are the treatment modalities for early and late stages of leiomyoma? As I told, in early stages, you can control with the medication like the GnRH agonist. And then for late stages in our country, they go for either myomectomy or uterine artery embolization, ma'am. And how will differentiate histology of early and late stages? Okay, early and late stages of endometrium, of secretory phase, proliferative phase, or I don't understand the question. Please, once more, can you send J. Premlata, ma'am? Okay.
Hello, it is this, it is a misprint I asked. I want to know histologically, how can you differentiate between early and late stages? That you can say that this is an early stage and you can stop it, when an early, like a polyp kind of a stage is occurring, then how will you differentiate, how will you differentiate that early stage and the late stage? Histologically, do you need to do histochemistry? Are there some biomarkers or something like that, or something?
Histologically, ma'am, we can see in endometrial polyp, ma'am, there hyperplasia, there will be more of estrogen hormones, that as a result of which the receptors will react to it, and the disease will progress. So, ma'am, if there is more estrogen hormone, the hyperplasia of glands will occur, ma'am. So in early stages and the late stages, early stages, we can see the hyperplasia of glands, and then give the treatment accordingly, or we either stop the OC pills or any other factor which is enhancing this estrogen proliferation, ma'am. We have to see the family history of the patient, ma'am. We have to see the medication that has been administered to patients. Even some of the drugs which used in breast cancer, like tamoxifen, can proliferate endometrial changes. So we have to see the drug history of the patient also in that case.
Okay. Okay, thanks so much. Actually, I wanted to ask whether this ovarian ablation you all are doing, like to remove the ovary as such.
No, ma'am, it is not practiced in our hospital actually, ma'am. We here mostly do myomectomy or hysterectomy, or laparoscopic myomectomy or hysterectomy as the end procedure, or we give medications, ma'am. As far as cases I have seen in my hospital, ma'am, in my own hospital.
Okay. Thank you so much. You answered really nicely.
Thank you, ma'am. Thank you very much, ma'am.
So thank you so much for your explanations. If there are no more questions, then we will go to our next speaker, Dr. Sria Sato from India. So I will pass the stage to deliver the speech.
Thank you.
A very good morning to everyone. I hope I'm audible.
Yeah, you are.
How do I share my screen? Okay, is my screen visible?
Yeah, that is.
Okay, fine. So very good morning to everyone. I am Dr. Sria Sato from PGIMS Rohtak, Haryana. And I am today presenting a talk on primary breast neuroendocrine carcinoma. Along with this, I will also be discussing a case report which was recently received in my department and was diagnosed as primary breast neuroendocrine carcinoma on cytology. Right? So first of all, here are some introductory points regarding neuroendocrine carcinoma. The incidence of foci of neuroendocrine differentiation in breast carcinoma is reported to be around 2 to 5%. And such a differentiation was first described in mucinous carcinomas. And thereafter, in 2003, the breast neuroendocrine carcinoma, or BNEC, was, as they call it, was defined as a separate entity by the World Health Organization. That time also, World Health Organization divided BNEC into 3 subtypes. These were solid neuroendocrine carcinoma, small or old cell carcinoma, and large cell neuroendocrine carcinoma. Overall, when we see, this was although the incidence of neuroendocrine differentiation in a carcinoma of breast is 2 to 5%, a primary per se neuroendocrine carcinoma is even more rare, and it has been reported to have an incidence varying from less than 0.1 to 5% of all breast carcinomas, and less than 1% of all neuroendocrine tumors. Now, in a recent expert consensus statement, which was given in 2018 by the International Agency for Research on Cancer, that is IARC, and WHO, it was agreed to adopt the term NEN, or neuroendocrine neoplasms, encompassing all the tumor classes with predominant neuroendocrine differentiation. And now this term was called in to include both well-differentiated as well as poorly differentiated forms. So in a way, when we refer to neuroendocrine neoplasms, we are actually categorizing them into two parts. First is neuroendocrine tumor, which is the well-differentiated part. And then we have neuroendocrine carcinomas, which are the poorly differentiated ones. Now, what are the key features to diagnose neuroendocrine carcinoma? So there are two main bases on which we give our diagnosis. First and foremost, it is the morphology, and secondarily, it is the expression of markers of neuroendocrine differentiation. Now, as far as the morphology is concerned, there are certain differences within differences between what kind of morphology we consider as neuroendocrine neoplasm in gastrointestinal tract and lung, and what is a difference. And there is some difference in the morphology when we are considering breast, which I'll be discussing in the coming slides. And expression of markers of neuroendocrine differentiation, which is done by immunohistochemistry. Thereafter, there is also ultrastructural examination, which in our country is not available in almost in all the places, but these are not included within the key features. So they can be they act as an addendum to our report. Invasive carcinoma NST with neuroendocrine differentiation. Now, this is the diagnosis which is given if neuroendocrine histological features and the neuroendocrine marker expressions are not distinct or uniform enough to classify the tumor as NEN. The classic organoid features. Now, this is here comes the difference between the different organs when we are discussing neuroendocrine neoplasms. The classic organoid features of carcinoid tumors of lung and GI tract. So we consider regular nests, ribbons, cords, and rosettes. Now, these are not features of primary NENs of the breast. In case of breast, we can rather see solid nests and trabeculae. Also, papillary and insular patterns and sometimes alveolar-like structures can also be seen. In 2012, when the 4th edition of WHO classification of tumors of the breast was given, the NECs were included in the category as carcinomas with neuroendocrine features. So NENs of the breast overall now are classified into two main categories as we discussed, NETs and NECs. NETs well differentiated, which include low and intermediate grade tumors, and NECs poorly differentiated, which include small cell carcinomas. Metastatic well differentiated neuroendocrine tumors can be present, or there can also be moderately differentiated neuroendocarcinomas, particularly those of lung or gastrointestinal pancreatic origin. These should be excluded before we are making a definitive diagnosis of primary neuroendocrine carcinoma of the breast. So what are the supportive findings that suggest a primary? So these are presence of a focus of ductal carcinoma in situ. Usually, these malignancies are ER positive. However, as I went through the literature, I found out ER expression is seen in 30 to 50% of the cases only. So, and the PR expression is seen in even lesser number of cases. So it can be, there can be a possibility that your case is both ER as well as PR negative. And however, you can still suspect neuroendocrine carcinoma. Also, neuroendocrine carcinoma cases have a higher propensity for axillary node metastasis. And thereafter, to give a finding that it is a primary, give a diagnosis that it is a primary, also there should be absence of a history of an extramammary primary neuroendocrine neoplasm, for which workup of the patient needs to be done. Coming over to neuroendocrine carcinoma, it is now by definition, as per the WHO, it is an invasive carcinoma which is characterized by high-grade neuroendocrine morphology, which could be either small cell or large cell, and it is supported by the presence of neurosecretory granules and a diffuse uniform immunoreactivity for neuroendocrine markers. WHO has given certain essential and desirable diagnostic criteria to make a diagnosis of neuroendocrine carcinoma. Herein, the essential criteria is histological features similar to those of small cell neuroendocrine carcinoma and large cell neuroendocrine carcinoma of the lung, and these are usually these are high-grade tumors. A desirable, now coexisting ductal carcinoma in situ as per WHO has been put under a desirable diagnostic criteria and not an essential one. Now with this introduction, I'll be going forth with my case report. I was the first and presenting author for this, And this was done under Dr. Sant Prakash Kataria, and Dr. Akshay Kaul was a co-author. And this study was done at PGIMS, Rohtak, Haryana. Our patient was a 72-year-old female, and she presented to the surgeon with the complaints of lump and pain in the right breast since 3 months. On examination, a hard lump was felt in the retroareolar region of the breast, measuring approximately 5 into 4 centimeters, and local temperature overlying of the skin overlying the lump was raised. An examination of the axilla, however, in our case, did not show any lymphadenopathy. The patient underwent fine needle aspiration for her breast, which yielded blood mixed mucoid material as aspirate. Now, on microscopic examination of our case, the smears were hypercellular. The malignant cells were seen, which appeared plasmacytoid at most places, along with few round to polyhedral cells. And these were seen both singly as well as in clusters with delicate cyanophilic cytoplasm and a relatively clean background. These cells revealed high nucleocytoplasmic ratio and round to ovoid nuclei and with coarse granular chromatin. Now, this is the photomicrograph of my case. If you can clearly see, these are the cells that appeared plasmacytoid within a background of RBCs, and the cytoplasm showed granularity. Okay. Again, this is a photograph from another field wherein hypercellularity is seen and plasmacytoid appearance of the cells is seen. Again, granularity in few of the cells is seen. There are we made a presumptive diagnosis of neuroendocrine carcinoma, and thereafter we prepared cell block of the aspirate, and we performed immunohistochemistry on the same. The tumor cells were found to be, in our case, were found to be positive for cytokeratin, synaptophysin, and neuron-specific enolase, and it was negative for chromogranin and CD56. Sorry. Now, based on the cytomorphology and immunohistochemical markers, a diagnosis of primary breast neuroendocrine carcinoma was made. As per the WHO description of the tumor, they say that either it should be positive for the neuroendocrine markers. Out of those, either synaptophysin or chromogranin should be positive to call it a neuroendocrine carcinoma. This is a photo from the photomicrograph from the cell block that we prepared. It showed diffuse proliferation of the cells. Few of the cells showed salt and pepper chromatin, and these cells had stand to moderate amount of cytoplasm. This is a photomicrograph of the cytokeratin stain that we did, which was largely positive in the cells. Also, synaptophysin was positive, which confirmed our diagnosis. Chromogranin and CD56 in our case were negative, and a neuron-specific enolase, or non-specific enolase as they call it these days, was also positive. Now, coming to the discussion of our case, neuroendocrine tumors are known to derive from neuroendocrine cells which are present throughout the body. These tumors are rare and are slow growing. Now, one catch here is that although these tumors are slow growing, they are seen to have had a worse prognosis. So overall prevalence has been estimated to be around 1 to 2 cases per 1 lakh persons. In a study which was conducted by Yupa Lekhin et al., they searched the English literature and found 59 cases of neuroendocrine tumors in the breast, out of which 38 were primary breast neuroendocrine tumors. The mean age of these patients was found to be 66 years, and none had reported symptoms of carcinoid syndrome. The existence of neuroendocrine cells in mammary tissue was indicated by Volger in 1947. Neuroendocrine differentiation in carcinoma breast is morphologically similar to its counterparts in the gastrointestinal tract, lung, and other non-endocrine organs with endocrine differentiation. These tumors were earlier known as the argyrophilic breast carcinomas, endocrine carcinomas, or breast carcinoid. These terminologies are presently not accepted by WHO. Presently, they are classified as breast carcinoma with neuroendocrine differentiation or primary neuroendocrine breast carcinomas. However, clinically, these are indistinguishable from other types of breast tumors as per their presentation. As we already discussed, neuroendocrine differentiation in breast carcinoma has been reported in around 2 to 5% of the cases. And this is most commonly seen in 6th to 7th decade of life in female patients. It can be found in many breast histiotypes, such as ductal, NOS, lobular, mucinous, tubular, and papillary breast cancers. And such a differentiation can also be seen in male breast carcinomas. The neuroendocrine tumors may represent either primary or metastatic lesions, and the differentiation may be difficult even after the microscopic examination, because morphologically they will be the same. A component of ductal carcinoma in situ is the only absolute proof of the primary nature of breast carcinomas. As per the present consensus, so if we have another focus of carcinoma in situ, and also we are seeing neuroendocrine morphology resembling neuroendocrine carcinoma, we give a diagnosis of neuroendocrine carcinoma of the breast. And also, as per the present consensus, the expression of neuroendocrine markers should be positive in more than 50% of the cell population for the diagnosis of breast neuroendocrine carcinomas. In our case, these markers were expressed in approximately 90% of the cells, and therefore we did not diagnose it as a neuroendocrine differentiation, but rather as a neuroendocrine carcinoma of the breast. Also, the expression should be positive for at least 2 of the following markers: chromogranin, synaptophysin, CD56, and NSE. On ultrastructural examination, there can be seen there's demonstration of dense core granules or electron dense granules, and these are characteristic for neuroendocrine carcinoma. Our case was diagnosed as primary neuroendocrine carcinoma of the breast, and also we further consulted the clinician and did a workup of the patient to rule out any other focus of primary neuroendocrine carcinoma, and there was no such focus found in the patient. So we made a diagnosis of primary neuroendocrine carcinoma of the breast. And yeah, so these were my references. Thank you. Open for questions.
Thanks so much for your nice presentation. And I can see a question in the chat box that asks, where or in which 5 main subtypes of breast cancer does NET carcinoma, does it fall under?
Which 5 main subtypes of breast cancer?
Yeah, actually, my question is that there are 5 subtypes, right? Like luminal A, luminal B, based on the estrogen and the tyrosine kinase HER2 receptors. So these subtypes have become very commonly used for targeted therapy and all. So like you have luminal A, luminal B, triple negative, and then you're having basal type, and then you're also having the triple negative, so you having ER positive, HER2 negative, then ER positive, HER2 positive, triple negative basal carcinoma. So in that subtypes of breast cancer, where does it fall? Like,
Ma'am, as far as the most common presentation is concerned, these are ER positive, PR positive, and HER2 negative. So in that case, they come under luminal A. But however, they don't have a very consistent because it says that only 30 to 50% of the cases will have ER positivity.
Yeah.
So with that, for every case, I think it has to be assessed likewise. However, as per the most common presentation, most common expression of markers, it comes under luminal A.
Okay. So you're saying that usually, like if it is luminal A, they give this palcosibib. No, now lately that CDK 4 and 6 inhibitors have come. So do you think that differentiating as neuroendocrine tumor helps in the treatment modality? Like, will you give some other treatment if you classify it as a neuroendocrine tumor, or like you're a surgeon or you're a PhD?
Ma'am, I'm a pathologist.
Okay, pathologist. Okay. So yeah, I'm not a pathologist. I'm a molecular biologist. So actually, what I'm trying to ask is that are the treatment, the classification important for treatment? Like if you classify, you will give some other treatment, and if it is not diagnosed as neuroendocrine, then the patient is given some other treatment. That's all.
Ma'am, actually, the basis for mentioning that the percentage of the component of the neuroendocrine part in any breast cancer which is having a neuroendocrine differentiation or neuroendocrine carcinoma per se, is that these have particularly worse prognosis. So just to give an idea regarding the prognosis, we mentioned the percentages. However, I am not quite sure, but I will have to read about it. I remember reading somewhere that platinum-based therapy, particularly the neuroendocrine part, responds very well to the platinum-based therapies.
Okay.
So if you mention the percentage, so we can actually give a good response. Patient might give a very good response to the platinum-based.
Yeah, because there are different modalities of treatment like doxorubicin and anthracycline and Taxol, and of course tamoxifen is also given, right? If it is ER positive. Okay. So that's that is interesting that it is you would tend to give more of cisplatin, right? Platinum based therapy. Okay. Thank you. That was very nice presentation.
Thank you. Thank you.
So if there is no more question, again, thank you so much, Dr. Sato, for your nice presentation. And we will go to our next presenter. I will welcome our first keynote presenter and speaker, Dr. Ali Mukhtar from Iran. So I will pass the stage to deliver the keynote speech.
Thank you so much, Dr. Ghazaleh. I'll try to share my screen. Can you see my screen now?
Yes.
Okay. All right. Hello and very good morning or good evening or good night, everybody. I'm Dr. Ali Mukhtar, anatomical pathologist, fellow of the Royal College of Pathologists of Australasia. And for today, my presentation is about spindle cell lesions of the breast. So I'll try to cover a range of benign, inflammatory, benign, and also high-grade lesions in this topic, and we'll also address the diagnostic challenges. So with that, we go through also immunohistochemical markers and molecular studies briefly, and we'll try to sort the main, differential, so-called differential diagnosis difficulties to make our actually final diagnosis, and perhaps this topic actually I'm quite hopeful that this topic will help you to actually sort the difficult cases out. For the histology and also for the functional unit of the breast, so as you know that we have terminal ductlobular unit, which is the functional unit of the breast with acini and small ducts and further larger ducts, which drain the secretions out toward the nipple. So the main bulk of the breast is actually composed of fat, as you know, and is supported by muscles and also rib cage, as you know, and it's surrounded by extensive network of lymph nodes from the axillary toward the supraclavicular nodes and also intramammary lymph nodes. So this is a histology, normal histology of the breast. So you can see the a lobule here with groups of so-called acini and smaller ducts, and finally they will drain their secretions into larger ducts, and which will actually leave the lobule towards the nipple. Okay, so when we talk about the spindle cell lesions of the breast later on, so we have some lesions arising from all these structures in the breast. That's why actually I consider this picture as important, because you have better idea what we are talking about and where the lesion comes from. Okay, so in general, when we talk about the spindle cell lesions of the breast, so they are not that common, as you know. So in general, they're considered as uncommon lesions, but I think most of pathologists have this experience that they have seen actually lots of this kind of so-called pseudo neoplastic or neoplastic breast lesions with the spindle cell morphology. So it doesn't mean that okay, this is uncommon, but we are not actually dealing with these cases routinely. So they are actually variety of cases in this group. Okay, as I said, from reactive to low grade and high grade ones. So some of them are site-specific lesions, means they are arising from the breast tissue, breast parenchyma itself, and some other arising from soft tissue or cutaneous spindle cell, actually cutaneous structures, which form spindle cell morphology. Okay, so actually that's why we are going to categorize them into a simple and practical actually way, because we are dealing with lots of morphologies and presentations. So it's better to consider a practical and easy to use the day-to-day approach. That's why actually I'm going to introduce a good practical method for categorization of these sort of lesions. Okay, so at the end of the day, so don't ignore clinical, radiology, and ancillary studies apart from morphology, because they play a major role in diagnosis of difficult spindle cell lesions of the breast. So as I said, the spindle cell lesions of the breast might be originating from the parenchyma itself. So we're talking about ducts and also stroma, so epithelial and myepithelial cells, as well as the stromal cells. Or sometimes they're coming from non-breast specific skin and soft tissue. Okay, so they are all sources of spindle cell lesions, or they might be sources of actually spindle cell lesions of the breast. So morphologically, again, they might be bland looking, totally bland or reactive, sometimes low grade, and in rare cases they are high grade. Okay. The approach that we are going to discuss today is going to categorize them in general into biphasic and monophasic spindle cell lesions. Okay, so first of all, we categorize them into these two broad categories, and then we further sub-classify them into like, for example, low grade or high grade, or sometimes reactive. Okay, so we then consider histologic grading according to the morphology. So this is a nice table. Okay, this is a summary of what I'm going to talk about. I will go into details for some of these important subclasses. So for you, it's, in general, you have to have in your mind that we are going to classify them into biphasic and monophasic in general. And then for each category, we have low grade and high grade ones. And for monophasic type, we have also inflammatory or reactive lesions. Okay, so we have different kinds of important so-called lesions or conditions in each category that I will talk about later. Okay, so I will start with biphasic spindle cell lesions. For the biphasic ones, we have very common lesions in our routine practice, like fibroadenoma. As you know, we have fibroepithelial lesion like fibroadenoma phyllodes tumor. We have PASH in this group, pseudoangiomatous stromal hyperplasia, hamartoma even though they are not that common, but we consider them as biphasic spindle cell lesions with benign morphology and behavior. Adenoma epithelioma as well, and some actually spindle cell metaplastic carcinomas also they present as biphasic spindle cell lesions in routine practice. In general, when we talk about biphasic spindle cell lesions, they are more commonly originating from breast tissue itself rather than skin tissue or soft tissue from outside breast. Okay, in order to diagnose actually biphasic spindle cell lesions, we have to have adequate sampling or adequate excision, because sometimes we miss one component and wrongly we diagnose them as monophasic, as one of the monophasic spindle cell lesions. So we have to consider this. We have to make sure that we have enough adequate sample for our final diagnosis. So as I said, in limited biopsies, for example, or limited material, sometimes we miss one component, and this could be erroneously actually lead us to wrong diagnosis or monophasic lesion. In some of these circumstances, we may use IHC markers. Okay, for example, using cytokeratin and P63 can be helpful to highlight the epithelial component. So immunohistochemical markers, as initially mentioned, are very helpful in challenging cases. So the biphasic spindle cell lesions, like later on we'll talk about monophasic ones, they are classified also, further classified, subclassified into bland or pleomorphic, also called benign to low-grade malignant or high-grade spindle cells. So we have different kinds of lesions under each category. First, we talk about further we talk about benign spindle cells with bland morphology. Okay, so first of all, fibroadenoma, which is common biphasic lesion with bland stromal cells. It may undergo some further atypical changes, like or atypical changes, or further, proliferative changes like UDH, DCIS, LCIS, ADH, PASH, squamous, and even the stromal smooth muscle metaplasia. So there are some examples of secondary changes which may happen in fibroadenoma. Interestingly, use of cyclosporin A and also estrogen, as you know, will actually also proliferate the stromal component in fibroadenoma. I mean, it's a risk factor for actually development of fibroadenoma in real practice. Okay, so this picture you can see the case of fibroadenoma with some further atypical or malignant changes. At the top, A and B shows fibroadenoma with DCIS. So you can see these cribriform changes in the epithelial component. So there is DCIS changes in the fibroadenoma at the top, and at the bottom you can see LCIS changes in the fibroadenoma. So you can see these pre-malignant lesions in the case of fibroadenoma. But as long as these lesions they are limited to the borders of fibroadenoma, there is no increased risk of so-called invasion or metastasis if the lesion is completely excised. So this means that the prognosis will not change with only presence of this atypical or low-grade or so-called pre-malignant lesions if we are able to excise the whole lesion. We have a terminology for fibroadenoma. Sometimes we call them complex. So just mention about this, that it may contain cysts larger than 3 millimeter, or if they have foci of sclerosing adenosis or some epithelial calcifications. Or sometimes you may see a papillary epicrine metaplasia. In these cases, we call them complex FA. Complex fibroadenoma actually is sometimes associated with an increased risk of breast cancer. So with some belief that they are actually precursors for malignancy in the case of complex lesion. The stromal component, the stromal spindle cells in the fibroadenoma, they are normally positive for CD34 and BCL2. Actually, we don't need in routine practice to use these markers, but in difficult cases, sometimes we have cellular fibroadenoma in order to appreciate from phyllodes tumor or perhaps some low-grade malignant lesions. We may consider these immunohistochemical markers. And interestingly, somatic mutations for MID12 and RARA mutations also could be helpful in challenging cases. So the next one is phyllodes tumor, the benign one, of course. So these tumors mainly present with a palpable, painless masses with benign clinical course. In general, when we talk about phyllodes tumor, so we have some criteria to consider them as benign, borderline, or malignant. So our criteria will address stromal cellularity, atypia, presence or absence of atypia, mitotic rate, tumor borders, whether it is infiltrative or not, stromal overgrowth. The definition of stromal overgrowth is the presence of stroma without epithelium occupying at least one low power field, and also presence of heterologous components, means chondroid tissue or osseous tissue, or other heterologous components, or sometimes rhabdomyoblastic differentiation even. So the benign ones, the benign phyllodes tumor, normally show uniform and scant stromal cellularity. Mite or absence of stromal atypia is there, and mitotic count is normally less than 4 in one high power field. The borders are quite delineated and well defined, so there's no infiltrative margin, and of course there's no also stromal overgrowth. So you can see here, this is an example of benign phyllodes tumor with these leaf-like structures at the left side. You can see this pattern, which is quite characteristic of phyllodes tumor. And so we have two components, epithelial and stromal components. And at higher magnification, you can see there's a bland-looking nuclei, spindle cells in the stroma. And in this case, there is one giant cell, okay, which is quite bland, which may be seen, which may happen in a case of a benign phyllodes tumor. If there is high cellularity, sometimes we use these features in order to diagnose or differentiate them from cellular fibroadenoma. So we use stromal cell pleomorphism, fragmentation, intracanalicular growth pattern, and also presence of multinucleated stromal giant cells, just to differentiate them from fibroadenoma. Okay, so again, immunohistochemical markers could be useful for difficult cases. So we use CD34 positivity, BCL2, and interestingly, beta-catenin also could be positive in a spindle cell component of phyllodes tumor. So in terms of mutational analysis, so again, we are dealing with MID12 mutation, like a case of fibroadenoma, but apart from that, FLNA, SET-D2, KMT2, T2D, BCOR, and MAP3K1 also all positive in phyllodes tumor, which are not actually seen in a case of fibroadenoma. So in difficult cases also we have some mutational analysis factors to differentiate them. So this is again another nice table just for you for your reference. This is a comparison of biphasic lesions with bland spindle cells. So we are going into details of each category later on, but for you, just you can find fibroadenoma, phyllodes tumor, PASH, hamartoma, and adenoma epithelium, and there is comparison in terms of clinical features, radiological features, histological features, and interesting IC profile for difficult cases. Okay, so and finally molecular features for each category is the important ones have been actually shown here. And also for high grade lesions, phyllodes tumor, the borderline or malignant one, and also spindle cell metaplastic carcinoma. So you can see differentiating features. You can use these criteria and this so-called information in your routine practice. So we will cover some of the important ones in our presentation. So the next one in this category is PASH, or pseudoangiomatous stromal hyperplasia. So again, PASH is a benign lesion. So it's composed of proliferating stromal myofibroblasts, and normally presents as a palpable mass, which is called nodular PASH, or sometimes it's just detected on radiographic imaging. And so it is how it's diagnosed. Actually, this is how it's diagnosed on imaging without any mass, palpable mass. So again, it's mainly seen in premenopausal women or those ladies under actually hormone therapy. So it's mainly seen in young individuals. Actually, despite its benign nature, the radiology sometimes is very deceptive because it may present in the radiology as irregular or speculated mass. But under histology, you see just a benign morphology. So PASH consists of complex interanastomosing channels. Okay, so you are dealing with like vascular or blood vessel-like structures, like sinusoids. So they just resemble vascular spaces, but they are not true blood vessels, and they are lined by bland spindle cells in the background of just fibrotic stroma or paucicellular stroma. So that's the typical picture of PASH, or pseudoangiomatous stromal hyperplasia. This is the left side. You can see low power, just a nodule with a bit of infiltrative margins. Okay, so it may be a bit worrisome at this magnification, and you have these entrapped ducts in between, and the stroma is quite fibrotic. Higher magnification, you can see this collagen material or fibrosis in between, and you may appreciate these blood vessel-like structures or pseudovascular spaces here. They are not true blood vessels, of course, and they are actually surrounding these ducts. Ducts are entrapped in between this so-called fibroblast or myofibroblastic proliferation. So PASH can happen alone, but in most of the associated with hamartoma or phyllodes tumor. May I ask you, to hear me well or not? Hello? Am I audible?
Yes, we can hear you.
Okay, sorry, because there was a message that my internet connection is unstable.
No, that's fine.
Okay, as I said, so PASH can occur alone or in association with hamartoma, fibroadenoma, or phyllodes tumor. Okay, so most of the cases, it is a secondary lesion in a single presenting breast, actually, condition of breast disease. So again, in terms of immunohistochemistry and IHC profile in challenging cases, the spindle cells are positive for CD34, BCL2, SMA or smooth muscle actin, ER, and PR. So you may use these markers in challenging cases as well. So they are estrogen, progesterone actually responsive. So they have these receptors, and that's why they are mainly seen in premenopausal ladies. The next one in this group is hamartoma, breast hamartoma. So hamartomas are very common, and actually they can be everywhere. So in breast also we have hamartomatous lesions. So based on definition, they are actually disorganized tissue indigenous to a particular site. Okay, so they are not true neoplasm. They are pseudo-neoplastic lesions, and they are composed of quite normal structures, but these structures are arranged haphazardly, so they are not nicely organized in that single organ. And this is the case also for breast parenchyma. And based on based on radiology, we have a characteristic morphology, so-called breast within a breast appearance on mammography. So this is interesting because you will see all the structures limited to the breast parenchyma. It means you can see fat, ducts, and acini all together, but arranged haphazardly and very well defined in a breast parenchyma. That's why we call it breast within a breast. So it's classically defined as a nodule containing variable amounts of adipose tissue, lobules, ducts, and fibrous tissue. Okay, so that's what we have in the case of hamartoma in general. So you can see interlobular fibrosis is prominent, and also fat is there, but is arranged haphazardly, but is normally encapsulated. And there is also presence of patch-like changes. Okay, so when you can see these features are very helpful for you, because as I said, patches can be accompanied by hamartoma in some cases. Okay, so hamartomas in general are considered pseudoneoplastic lesions, but sometimes in some specific settings like Cowden syndrome with P10 germline mutation, they may be associated with underlying premalignant or invasive carcinoma. So we have to be careful in some cases not to miss this sort of underlying lesions, especially in the case of Cowden syndrome. So in this picture, you can see this mainly fibrotic stroma and entrapped fat, okay, and also ducts. So everything is haphazardly arranged without any organization. Okay, so this is the structure, normal structure of hamartoma. Okay, so you can see this on the microscopy. Okay, the next one is adenoma epithelium in this group. So again, biphasic lesion, benign biphasic lesion composed of epithelial and myepithelial cells. So in terms of clinical presentation, it presents as a solitary palpable mass, and in the mammography you have dense, circumscribed, round, or lobulated lesion. Okay, so it's well defined. So there is no worrisome feature also on a mammography. So it's composed of, as I said, it's composed of bland ductal epithelial cells embedded within hyperplastic myepithelial cells. Yeah. So the myepithelium in overall actually may have different cytologic features. They could be basoid or plasmacytoid, or sometimes, in our case, that's why we consider the myepithelium under this category. Sometimes they have spindle cell morphology. Their cytoplasm is clear to eosinophilic, and in the case of adenoma epithelioma, they are the main part of the lesion. Okay, so we have less number of proliferative epithelial cells as compared to myepithelial cells. So in terms of immunohistochemical marker, they are positive for SMA, calponin S100, and also basal markers like P63, and also cytokratins like, for example, pancreatins like A1-3. They can also highlight the presence of epithelial cells. So this is a picture of adenoma epithelioma, photomicrograph adenoma epithelioma. So you can see mainly spindly cells. Okay, so you can appreciate this spindling, which is coming from the morphology of myepithelial cells, and in between you have these epithelial cells as well. And so in general, when you have to appreciate first the circumscribed lesion at low power, and when you go to higher power, you can see this two population of cells, epithelial and myepithelial cells, and as I said, you see more of myepithelial cells in this sort of lesion. Okay, so after benign lesions of biphasic type, so we have higher grade lesions. Okay, so with high grade morphology, of course, we have Phyllis tumor in this category, borderline to malignant ones. So definitely we have to apply that criteria, the one that I mentioned. So we have to use stromal cellularity, stromal atypia, and also mitotic count, which is in this case normally more than 10 per 10 high power field. And also stromal overgrowth is here with permeative borders. So you can apply the same criteria here also to confirm that this is borderline or malignant as opposed to benign. So the borderline ones show moderate stromal cellularity, and atypia is something between benign and malignant, and mitotic rate is 5 to 9 normally per 10 high power field, and they may only demonstrate focal stromal overgrowth and permeative border. Okay, so there's no extensive stromal overgrowth and infiltrative margins like what we can see in the case of malignant Phyllis tumor. So the stromal cells, sometimes actually they express P40 and P63 and cytokratins, interestingly, in the case of borderline and malignant lesions. So they might be actually mistaken for metaplastic carcinoma in this case. Okay, but in general, this is a helpful clue for you that the staining is usually focal. Okay, in the case of Phyllis tumor, and more likely seen in the areas of subepithelial and subepithelial stromal condensation. So it's not that diffuse or extensive like case of metaplastic carcinoma. And in general, malignant Phyllis tumor might be actually showing different sort of mutations like P53, RB1, NF1, PIK3CA, P10 mutation, BRAF mutation, EGFR, and TRT mutations can happen in the case of malignant Phyllis tumor. When we compare these lesions to benign ones, benign Phyllis tumor, the malignant tumor normally shows reduced CD34 positivity and higher expression of CD117, P53, and CD10. Okay, so it can be used also as a clue for difficult cases or for those with so-called equivocal features. So this is a picture of Phyllis tumor. So you can see again, so as you can see at the lower magnification, there is like a permeative border. So there is entrapment of fat, the periphery, and the ducts also are embedded within this, stroma. Higher magnification, you can see like this mitosis, but they are not that frequent anyway. Okay, like case of malignant one, but this stromal cellularity has increased as opposed to a benign one. Yeah, this is the morphology of borderline one, and next stage, which is malignant. So you can see higher cellularity as compared to borderline one, and more of mitosis and some abnormal ones or pleomorphism, stromal atypia, and also stromal overgrowth, as has been depicted on this picture. So you can see presence of only stroma at least one low power field. So this is the criteria that we use in order to diagnose malignant Phyllis tumor, in addition to other features that I've explained already. So the next one after this is biphasic or so-called carcinomatous metaplastic carcinoma. So this is the next member of this group of biphasic high-grade lesions. So as you know, they are traditionally classified into matrix-producing spindle cell carcinosarcoma, squamous cell, and metaplastic carcinoma with osteoclastic giant cells based on morphologic characteristics. Okay, so we have this. Traditionally, we use this. We used to use actually this so-called category to call or differentiate biphasic or carcinomatous metaplastic carcinoma. All right. The one metaplastic carcinoma with a spindle cell component. Okay, when there is a spindle cell component in it, it can be divided into monophasic or biphasic. Again, all right. So we use again this criteria, our categorization or you know, this classification again to differentiate different sorts of, you know, metaplastic carcinoma. So sometimes we have only sarcomatous component and sometimes biphasic. Okay, sarcomatous as well as carcinomatous, and it may be accompanied by heterologous elements as well. So you can see here biphasic metaplastic carcinoma at the left side. You can see spindle cell component here, and the right side you will see just glandular components. So you have two different morphology, spindle and glandular. And at the right side there is chondroid tissue, which is considered as a heterologous component. In the case of metaplastic carcinoma, radiology sometimes could be very, you know, deceptive because the lesion is not that infiltrative sometimes. Okay, so the borders are very well delineated and well defined in some cases, and that's why it might be very, you know, tricky. In biphasic metaplastic carcinoma, the defining carcinomatous component or the second component other than the spindle cells could be glandular, as I've shown you in the last picture, or could be squamous or carcinoma in situ as well. Okay, so we have these secondary components normally. The sarcomatous component is positive for P63, okay, basal marker, cytokeratin cocktails, myepithelial markers. Okay, some cases are positive also in metaplastic carcinoma, and normally these cases are triple negative. Okay, so they are ER, PR, and HER2 negative. Okay, so now if we have finished the biphasic ones, then we go through monophasic spindle cell lesions, the second category. So again, we have low grade and high grade ones, as well as in this category we have also inflammatory reactive lesions. Okay, like for example fibrous scar, desmoid fibromatosis, and nodular fasciitis. Okay, so we have these inflammatory reactive lesions, as well as low grade ones like myofibroblastoma, fibromatosis like metaplastic carcinoma, which is an interesting lesion, neural and lipomatous tumors, and higher grade ones like monophasic spindle cell metaplastic carcinoma, metaplastic carcinoma with heterologous components, sarcomas, and metastatic neoplasm. So I will go through all this step by step. So against what we talk about biphasic lesions, most monophasic spindle cell lesions may also occur in extramammary sites. So it's not like biphasic ones, which are mainly originating from the breast parenchyma. They might be coming from actually other non-breast specific sites also. So entrapment of normal epithelial structures in monophasic lesions. Okay, so it may lead to erroneous classification as a biphasic lesion. So we have to be careful when we are going to diagnose a lesion, spindle cell lesion, as monophasic, because as biphasic, we have to revise our diagnosis and double check, because sometimes there's just entrapment of normal ductal structures, especially at the edge of the lesion. That's why we call them biphasic, and they are truly monophasic spindle cell lesions. So we have to be careful in that sense. So the first category, inflammatory reactive one, So as I said, we have fibrous scar or reactive spindle cell nodule. So they are normally so-called post-operative or post-traumatic lesions. They occur within a month following a final aspiration, biopsy, surgical operations, or physical trauma. And in terms of histology, they form vague nodular proliferations of spindle cells, and they are mainly myofibroblasts with mild to moderate degree of nuclear pleomorphism, and sometimes there is a prominent nucleoli with visible mitotic activity. So it could be actually and if you don't consider the clinical context, it could be very worrisome. So microscopic clues is just presence of mononuclear inflammatory cells. So there is an inflammatory background, foreign body type giant cells, okay, in some cases, again, and indicating that there is inflammatory so-called reaction or a reparative process, foamy macrophages, hemosiderin deposition, and the granulation tissue like small vessel network are useful clues to diagnose fibrous scar reactive spindle cell nodule. This picture, you can see fat necrosis here. Okay, so you'll see entrapment of dead fat in between, and so you have fibrosis as well as dense mononuclear inflammatory cell infiltrate. So it is a sort of fibrous scar reactive spindle cell nodule in the right context. So it may be considered as late stage of fat necrosis as well. Okay, so it's not that uncommon in breast parenchyma. Here you can see even in trap duct, so it may be a bit of worrisome when you look at the lesion without considering the background of the patient. So the next one in inflammatory reactive lesions is nodular fasciitis. Is a reactive proliferation triggered by local trauma or injury. Okay, so again, another reactive lesion. It initially presents as rapidly growing painless mass. Okay, so it sometimes it is mimicking a sarcoma. Okay, so it's a pseudosarcomatous lesion, but the good thing is that the size will not go beyond a few centimeters, and it will normally resolve within a month or up to 2 years. So it's not that so-called worrisome if you follow the lesion, follow up the lesion. But anyway, on radiology, sometimes you'll see irregular unencapsulated hypoechoic nodule, okay, or a lesion with a speculated border on mammography, which is very worrisome, and also they present at proliferative phase normally, okay, when they are enlarging, and with this suspicious imaging finding, they may simulate a malignant neoplasm. So histology also sometimes is worrisome. They show, like for active mitosis, they show presence of, as moderate atypia. But the thing is that the background is inflammatory. There is a small capillary proliferation, extravasated RBCs, and tissue culture-like appearance, so-called myxoid material in the background. So they are coming from myofibroblast anyway. Okay, so the tissue of origin is myofibroblast, so but sometimes when you look at the lesion itself, is very, very worrisome, because it's very frightening, because you will have, as I said, mitosis. You have a bit of pleomorphism. So the fascicles are arranged haphazardly, and that's why nodular fasciitis is a pitfall, is a challenging case normally in the routine practice. And sometimes we have to proceed with immunohistochemistry, so we have to consider clinical or radiological correlation. So recently, I mean, within the past few years, we have actually identified a specific translocation, which is MYH9 USP6 translocation, which is specific for nodular fasciitis of some sort. And you can use also this translocation with FISH studies to highlight the and highlight the nodular fasciitis nature and confirm the diagnosis. So you can see here short fascicles arranged haphazardly with inflammatory background, tissue cartilac appearance at low power is very obvious here, and the entrapment of duct. Okay, so this is another type of reactive lesion, which is sometimes is challenging case in our practice. Okay. So the next one after nodular fascia is desmoid fibromatosis. Again, this is considered as a reactive lesion. So extra-abdominal one is locally infiltrative without metastatic potential. Okay, so it can mimic a malignant lesion in terms of infiltration, but in any way there's no normally metastasis. So a subset of DF occurs in patients with familial adenomatous polyposis and is associated with germline APC gene inactivating mutation, as you know. Okay, on radiology also, it may have again speculated borders. Okay, there's tethering of Cooper's ligaments and involvement of intercostal or pectoralis muscle, so it looks very infiltrative and very scary sometimes. Histology, it's composed of fibroblasts and myofibroblasts arranged in characteristic long sweeping fascicles. So these long sweeping fascicles is a morphologic criteria that we use for diagnosis in terms of arrangement of fascicles at low power. And of course on high power, so you can see blend myofibroblasts and fibroblasts with pinpoint nuclei, which is very helpful. And so you won't see that much of mitosis or pleomorphism at high magnification. So you'll get rid of so you'll feel that, oh, that's actually totally benign, and what you can see at low power is actually quite frightening as opposed to higher power. So you can see here, for example, this low power lesion, infiltrative borders, okay, within fat, entrapment of ducts here, and but you can see they are just composed of long sweeping fascicles. There's no haphazard arrangement, and you have this chance to stain this lesion with beta-catenin, which shows normally nuclear staining in most of the cases. Okay, so yeah, beta-catenin mutations in the APC beta-catenin pathway in FAP associated and sporadic desmoid fibromatosis normally results in accumulation of nuclear beta-catenin, and the one that I showed you, and this is due to involvement of exon 3 of CTNNB1 gene. Okay, so producing this sort of mutation. Monophasic spindle cell lesions. The next category is low grade. Okay, so we have covered so far biphasic ones and also monophasic one of reactive type. And now second member of this category is low grade lesion. Actually, we consider some important ones like myofibroblastoma in this category. So memory myofibroblastoma is a benign tumor occurring most commonly in postmenopausal ladies, okay, and also interestingly in men of similar age. It appears radiologically as solid circumscribed or smoothly lobulated lesion, so it's almost circumscribed on radiology. Microscopy will show short fascicles here, as opposed to desmoid fibromatosis. You're dealing with short fascicles of myofibroblasts with bland nuclei in distinct pale cytoplasm with indistinct cell borders as well. And in the background, you have fibrous tissue collagen material with ropey collagen bundles. I will show you the picture later. And interestingly, there are many variants for this. Sometimes they are making challenges for you for your diagnosis, like for example, symplastic epithelioid invasive lipomatous myxoid deciduoid cell, palisaded or Schwannian-like, and memory fibroblastoma with extensive myxoedematous stromal changes. There are some variants of this actually kind of condition. So you can see here, this is the classic myofibroblastoma spindle cell lesion within a fibrotic stroma with this ropey collagen, so-called ropey collagen. The cytoplasm is pale to lightly eosinophilic, and there is no distinct cell borders. Okay, so there are some, and also they are forming short fascicles, as I said. So there are some important clues in terms of morphology. And this one is my fibroblastoma lipomatous. So they are arranged within nodules within the lipomatous lesion. Okay, so they look infiltrative within fat. And higher power, you have some classic features, okay, as I show you, like these short fascicles within fibrotic stroma with ropey collagen fibers and all this, with pale cytoplasm. So you can apply all these features when you have a difficult case, and of course the high power will help you. But in challenging cases, you may use immunohistochemical markers as well. So this is one is my fibroblastoma with palisaded or Schwannian-like features. So you can see very nice arrangement of palisading arrangement of the cells of the nuclei, and very okay body-like features, which is very characteristic for schwannoma. When you see this sort of morphology, you may consider schwannoma, but when you stain with S100 is negative, but SMA is positive, like in this case, and which confirms my fibroblastoma. Okay, so it is reactive in general to CD34, CD99, vimentin, desmin, SMA, BCL2, and hormone receptors, ER and PR. And in men and actually in male individuals, it's also positive for androgen receptor. In some cases, there's loss of RB gene, which can be found also in some cases of, as I say, my fibroblastoma. So that's about my fibroblastoma. And the next member of this group is fibromatosis like metaplastic carcinoma. Okay, so interestingly, metaplastic carcinoma could have nearly bland morphology, okay, and it is very deceptive. So it's an indolent subtype of metaplastic carcinoma with potential for local recurrence, but low risk of metastasis. So the good thing is that if you miss it, so at least you have in this your mind, this actually fact in your mind that it has low risk of metastases. But anyway, it's considered a subtype of metaplastic carcinoma. We have some criteria to appreciate also this lesion that I will talk about. So it appears rounded and circumscribed on mammography, and histologically is composed of spindle cells with low to moderate cellularity with finger-like edges. Okay, so there is infiltrative borders, and there is also entrapment of adjacent breast lobules. Okay, so you can see here low power. So it forms a nodule, but with spiculated or infiltrative borders. Okay, so spindle cells, and you can see if you look at perhaps medium power or high power, you can see some areas of epithelioid morphology as well in between. Okay, so there is just sometimes there's a mixture of epithelioid and spindle cells anyway, but this in this case is very focal. And you can apply P63 staining, shows nuclear stain. And this confirms the so-called metaplastic carcinoma in this case. So you can use also other cytokratins to confirm your diagnosis, and you can also rule out fibromatosis because it's in general it's like fibromatosis in terms of morphology. Perhaps long sweeping fascicles can be there, but you can use beta-catenin, which is negative in this case, and it will completely exclude fibromatosis. So we have other mesenchymal tumors also, which I'm not going through all this, like for example, neural tumors, schwannoma, neurofibroma, lipomatous tumors, angiolipoma, lipoma, leiomyoma, solitary fibrous tumor, fibroma, inflammatory myofibroblastic tumor, or myxoma. So we have also rare cases like this also, but just for you to consider this in your practice if actually this case happens. For example, this case is mainly composed of fat with this fibrous stroma and also myxoid areas and ropey collagen. This is a case of spindle cell lipoma in the breast. So it may happen also in breast. So you have to bear in mind that so we are dealing with a variety of lesions actually. So we have breast specific lesions and also non-breast specific lesions. So the next category of final one is high-grade monophasic spindle cell lesions. So in general, it is reported to be so-called particularly aggressive among metaplastic carcinomas. Okay, so actually the spindle cell component usually actually unlike its morphology, which is sarcomatous, but usually it possesses a subtle the epithelial features, okay, at least focally within the tumor. All right, so you may appreciate at least the focal areas of so-called carcinomatous differentiation. These features commonly include focal areas of vague cellular adhesion. Okay, so there might be some cellular adhesion like carcinoma, focal to diffuse reactivity to high molecular weight cytokeratin, P63, and other basal and epithelial markers. So you can use this actually ancillary studies to confirm your diagnosis. So you can see here at the left side the morphology of monophasic spindle cell metaplastic carcinoma. Okay, it's spindling, and at the right side is one of the epithelial markers, which is EMA. In this case, EMA is positive, just to confirm the carcinomatous origin. Okay, so when you're dealing with heterologous elements or some sarcomatous elements like osteosarcoma, chondrosarcoma, just bear in mind that it's very uncommon for the breast to have some primary sarcoma. Okay, so it means that when you have frank sarcomatous tissue in the breast parenchyma, so you have to consider metaplastic carcinoma. Okay, spindle cell metaplastic carcinoma, you have to rule out this first. Because it's very rare for breast to have this sort of primary sarcomas. The next group is sarcomas. As I said, they are rare. They are very rare in breast parenchyma, but the most common one is angiosarcoma. If you are actually dealing with a case, so the most common one is angiosarcoma. The primary one can happen in 3 settings in general. It may happen de novo, as a primary lesion, or sometimes is followed by irradiation. Okay, let's say the patient had a previous malignancy and underwent irradiation for the treatment, and it may actually be complicated by a second malignancy due to irradiation, which is actually angiosarcoma in this case. And also sometimes due to chronic lymphedema, like in the case of Stewart-Treves syndrome. So we have these conditions related to angiosarcoma and breast parenchyma. So in general, when we talk about angiosarcoma in the breast, normally it doesn't form a well-defined mass. Okay, so it presents as a painless bruises. Okay, so because it's a blood vessel lesion, so definitely we are dealing with some sort of extravasation of RBCs, and unfortunately we can say it doesn't form a palpable mass in most of the cases. That's why sometimes it is diagnosed very late in this stage. So ultrasound mammography normally they cannot help that much, so we confirm the diagnosis by MRI. So MRI can be very helpful in terms of diagnosis. So histologically, angiosarcoma is characterized by complex anastomosing vascular channels and can be graded into low, intermediate, and high-grade lesions based on degree of atypia of the lining endothelial cells, and also formation of papillary or solid areas. Okay, so we have different grading also for that. In terms of immunohistochemistry, So we can use C31, C34, FLI1, ERG, and factor VIII related antigen. Okay, they are quite useful markers for the diagnosis. If you use especially 3 or 4 of them, so you can confirm for sure that this is a vascular lesion, and in the right context, you can confirm the diagnosis of angiosarcoma. So the radiation-associated angiosarcoma, they are more commonly high-grade lesions, and unfortunately, they harbor MYC amplification. Okay, so MYC amplification in most of the cases of radiation-induced angiosarcoma can be seen. So we have other primary breast sarcomas like fibrosarcoma, pleomorphic sarcoma, leiomyosarcoma, osteosarcoma, and myxofibrosarcoma, but they are very rare as confirmed as opposed to angiosarcoma. So anyway, irrespective of the phenotypic differentiation for the sarcomas of the breast, primary breast sarcomas, I mean, the prognosis is very poor, and so the patient normally have poor prognosis in this case, in this setting. The last one is in this group is metastases. So metastasis to the breast also is rare, and only 0.3 to 2.7 cases of less than 3% of malignant breast tumors are considered as metastases. So the most common source of malignancy is cutaneous melanoma, pulmonary, and ovarian carcinomas. Okay, so they are the most common ones. You have some criteria to use in terms of morphology. For example, productile distribution of tumor cells and absence of in situ component. So there's just some hints for you that this lesion is not coming from the breast parenchyma and is coming from outside. All right, and you can confirm by immunohistochemical markers like, for example, GCDF-P15, hemoglobin, and GATA3, useful breast markers. But the thing is that GATA3 is the most sensitive one, as opposed to, as compared to the GCDF-P15 and the hemoglobin, but they have less specificity against them. So GATA3 can be positive in urothelial neoplasm, so you have to bear in mind, in the case of positive GATA3, you have to see that whether the patient has had a previous history of urothelial neoplasm or not. Okay, so you have to rule out also this lesion. Okay, when we talk about these markers, of course, they are very helpful for the diagnosis of primary breast disease, but the thing is that they are mainly working on ER-positive breast cancer. So triple negative ones may be negative for GATA3 or GCDF-P15 and hemoglobin. Okay, so at the end, just to summarize, the thing is that because of this vast variety of lesions in this group, spindle cell lesions of the breast, so I've just tried to address one useful categorization. Okay, so in classification into biphasic and monophasic, and further based on grading, low grade, high grade, or in case of monophasic one, reactive ones. So this is how we try to classify, and this perhaps a bit of simpler classification could help pathologists and clinicians to understand the origin and also the to overcome the diagnostic challenges in real practice. But anyway, we have to bear in mind that we have other tools also for diagnosis. In difficult cases, we have to apply IHC and molecular techniques sometimes for the accurate diagnosis. So yeah, this is my references, and thank you very much for your attention. If there's any question from the audience, I would be happy to answer. Yep. Any question? Any question or comments? Okay, thank you, everybody. Thanks
Thank you,
for your
Dr.
time and
Mukhtar,
listening.
thanks so much for your nice presentation. So if there is no questions, we will go to our next speaker, Dr. Sudipto Malakar from India. I will pass the stage to deliver the speech.
Good afternoon, everyone from India. This is Dr. Sudipto Malakar. I'll be presenting my study on hematological markers, hematological quality indicators. I'll just share my screen. Hopefully, I'm audible to everybody.
Yes.
Is my presentation visible? Audible?
Yeah,
is my presentation visible?
Yes, yes.
Okay. So today's topic is quality indicators in hematology laboratory and analysis in a tertiary care hospital. Myself, Dr. Sudipto Malakar, and the co-authors for this presentation is Dr. Shashikala K. So why concentrate on quality indicators in a hematological hospital for a hematology laboratory? Because quality healthcare is that which is defined by the Institute of Medicine as the degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Since laboratory testing forms a very integral and essential part of the system, quality indicators of quality of laboratory reports have a significant impact on overall quality of healthcare delivery system. To assess the effectiveness of the final working quality indicators are required for comparison, for self-improvement, and also for corrections if there's a decrease in the quality of the delivered healthcare. Finally, a quality indicator is defined as a parameter which evaluates critical components, primarily like patient safety, effectiveness, equity, patient-centeredness, timeliness, and efficacy of healthcare, can be objectively assessed based on the evidence and can be implemented in a consistent and comparable manner across settings over a period of time. This study analyzes common quality indicators that we have taken, which covers all the phases of the entire workflow of a laboratory, namely the pre-analytical, analytical, and the post-analytical phases. So 7 quality indicators have been chosen, based on which our performance is consistently assessed, and these being the sample rejection rate, the sample redo rates, the routine turnaround time, critical reports, corrected reports, concordance in external quality assessment scheme programs, and staining quality. So coming to the methods which were undertaken for this purpose of this study, the data that was taken for a period of 1 year, that is between August 2020 and July 2021. It was an observational kind of study conducted at the hematological laboratory in a hospital at Rajarajeshwari Medical College and Hospital. And it was also a retrospective study, as the data is from the previous calendar year between August 2020 and July 2021 of this year. The 7 quality indicators that were analyzed were sample rejection rates, sample redo rates, turnaround time, critical reports and their turnaround times, corrected reports, staining quality assessment, and concordance in external quality assessment schemes. The quality indicators were calculated every month, and based on which the trends were analyzed. Coming to the results from the study that was undertaken, the final results showed showed average routine, urgent, and critical turnaround times being between 6.5 hours, 1.5 hours for urgent, and 3.4 hours for very critical reports. For the other quality indicators, it was shown to be as sample redo rates between 1.6%, rejection rates at 2.4%, corrected reports before validation was 4.5%, and after validation was 1.2%. Staining quality, that is unsatisfactory day rates, was 2.5%. 99% concordant performance was found with the external quality assessment program. Over the study period, it was observed that the turnaround time showed a decreasing trend, and the sample rejection rates was also decreased. The number of monthly critical alerts for the same period of study showed an upward trend, which could be attributed to the increasing awareness among the staff, laboratory staff. Redo rates didn't show any significant change. In this chart, we are showing the various causes of sample rejection. And as we can see in this chart, the primary cause in our laboratory for sample rejection was sample receipt was clotted. After that, the most common cause being the mismatch vacutainers, as they were sent in the wrong vacutainers from the collection centers or from the respective wards. Followed by this, there were two other important causes being being insufficient samples and hemolysis and other miscellaneous causes. Now coming to turnaround time. Turnaround time was defined as the time elapsed from the collection to the time of reporting of the results. The maximum that has been set in our laboratory is 8 hours for routine tests and 2 hours for those which have been marked urgent. This period was actually calculated by the hospital information software that we use here from the time the sample is validated to the time it is available on the hospital information system. That is meaning to say that the actual time of collection between there was a difficulty in obtaining the actual time of collection in all the reports. We have assigned it as that the time when it was received in our lab and to the time the final report was put into the hospital information system. Average for the routine, urgent, and critical reports, the time around time was 6.5 hours for the routine, 1.5 hours for the urgent, and 3.4 hours for the critical reports. The analysis on trend analysis, the turnaround time showed a significant downward trend during the study period. Coming to the next important quality indicator, that was sample redo rates. Sample redo rates was defined as a case where the results did not match either with the previous results, that is called as a failed delta check, or with slides or with given clinical picture, and hence a fresh sample was asked for confirmation and rechecking the values. The rates observed in our laboratory was about 6.9% with no significant change over the period of study. The commonest cause was the mismatch with previous values. Other common causes being the wrong samples taken in wrong samples, pre-label analytical errors in blood collection, like sample being collected in a wrong vacutainer, or it being wrongly labeled, or wrong history being provided, and technical issues or wrong entry into the final registries. The next most important quality indicator being critical alerts or reports. Critical reports are those samples for which reporting delays can result in serious adverse outcome for the patients. Our laboratory defined the critical values for the various parameters as per the table. 1. Here we can see the critical alerts as set by our laboratory. the 9 critical parameters have been taken. The first being hemoglobin less than 6 grams per day, total leukocytic count more than 25,000 per millimeter cube, absolute neutrophil count being less than 1,000 millimeter cube, platelet count being less than 50,000, peripheral blood smear showing blasts or active hemoparasites or active hemolysis, sickling test being present, ESR being more than 100 millimeter in the first hour, international normalized ratio and APDT, these are coagulation studies. In case of APDT being more than 16 seconds or no coagulations, and INR being more than 5. The percentage of critical alerts was also calculated monthly, and the trend analysis showed an increase in the critical alerts over the duration of study. Most common critical values being the low platelet counts, which are accounted for nearly 31% of the total investigations done, and abnormal PT-INR 13% being for the same period. The average critical reporting percentage per month were around 5.4%. Coming to the corrected reports, this is an indicator that is used to determine the causes of corrections so that preventive actions can be taken and reduce the release of incorrect reports from our laboratory. It was found that before final validation, it was the rates, average rates loomed around 4.5%, and the correction of validated reports that's after final validation was found to be around 1.2%. Most common value corrected was the platelet count after slide validation. Cause of correction after validation included a wrong selection of positive or negative results from drop-down menu or clerical errors while entering the results in the hospital information system. Coming to the internal quality check failure rates, this is an important quality indicator. It is followed every day, daily twice in our laboratory, and the results are assessed and tabulated in a monthly manner. For daily internal quality checks, we all analyze that cell counters and coagulations are recommended according to QC materials. The rates of IQC failure was calculated monthly. The average for cell counters being around 2% and the coagulation analysis being 1.5%. Analytical procedures like staining quality, a subjective assessment was recorded daily as satisfactory or unsatisfactory. Unsatisfactory stain being around 2.5%. Performance in external quality checks. Concordance was checked in external quality assurance program, and interlaboratory comparisons were drawn. It was 99% for the CBC and peripheral blood smear morphologies. This program is conducted here in India by AIIMS Laboratories IS HTM EQUAS program, and 97% with the CBC Velo EQUAS program. Overall concordance for laboratory in various EQUAS programs was 98%. Coming to the discussion, a single error at any step during this testing process for sample collection to transport and analysis of samples of the reporting of results invalidates the quality. So to ensure a tight quality system, the process of identifying the errors, their corrections and future preventions should be integrated into the system. Sample rejection rates is an indicator of skill testing at all levels of pre-analytical analysis. Low rate indicates an efficient system. For example, in our hospital, ICUs have the least rates for rejection as due to more experienced and skilled staff. The decrease in the rate over this period of study may be attributed to the increased awareness among the and more compliance by the nursing staff and as well as the other medical personnel. Turnaround time is defined as the time elapsed between the sample validation at laboratory to the time to the report being available online. The average turnaround time for routine, urgent and critical tests fell within the maximum permissible turnaround time set limits. Sample redo rates are an indicator of robust delta check actively being followed in the laboratory. Critical reporting is considered an important laboratory process because it can impact the clinical decision making, patient safety, and operational efficiency. In a survey of nursing supervisors, physicians, and the majority of medical staff, interviews and reviews of medical records indicated that critical values resulted in a change in therapy. 95% of surveyed physicians indicated that critical value results were valuable for patient care. Performance in internal and external quality indicators showed good indicators of efficiency and accuracy of our machines and reporting systems. These parameters are easily analyzed objectively over time and hence make a robust quality indicators for any laboratories. Coming to the conclusions, quality indicators help not only in objective assessment of any laboratory by external agencies, but also for self-assessment and improvement. Continuous monitoring is mandatory to have a tight quality check system and better clientele satisfaction. These being my references. Thank you.
Thank you so much, Dr. Malakar. If there is any question, just please ask or write in the chat box. So if not, thank you again, Dr. Malakar, for your nice presentation.
Thank you for the opportunity, ma'am. Thank you, everyone.
You are welcome. And yes, I will give the speaking to Dr. Sagarika Mahapatra to introduce the other speakers.
Am I audible?
Yes, yes, you are.
Thank you, Dr. Madani.
You are welcome.
I am Dr. Sagarika Mahapatra from Nepal, and I am the next chairperson for the upcoming 5 talks. And I would like to thank the organizing committee for providing me this opportunity to chair this session. And I'm very glad to be a part of this conference. And I think this is a very wonderful platform for us to share our knowledge and ideas and get connected to people from different parts of the world. So without any further delay, I would like to start the upcoming talks. We have a question for Dr. Sudipto. How many samples and staffs are working in a day? Dr. Sudipto Malakar, are you there? Okay, maybe you can, Dr. Sudipto.
Yes, ma'am. Yes, ma'am.
There's a question for you. How many samples and staffs are working?
Ma'am, we are getting around average of 250 to 500 samples per day. Monthly being around 8,000 to 9,000, but there are variations in that. And as for the number of staffs, we have around 8 staffs who are in the professors and higher grade, and we have 15 residents, and we have also around 7 to 8 lab technicians who help us in conducting our laboratory work.
Okay, thank you, Dr. Malakar. Are there any further questions? You can write in the chat box if there are any. So we'll proceed with the conference, and I would like to invite our next speaker, Dr. Ramazan Demirel from Turkey. I'm passing the stage to deliver the speech. Thank you. Dr. Ramazan Demirel, are you there?
Yes, I'm here. Hello, everyone. I open my videos.
Yeah, can you please turn on your video?
Okay.
So this talk is on behalf
Hello
of...
everyone, I will make my presentation trying one article.
I'm open it. You sure?
So this talk is on behalf of Dr. Hatis Basaran from Turkey, and Dr. Ramazan Demirel will be presenting the talk.
I'm started. Okay.
Hello everyone, I will make my presentation trying one article. In order to understand its expression, it is necessary to
Dr. Ramazan Demirel, are you there?
I'm here. I'm trying.
We've not been able to hear you.
Okay.
Please share your screen. There's a button called share screen. Green button, share screen. Please click that button and then share your screen.
You show my presentation?
You have shared your screen, but we cannot see your presentation. At first, please open your presentation in the background.
Background.
Please open your presentation in the background. I think there has been some issue with sharing the screen. So I'd like to invite our next speaker, Dr. Faisal Mahfouz from India. I'm passing the stage to deliver the speech. Are you there, Dr. Ramazan Demirel?
Okay. You show my presentation?
Yeah, okay. Are you there? So we can see the screen.
Okay, I'm started.
Yeah, okay, you can carry on with your presentation.
Okay.
I will make my presentation trying on article in order to understand its expression. It is necessary to know the pathways of PD-L1 in the cells. Presentation plan. What is PD-L1? Checkpoints, PD-1, PD-L1 pathway, PD-L1, PD-L1 pathway in solid tumors. Once. What is PD-L1? The programs so that one receptor is an immune checkpoint inhibitor, which is expressing one the effects on human effect cells. It is activated manner by PD-L1, which can be expressed by all human cells. The PD-1, PD-L1 pathway plays a role maintaining peripheral lymphocyte tolerance and regulation inflammation. In concert, the expression of PD-L1 seems to be one of the major immune escape mechanisms. My students have shown of clinical PD-1, PD-L1 with specific antibodies like in the breast, potential response demonstrates metastatic triple negative breast cancer. The tumors are initiated by a combination of mutation with take organic information. Mutation might not only mutation population and immunism, but also the no antigen by Chinese standing or antibody. Remaining foreign antigen or the immune times leading to immune reaction directing against it. Evidently, in zinc tumors, there's antigen directing immune reaction is entirely inactive or displayed or but charity immune escapes. PD-1 on the T-cell and its ligands PD-L1 on tumor calls has been the focus on many clinical drugs. Immune checkpoints and the cells are activated for foreign antigens are present on major complex anti-co-expression of the cells receptor on the one hand and by concurrent for activation of cosmonaut and or co-inhibitor signal on the other hand. The latter include members of the family and not immune checkpoints. Immune checkpoints are involved in the T-cell tolerance as well as activation. They play important role in T-cell tolerance and immune chance. Hemostasis under psychological condition, therapy predicting tissues from unnecessary damage when the immune system has effectively clearing the pathogen. Our maternal immune tolerance to those the fetus in part regulates by checkpoints. PD-1, PD-L1 pathway. PD-1 is inhibitor immune checkpoints inhibitor which expression on the surfactant of the cell, natural killer cell, T-cell, disease, and indication of the tolerance to antigen. The in vitro blocking PD-1 with monoclonal antibodies led to fall increase the stocking production. However, the in vivo activity also depends on the dead cell motility as well the duration of the interaction with antigen presenting cells, target cells. When they decide how we activation by their PD-1 expression simulation to offer the particular side away as exclusion immune reaction. PD-1 expression response and the immune response has eliminated the pathology antigen as important role of the PD-1, PD-L1 pathway has been shown diabetes cardio, the human immune defective first infection with disorder, autoimmune disease, as well as in solid tumors. In the embryological immune checks produced and respect molecular antibodies has been shown to trigger efficacious anti-tumor response not only is classical immunogenetic tumors types like melanoma and renal carcinoma, but also many other solid tumors, lung, colorectal avulsion, esophageal bladder, and breast cancer. PD-1, PD-L1, that's why in solid tumors. In solid tumors, the PD-1, PD-L1 inhibitor pathway can be used to slice the immune system by increasing the expression PD-L1 on the tumor cell surface. PD-L1 expression has association with large tumor size, high grade, hyperplasia, estrogen receptor negative status, and for two positive status, and it is inversely correlated with ovulation, and breast cancer. PD-L1 is expression of triple negative breast cancer. These integrants that alter anti-tumor immunity elicited against many solid tumors. It is point blunt immunosuppressive factor. It was shown in vivo that PD-L1 increased tumorigenesis and the invasive and makes tumor cells less related to specific CDs, atypical melanoma tumor growth by suppressing PD-1, connective mass, PD-1, PD-L1 pathway using the specific antibody less striking tumor in cellular immunotherapies. Once immune modulation seems to be present in striking solid tumors, like immune-specific has been described breast cancer subtypes with high prevalence index. Immune checkpoints are often the major mechanism of the immune escapes. Expression of PD-L1 on the tumor cells leads to lower activity of CD. At these cells, antibody against PD-1, PD-L1 are begun in investigated clinical trials. The first results are proximate, but only subset of patients respond to immune checkpoints with treatment. Predicate markers are needed to select those patients with best chance for effective treatments. Thank you for listening.
Thank you, Doctor, for that wonderful talk. Do we have any questions? If there is any question, please write in the chat box and we can come to that later. So I would like to invite our next speaker, Dr. Faisal Mahfouz from India. I'm passing the stage to deliver the speech. Dr. Faisal Mahfouz.
Thank you. Is my screen visible?
Yes, it is visible. You can go ahead, Doctor.
Thank you. Good morning, everyone. I'm Dr. Mohammad Faisal Mahfouz. I'm a second-year pathology resident from Rajarajeshwari Medical College, Bangalore, India. First of all, I would like to thank the organizers for giving me this opportunity to present my study at this platform. and also to all the delegates as well for their valued presence. The topic of my presentation is cytomorphology of pathological body fluids and institutional experience. And my co-author is Dr. Shamila PS, who is former head of department and currently professor of pathology in our institute. Coming to introduction, cytological assessment of body fluids plays a vital role in providing insight into diagnosis, prognosis, and therapeutic aspect of various neoplastic and non-neoplastic pathological conditions. Evaluation of body fluids is a rapid, simple, cost-effective, and patient-compliant investigation. Present study is an attempt to analyze all the body fluid samples referred for cytological evaluation in our tertiary care hospital. And the most commonly analyzed fluids are pleural and ascitic fluid, followed by CSF and sputum. Materials and methods. The present study was conducted in the Department of Pathology, Rajarajeshwari Medical College and Hospital, Bangalore, India, from October 2020 to September 2021. The study design was a hospital-based observational study. The study was conducted for the period of 1 year, from October 2020 to September 2021. And the source of data was that all the body fluid samples received during the study period in the Department of Pathology were studied. A total of 144 samples were included in our study. Subjects and selection method. All the body fluids from neoplastic and non-neoplastic diseases which came for cytological analysis were included in our study. Procedure. After receiving the fluid sample, details like type of fluid, clinical diagnosis, age, and gender of the patient were noted. Immediately, the sample was centrifuged and the sediment smears were made. Sediment smears were stained by GIMSA, H&E, and Pap stain. Cell blocks were processed for H&E stain. Is my screen visible?
Yes.
Thank you. Sediment smears were stained by GIMSA, H&E, and Pap stain. Cell blocks were processed for H&E stain. Cell count of the fluid was done in improved Newbor's chamber. 100 cells were counted and differential count was expressed in percentage. Cytomorphology of the cells was studied and documented, paying attention to the cellular arrangement, cytoplasmic features, and nuclear characteristics. Coming to results, the cytological analysis was done on 144 cases. The male to female ratio of these fluid specimens was 1.44:1, with 85 male patients and 59 female patients. The most common fluid was pleural fluid with 46 cases. The second most common fluid sent for pathological analysis was ascitic fluid with 42 cases, followed by CSF with 18 cases, sputum with 12 cases, urine with 7 cases, bronchoalveolar lavage fluid with 6 cases. The other fluids included 2 cases each of synovial fluid, ovarian cyst fluid, nipple discharge, and 1 case of pericardial fluid, psoas abscess fluid, splenic subcapsular fluid, bladder diverticulum wash, peritoneal and endometrial wash fluid, and fluid from the brachial plexus tumor. The table over here shows the age range in years, the type of fluids and their distribution, and the total number of cases. As we can see, for pleural fluids, most of the cases, that is 11, came from the age group of 51 to 60 years. In case of ascitic fluid, most of the samples were from the age group of 41 to 50. In case of CSF, most of the samples were from the age group of 0 to 10. So to summarize, the range of age group varied between newborns to 85 years of age, with maximum cases in the age group of 51 to 60 years. And the most common age group affected was the 6th decade. The mean age of presentation in both sexes was 48.2 years. The table over here shows the type of fluid and we classified it as non-malignant, malignant, suspicious of malignancy, cases where there was no opinion possible, and a total of 127 cases were non-malignant, 9 cases were positive for malignancy, 4 cases were suspicious for malignancy, and in 4 cases, no opinion was possible. On the basis of gross appearance, fluids were categorized into clear, turbid, and hemorrhagic. Out of 144 cases, 85 cases were clear, 44 cases were turbid, and 15 were hemorrhagic. Out of the 6 bronchoalveolar lavage fluids, 1 was reported as suspicious of malignancy. Out of 7 urine samples sent for cytology, 1 was positive for candidial fungal elements and 1 was suspicious of malignancy. 1 sample of wash from bladder diverticulum showed candidial spores and pseudohyphae. No opinion was possible in the fluid from brachial plexus tumor. All other fluids like synovial, pericardial, ovarian cyst fluid, endometrial and peritoneal wash fluid, fluid from nipple discharge, psoas abscess fluid, splenic subcapsular fluid were all reported as non-malignant. The table over here shows the predominant cell types, the number of cases, and their percentages. In the study, majority of the fluids, that is 48.6%, had lymphocytes as a predominant cell type, followed by neutrophils. In 15 cases, we had mesothelial cells as the predominant cell type. There was no predominant cell type in 16 cases. There were 7 cases of atypical cells being predominant, 4 cases where there was no opinion possible, and 4 acellular cases. It is important to note here that smears showing predominance of lymphocytes point toward benign lesions, whereas predominance of neutrophils in sheets and clusters normally point towards acute inflammatory process. Coming to discussion, cytological examination of body fluids in adults has been widely known and documented in various pathological conditions. Also, the smear prepared from the cell population present in the fluid sediment is much more representative and has higher sensitivity and specificity than that obtained by needle biopsy. We studied a total of 144 cases, out of which pleural fluid was maximum, which was similar to the study of Chakrabarti et al., but in contrast to the study of Gupta et al., where peritoneal fluid was the most commonly studied fluid. Fluid was aspirated more from males as compared to females and was similar to the study of Piyush et al. And in contrast to the study of Sudha et al., where female preponderance was seen. Maximum number of cases belonged to the age group of 51 to 60 years, which was similar to the study of Saxena et al. In our study, malignancy was detected in 8.6% of cases in pleural fluid and in 11.9% of cases in ascitic fluid. Some of the studies noted relatively less percentage of malignant cells like Gupta et al., Khatib et al., and Priyanka et al., with 7% of their cases to be malignant, which was similar to our study with 6.2% malignant cases. The most common pathology noted in all the fluids was chronic inflammation, both in pleural and ascitic fluid. These lesions had a predominantly lymphocytic infiltrate. Reactive mesothelial cells were also seen in few cases. Pleural fluid was the most common fluid sent for analysis, 31.9% of cases, similar to the study by Kumawat et al. Of all pleural effusions, lymphocyte-rich exudates were the most common effusions, and similar to Kumawat et al., these were all clinically suspected as tuberculosis, which was in contrast to Chakrabarti et al. And Sholbha et al., who observed transudates as the most common body fluid. Four cases of pleural effusion were found to be malignant, and the cause was adenocarcinoma. Cell block was done on 3 cases of pleural fluid out of 4 cases which were positive for malignancy on cytology, and was reported as positive for malignancy in 2 cases and suspicious of malignancy in 1 case on cell block. Out of 42 cases of ascitic fluid, transudates were the predominant effusions and liver cirrhosis was the commonest etiology, similar to studies like Sudha et al. 5 cases were found to be malignant and were mostly adenocarcinomas metastasizing to peritoneal cavity. Cell block was done in 4 cases. 2 cases were reported as positive for malignancy and 2 were suggestive of malignancy. Examination of effusion cytology is sometimes tricky as morphology of reactive mesothelial cells may mimic malignant cells. Hence, the distinction between reactive mesothelial cells and malignant cells on cytological examination of fluid cytology is a diagnostic challenge. Hemorrhagic fluid is highly suspicious of malignancy. In our study, hemorrhagic aspirates were noted mostly in cases with malignant effusions. On the left side is image A, which shows eosinophils in sputum in a case of acute exacerbation of chronic obstructive pulmonary disease. And on the left side, eosinophils are seen under oil immersion 100x. Here on the left side is image A, which shows predominantly neutrophils in sheets and clusters in acute inflammation in ascitic fluid from a case of chronic liver disease with portal hypertension. On the right is image B, which shows reactive mesothelial cells scattered singly and in tiny clusters in ascitic fluid from a case of chronic liver disease. Here images A and B show epithelioid cells and lymphocytes in pleural fluid from a case of tuberculous pleural effusion. Here images A, B, and C show individual cells with pleomorphism, moderate to abundant cytoplasm, high NC ratio, irregular chromatin clumping, and nucleoli in few cells in a case reported as suspicious of malignancy in bronchoalveolar lavage fluid taken from a case of right lung, middle, and lower lobe consolidation. And this was finally diagnosed as bronchogenic carcinoma. Here images A and B show candida spores and pseudohyphae in a fluid which was labeled as wash from bladder diverticulum. This was taken under 100x magnification. Here images A and B show atypical cells in 3D clusters, groups, and scattered singly. The individual cells are large, round to oval, with moderate to abundant amount of cytoplasm, high NC ratio, and hyperchromatic nucleus. Few multinucleate and binucleate cells are also seen in this pleural fluid. This was from a right-sided pleural effusion case and was reported as positive for malignancy. Here image A on the left shows cryptococcus with a thick capsule in Newbor's chamber from CSF of a case of cryptococcal meningitis. And on the right side, we can see cryptococcus in India ink preparation from the same case. Coming to conclusion, effusion cytology is a simple and safe diagnostic procedure. The study of fluid cytology has paramount importance in identifying atypical cells in effusions, which in turn helps to know the advancement of the disease process in the body. Fluid analysis, although is not a substitute for conventional histopathology, but can be complementary to it in diagnosing malignant conditions. Cytological examination of the fluids, along with physical examination, is an asset to both pathologists and clinicians to identify specific etiologic agents, to follow the natural process of disease, to plan the treatment and monitor the response to therapy in a cost-effective manner. These are my references. Thank you.
Thank you, Dr. Mahfouz, for your informative talk.
Can I ask you a question?
Yeah.
How often do you see contamination by Candida in the body fluid? Is that common? Because I've just recently had a case, and definitely we have to correlate with the right clinical context. But I'm asking about your experience. How often do you see, or how often do you report contamination?
We have not seen many such cases, but yeah, this one case of candidal spores being seen was a recent case, and we also advised the clinicians to go for candidal treatment, and the patient responded well. And
I see.
in case and contamination as such, we are not seeing many cases.
I see. Okay. Right. Thanks.
There's a question that what do you mean by no opinion possible? Well, sometimes there is scant cellularity. If it is not completely acellular, sometimes we classify fluids as completely acellular. If it is not acellular, there is scant cellularity. You can see scattered cells singly, and sometimes you can see the sample is insufficient, and sometimes after processing, you don't have much of the sample left. Such cases we give as no opinion possible. Sometimes there is CSF, which is hemorrhagic, after a hemorrhagic tap. So mostly you will see all blood derived cells. So in that cases, we are giving it as no opinion possible.
I have a question. Well, I would like to know the cytological findings in cases diagnosed as malignant on cell block. What were the cytological findings?
Yes, ma'am. We saw pleomorphism on cell block 2, and some cases were given as actually suggestive of malignancy, and some were given as suspicious of malignancy. And we actually wanted to go for a biopsy and further studies to confirm such cases.
Okay, thank you. Okay, so is there any question? If there are any questions, please write it in the chat box. Thank you, Dr. Mahfouz.
Thank you, ma'am. Thank you, everyone, for being patient listeners.
Okay, now I would like to invite our next speaker, Ms. Ghazali Madani from Germany. I'm passing you the stage to deliver the speech.
Hi, everyone. Thank you, Mrs. Maharjan. I am Ghazali Madani, master student of biochemistry and molecular biology. And I am so happy that I am here. So I will start to share my screen to start my presentation. So is it visible to all?
Yes, it is visible.
So thank you. The subject that I am going to talk about today is the evaluation of BRAF pathway and mutation in BRAF F600E gene as a prognostic and early biomarker in the diagnosis and metastasis of ovarian cancer. In the first step, I want to talk a bit about the ovarian cancer. First, I have to talk about what is exactly ovarian cancer and how they are going to be in groups. Ovarian cancer is the fourth most common type of cancer and the most common cause of death due to gynecological cancers, the epithelial type of which is the sixth most common cancer in women. As a matter of fact, the first thing is about ovarian cancer is that by itself, it cannot cause deaths. The most important thing is that it can cause deaths because of the metastatic. And in 70% of the cases, we cannot understand the ovarian cancer until it gets metastatic. Ovarian cancer is a multifactorial disease that is affected by both genetic and environmental factors. This cancer has the highest mortality rate among all other diseases of the female genital tract. Most patients with ovarian cancer are diagnosed at an advanced stage, as I said, the stage 3 or 4, which accounts for a large volume of cystis and widespread peritoneal diffusion. So in this case, the lymph nodes are included in the cancer. Maybe that's get to the liver or pancreatic, so that is metastatic, and in so many cases that lead to death. The risk of ovarian cancer is higher in those who ovulate more often. Therefore, those who have never had a child are at higher risk. People who start ovulating at a younger age or menopause at an older age are also at risk. That's the reason why they said that if there are anything special and not in order during the ovulating or something like this, in teenagers, they have to visit a doctor to be in touch with her, and if there is something wrong, to prevent the risk of ovarian cancer. Ovarian cancer mainly affects women who have been through the menopause, usually over than 50 years old, but it can sometimes affect younger women too. And here is the progression of ovarian cancer. As normal epithelium that we have, stage by stage gets to carcinoma, and here is the way that we can recognize the ovarian cancer, and it's mostly at the 3rd or 4th stage. And here is the percentage of ovarian cancer cases that is diagnosed by the age group. As it can be seen here, we have the most cases in 54 to 64 age that we talk about here. That's the menopause age. And the very rare form is in less than 20-year-old or between 20 and 34 years old, and started from 45 to 84. That is the most age of getting cancer. To have some groups of diagnostic the ovarian cancer, one of the types is based on the biologic or cell biologic of the cancer, where is the start of the ovarian cancer. Here are 4 types of the cancer that is written here. The first and most common one is the epithelial ovarian cancer that starts from the surface of the ovary, as it's named, and from the epithelium. And as I said, that's the most common ovarian cancer. The other one is the germ cell ovarian cancer that is from the reproductive cells of the ovaries, and it's somehow rare. The other one is the stromal cell ovarian cancer that is from the connective tissue cells, also rare. And the 4th one is the small cell carcinoma that's called SCCO of the ovary. It's an extremely rare ovarian cancer, and it is not certain whether the cells in SCCO are from ovarian epithelial cell, or from 6-cord stromal cell, or from germ cells. The point that I need to mention here that in the first step, I said that that's the combination of genetical and environmental cancer. I mean, environmental effects like having high BMI and adipose and anything like this can 100% affect the percentage of the cancer. Here are the common ovarian cancer gene mutations in Western countries mostly. That was the thing that is not completely new, but I couldn't find any newer thing like this schedule here. So if we can divide the ovarian cancer into epithelial or non-epithelial subtitles, here we are searching for low-grade mutations that I am going to talk about them today, specifically BRAF. They are the one that if we can diagnose them in an ovarian cancer case, we can understand that it is in a low grade. So there is no metastatic step. So we can prevent metastatic and deaths of the ovarian cancer. But if it's gonna be from, I don't know, P10 or PPP2R1 alpha or anything like this, that is mean that that's a bit metastatic and that's somehow over. So here I am going to talk about the BRAF-KRAS pathway. The BRAF gene family provides instruction for making potential proteins that help transmit chemical signals from outside of the cell to the cell nucleus. Genetic precursors such as changes in the pathway of BRAF genes that lead to mutation in the type 1 biological evaluation, that's the BRAF genes are more related to the type 1 evaluation, and are particularly important in somatic cells. In particular, the RAS-MAPK pathway regulates cell growth and division or proliferation. That's a process that stimulates cells to perform a specific function that can be somehow differentiation, cell movement or migration, and cell self-sufficiency or apoptosis that can happen when a cell is not functional anymore and apoptosis happens. The BRAF gene belongs to a class of genes known as oncogenes. So, and here is the signaling of BRAF and RAS pathway that we can see that is come from surface and will go inside of the nucleus of the cell. The BRAF gene belongs to a class of genes known as oncogenes, as I mentioned. When mutated, oncogenes potentially cause normal cells to become cancerous. And if I want to talk specifically about the gene position, I can say that the chromosomal location of gene, cytogenetic location, is the long arm of the chromosome or Q arm, and in the 7th position in 34. And the molecular location, the base pair is exactly here on chromosome 7. So that was the whole and general information about the ovarian cancer and the pathways. And now I want to talk about what did we do in this study to see if we can find out something about BRAF pathway. In this case control study, the frequency of BRAF V600E gene mutation in 4 groups of tumor samples of patients with ovarian cancer, blood of ovarian cancer patients, and blood of normal and normal individuals was evaluated and compared using real-time PCR technique. Blood samples were more important for us to get a result from them. I will come to it a bit later. How was the method? In this case control study, we studied 25 ovarian tumor samples and 25 blood samples from ovarian cancer patients who underwent surgery, and 50 blood samples from healthy women and 5 samples from normal ovarian tissue as control. Then DNA extraction was performed for all samples, and finally the frequency of BRAF V600E gene mutation was evaluated by quantitative real-time PCR. What was the results here? Due to the lack of gene fold changes related to the frequency of mutation in BRAF V600E gene and the absence of mutation in this regard in the samples of malignant tumor tissues of patients with ovarian cancer of normal tissues as a control, there were no significant results, and we have virtually no mutation. So here we have a valuable negative results. However, in the blood of patients in this group, 2 people, around 8% of our whole study, had this mutation, and gene fold changes are significant. So in this case, I can say that if we could have a bit of bigger population in our study, we could gain a bit more information about the first stages of mutation in BRAF V600E genes. Now, due to getting 2 mutations in blood sample, it can be shown in the future that, as I said, we need a larger statistical community with the specificity of the tumor type, because in our case, we just had the tumor samples or blood samples from the women that had the tumor. We didn't know about the stages, or we didn't specify them. So if we could specify the tumor type and tumor stage, then we have a bit more specific answer cancers, and we could recognize the stage of the tumor, because it can lead to more specific results. Then we can say that, okay, this mutation in BRAF pathway or in KRAS pathway is specifically for the early stages, and if it's not visible or if it's not detectable, so it is after this stage and it is metastatic stage. And this can be done in future for sure, because that's a less invasive and early method in diagnostic. So it is a study that can lead to more specific answers. And as I said, tumor type and stage of the cancer can affect the results of mutation. And here we have a photo from the quantitative real-time PCR, and the blue dots, as it can be seen here, are no mutations, and yellow dots are mutations. And I want to talk about a bit about the previous studies that has done before. That was a significance of these findings that BRAF and MEK1/2 mutation are more common than expected in ovarian cancer, which could have important implications for the treatment of the patient with the disease and suggest potential new therapies. So the gene therapy is a thing that is now a bit more common, and a disadvantage is that, not a disadvantage, but is that we cannot go so much through that because there are so many mutations, and of course that take time. A study by May et in 2016 found that ovarian cancer carcinoma has a low progression of the frequency of active mutation in the KRAS and BRAF gene families, which is consistent with our research in the presence of 2 mutations in the BRAF gene. And to come to discussion, it is true that the frequency of BRAF V600E gene mutation in early detection of metastasis in patients with ovarian cancer is low compared to other studied and reported tumors, that is somehow about 8%. Further researches is being conducted as a less invasive and early method in this diagnostic of early stages of cancer and metastasis of ovarian cancer, considering the prevalence of this type of cancer, the importance of its early diagnostic and follow-up of focused treatment. Because as I said in the first step, the ovarian cancer nowadays is detectable exactly when it's metastatic. So if we can have a bit more population of ovarian cancer and a bit more specific of the tumor type, then we can lead to a gene therapy and can lead to a follow-up focused treatment. So it can be somehow said that examining and determining the frequency and prevalence of this type of mutation, especially in the blood of this patient and not only in their tumor tissue, may be helpful in diagnostic. That was the reason that I said that we need blood samples more than tissue samples, because I know that was not a very big population, but in this population also we had the mutations in the blood samples. We couldn't see anything in the tumor tissue. With less invasive methods, select individualized treatments and treatment guidelines for ovarian cancer. And this BRAF pathway can be used as a prognosis in future. And I really will be happy if there will be any idea to how to choose some populations or how to consider new tumor stages for further studies. And thank you so much for your attention. If there is any question, just feel free to ask.
Thank you, Ms. Kahale Madani, for that very informative presentation.
Welcome.
Do we have any questions for Ms. Madani?
And also any comments how to develop this study to be a bit more and more specific one?
You can write the questions in the chat box as well. Okay, thank you, Ms. Madani.
You're welcome.
Okay, now I'd like to invite our next speaker, Dr. Shrungari Sundar Kulkarni from India. I'd like to pass the stage to deliver the talk, Dr. Kulkarni. Please proceed.
Yes. I'll share my screen.
Yeah, please go ahead.
Okay. Is my share screen visible?
Yes, doctor, it is visible. You can go ahead.
Am I audible?
Yes, doctor.
Yeah, okay. Okay, am I audible also?
Yes, you are audible.
Okay. So I'm Dr. Shrungari Sundar Kulkarni from India, Maharashtra, Aurangabad, and I'm pursuing my second year post-graduation studies and student at Aurangabad. So without wasting a single minute, I'll just like to thanks for this platform for giving me this opportunity. And I'll further proceed with my presentation, that is breast cancer awareness, signs and symptoms. So first of all, I'm not here to scare anyone. I'm here to make you aware of yourself. So what is cancer? So cancer is the abnormal, uncontrollable, continuous replication of cells. So in terms of breast cancer, it is formed in the tissues of the breast and it spreads mainly through the lymphatic system. So breast tumors are basically two types, which is malignant and benign. So as told by Dr. Madani, that malignant is a cancerous, and as well as if you talk about benign, it is non-cancerous. So benign, which is non-cancerous, are the abnormal growths, but they do not spread outside the breast and they are not life-threatening. Most lumps are caused by the combination of the cyst and fibrosis. So cysts are nothing but fluid-filled scars. Fibrosis is the formation of scars-like tissue. These changes can cause breast swelling and pain. So these are just a common benign presentations of the breast lumps, like the cyst, it grows inside the breast. So in order to talk about the malignant cancerous tumors that starts in the cells of the breast, it is found mostly in women, but men can get breast cancer too. So talking about the breast cancer, we have, as I told earlier, we have two, malignant and benign. So malignant can be invasive and the benign is non-invasive. So I would like to demonstrate more about invasive, which is cancer. Malignant spreads to other organs, that is metastasis. And non-invasive is the precancerous or non-cancerous, still in the original position, eventually develops into invasive breast cancer. So risk factors, there are two, which is modifiable factors and uncontrollable factors. So the factors that contribute to breast cancer is the gender, age, genetic risk factors, family history, and personal history of breast cancer. So here I would like to demonstrate more about family history and personal history of breast cancer. So let's talk about family history. So breast cancer risk is higher among women whose close blood relatives have this disease. For the personal history of breast cancer, a woman with cancer in one breast has a greater chance of getting a new cancer in the other breast or in another part of the same breast. So other factors that contribute to the breast cancers are race, ethnic background, dense breast tissue, certain benign, which is not cancerous, breast problems, menstrual periods, exposure to radiation early in life. So here I would like to demonstrate more about the menstrual period and exposure to radiation early in life. So for the menstrual period, women who begin periods early before age 12 or who even through the change of life, that is menopause, after the age of 55 have a slightly increased risk of breast cancer. And talking more about breast radiation early in life, women who have had radiation treatment to the chest area as a child or young adult have a greatly increased risk of breast cancer. And other factors that contribute to the breast cancers are not having children or having them later in life, certain kinds of birth control, using hormone therapy after menopause, not breastfeeding, alcohol, being overweight or obese. So there are factors other than that, like taking tobacco smoking. Smoking may increase the risk of breast cancer. And some studies has also mentioned that if the women who work at night have higher risk of breast cancer. So there are some factors that do not contribute to breast cancers are antiperspirant, or some of them who are using a body spray. So it's just a false belief that if you have a spray on your body that it doesn't cause you cancer, so you can use it. Bras, induced abortion. So if the patient has gone abortion, there's a false belief that she can be undergone through breast cancer. Also breast implants. So would like to talk about more about the malignant tumor that develops from cells in the breast. And it is the second most common cancer in Indian female. Secondly, it is leading cause of cancer death in women. So what exactly is the breast cancer? Cancer that develops from milk producing glands, that is called lobule, ducts or passages that drain milk from lobules to the nipple. Cancer can then spread to the underarm lymph nodes. And these lymph nodes are nothing but the small organs that filter out foreign substances in the body. So cancer can spread to the rest of the body from here. So what are the signs of breast cancer? So you can check for the lymph, change in the skin color or texture, clear of or body fluid that leaks out of the nipple, skin dumpling, change in how the nipple looks like, pulling in of the nipple. So talking more about the symptoms is like there is a painless lump in the breast, there is a change in breast size or shape, swelling in the armpit, nipple changes or discharge. Breast pain may also be a symptom as well. So who affected? 1 in 10 women will be diagnosed with breast cancer in their lifetime. Although breast cancer in men is rare, and estimated 1 man can be diagnosed with breast cancer with 138 female patients. So it is very rare in male bodies. So talking about the risk factors of developing cancer, it is uncontrollable and controllable. So uncontrollable, which we cannot control, that is positive family history of breast cancer, 1 or more blood relatives with breast or ovarian cancer, genetic predisposition, BRCA, that is a breast cancer gene 1 or 2, previous history of radiation to chest wall, early menarche, which is periods occurring before the age of 12, late menopause, that is after 50 years, as told by previous Doc Madani. So it was a very good lecture also that I was listening, and I could take some of the points from there to make my presentation more well. So coming to the controllable risk factors, it is obesity that we can control, older age at first live birth, never having children, and we can avoid alcohol. So these are the controllable factors. So coming to the screening, many young girls are unaware of the possibilities of developing breast cancer as a young adult. So talking about the screening, we can have a breast self-examination, clinical breast examination, mammogram, and ultrasound. So we can have a self-check. So what will you look for? You will look for painless lump in the breast, in the armpit, and changes in the breast size or shape. So nipple retraction or discharge, then changes in the skin texture such as dumpling, puckering, or skin that looks like orange peel. Breast pain may also be a symptom as well. So how will you check for the symptoms? So you can have a breast self-examination, examine your breast in the mirror with your arms down, up, and on your hips. So as shown in the diagram, you can have a self-breast examination. So you can also examine your breast in the shower while taking a bath. Place your left hand behind your head with the fingers of your right hand firmly pressed down using the smaller circular motions to examine the entire left breast. So feel your armpit as well. Also, you can palpate in lying down position. You can gently squeeze the nipple, checking for discharge, if there is any discharge from the nipple. Repeat the process, same on the right side. So this is how you can self-examine your breast. So rare signs to be aware of is, first is the inflammatory breast cancer is one of the most uncommon types of breast cancer that causes no distinct lump. It may cause the skin to become thick, red, and look pitted. The area will become warm or tender with a rash-like look. So this is how it actually looks like. So global outlook, breast cancer is the most common cancer among women worldwide. Hundreds of thousands of women each year are affected in countries at all levels of modernization. So I would like to extend my demo on modernization. What does it really mean? As there is an increased population of working women, there is a delay in first offspring, and due to which, they do not want to breastfeed just because they wanted to maintain the breast shape and size. So, they don't go through this process. So that's what I wanted to mention about modernization. Coming back to when to begin screening. So if you are at the age of 20 to 40 years, 3 yearly clinical breast examination should be performed. And if you are after age 40, then annual means yearly clinical breast examination, annual mammogram from the age of 35 years, breast awareness, as I already told, self-examination of the breast and the signs and symptoms. So that is breast awareness. Women with more than 25% are at risk of breast cancer. All of the above plus MRI yearly after 35 years. So there are some breast cancer myths like false belief. So there are researches made on the small false beliefs. So let's talk one by one about it. Only women with a family history of breast cancer are at risk. So this is a myth that most of the people believe. So roughly 70% of women diagnosed with breast cancer have no identifiable risk factors. So most breast lumps are cancerous. So 80% of the breast lumps are benign, which are non-cancerous. So benign, if you have a self-check of your breast examination, you can come to know at your early stage and you can diagnose it as early as possible. So breast cancer is non-curable. 90% of early stage breasts are curable. So if you undergo with the self-breast examination, so it can be cured, often with breast conserving treatments. Only women can get breast cancer. So for every 138 or 135 cases of breast cancer in women, one male is diagnosed. So small breast women have less chance of getting breast cancer. There is no connection between the size of your breast and your risk of getting breast cancer. So breast cancer always comes in the form of lump. So there is a saying, but as I told you before also that a lump is the one that brings the pain to the breast. So it may indicate the breast cancer, but women should be alert for other kinds of changes that may be the signs of cancer. Having a risk factor or even several mean you will definitely get the disease. So it's just increase the chances, not really that you will have a cancer. Your father's family history of breast cancer doesn't affect your risk as much as your mother's. So your father's family history of breast cancer is just as important as your mother's in understanding your risk factors. Okay. So wearing perseverant increases your risk of getting breast cancer. So as I already told you, you can use body spray and all that doesn't really cause breast cancer. And there is also one studies that has came across that caffeine causes breast cancer. So let me tell you everyone and make you aware that no causal connections have been found drinking caffeine and you getting breast cancer. So it's just a false belief. Annual mammograms expose you to so much radiations that they increase your risk of cancer. So while it's true that radiation is used in mammography, the amount is so small that any associated risks are tiny when compared to the huge preventive benefits repaired from the test. So things that we are looking up for is death rates from breast cancer have been declining since about 1990, in part to better due to screening and early detection, increased awareness, and continually improving treatments option. Should we try harder? Majority of the funding goes to science aimed at treating the disease. 5% goes to prevention efforts. So always stay aware that even with the lower risk of breast cancer, always stay aware of your own body. A breast self-exam is a checkup a woman does at home. Also, be aware about the best time to self-breast exam is about 3 to 5 days after your period starts. Your breasts are not as tender or lumpy at this time in your monthly cycle. If you have gone through menopause, do your exam on the same day every month. So prevention is self-check are the best way to avoid target results. Educate yourself, learn more about your body. And other sides of self-exam is current strategy is that once a month self-checks plays a small role in finding cancer. Therefore, it is important to know your breast and be aware of changes even after during self-checks. To be sure of accuracy, go over their self-checks technique with your doctor. And whom you should ask? Breast cancer is a sensitive subject for those who are new to finding it. So speaking with medical oncologists and private women's groups will help you encourage treatment and faster recovery. And what you should do? Reduce the weight, exercise, balanced diet, breastfeeding, avoid alcohol. So it's a take-home message for everyone today. Breast cancer can be cured if diagnosed early. Spread this message to your near and dear ones. October is Breast Cancer Awareness Month. And the first step towards change is awareness. The second step is acceptance. So as I have all made you aware of what is going to happen to our body. So let's take this be aware of our body and accept it as it is. Treat yourself and say goodbye to cancer, goodbye to fear. Thank you for listening to my presentation. I'm open to questions now.
Thank you, Dr. Kulkarni, for such an elaborate talk on signs and symptoms of breast cancer.
Thank you.
So
thank you for giving this opportunity to present myself on this platform at the day of Awareness Month.
Yes, thank you very much. Do we have any questions for Dr. Kulkarni? You can write it in the chat box if there are any questions. Now I would like to announce that our next speaker, Dr. Aishwarya Kesha, will not be able to present due to her family emergency. So we are taking a break till 2:30 p.m. Meanwhile, you can relax have some coffee, have some food, and we all shall be back at 2:30 p.m. Thank you.
Hello.
Hi, is the conference on break now?
Yeah, that is on break.
All right, thank you. I'm sorry, it's the time difference. I'm joining like from USA. I don't know what's the time difference from UK.
Yeah, now I think that will be like now in UK it's 12:56. And they will be back around 2 p.m. 2:30 p.m. So there is an hour and so time.
Yeah, I'll keep log in, and actually in USA it's like 7 a.m. in the morning.
Yeah, I understand. Yeah.
So the conference is 2 days. Tomorrow there will be like the second day, right?
I don't think so, because I think that will be just today. I am not sure, but I think that they say like this. We can ask when everybody is come back again.
Because I am like a speaker and I cannot like do the presentation today. So I was considering having the speaking or the presentation tomorrow morning.
Okay, so I will check it again and let you know.
I appreciate that. Thank you.
You are welcome.
Hello.
Hello.
Hi, this is Dr. Lubaba again. Actually, I'm not sure if I will be able to do the presentation. As I told you, the weather is becoming very, very bad, and this may affect the internet
Oh, okay. I
connection.
think you have to tell to the chairperson.
Yeah.
Yeah, I'm just one of the speakers, the keynote speakers, but I'm not the chairperson. So you just wait till they come on board, you know.
I mean, if you can help me, because I'm not sure if I cannot guarantee the internet.
Okay.
So just, yeah, if you can
Where
just
are you
pass
from? Which place are you from?
From USA.
Oh, okay. Oh, you're one of the keynote speakers, right? Okay.
Correct, yes.
Okay. Yeah, I will certainly let them know. So, yeah.
Yeah, I appreciate
Okay.
that. Thank you. Actually, there is like a heavy rain and wind. This may affect the internet connection. And yeah,
Okay. Okay, stay safe.
so
And yeah, I'll let them know.
I
Stay-
appreciate that. And if it is possible to give the presentation like tomorrow, then I will be grateful.
Okay, I'll let them know that also.
Thank you so much. And what's your name? And
I'm Dr. Jaipal. I'm Dr. Jaipal.
Nice
I'm
to
one of
meet
the
you.
keynote speakers, the 4 people, you know, and I think along with you, yeah. So I'm here in India, you know, from Chennai. So, so yeah, so okay, I will let them know.
Yeah, I appreciate that. And I will be like automatically disconnected because I see that the internet and the electricity is on and off. It's a heavy wind.
Oh, okay.
Yeah, this is like, oh, okay. Thank you so much. Thank you. And nice to talk to you.
Dr. Lubab, sorry.
Yeah, Dr. Ali,
Yes.
Dr. Lubab Qureshi just came on board, and she said that because of the winds and all the internet connections going haywire, now she's not, she cannot just give the talk.
Okay,
I
Dr.
apologize.
Lubab. Dr. Lubab.
Yes.
Okay, actually, we don't have any sessions tomorrow, so it's just one-day conference. So could you please try to prepare for the next hour, maybe starting from 2:30 p.m. London time. So you can present as the first speaker if you are prepared.
Yeah, the problem is that I cannot guarantee the internet because, as I mentioned, there is like a heavy rain and heavy wind, and all the local news are like saying that we have to stay home, get ready for the cut in the electricity.
I see.
I'm gonna keep myself connected, but I cannot guarantee that you can hear me.
Okay. Yeah, for now, everything is good. It seems okay.
Yeah,
Well,
that if it's good, then you can come and give your lecture.
Yeah, I cannot guarantee two things. So it's the voice and the camera. That's I cannot guarantee. So if I can like continue without the camera, that will be helpful. And if my voice cut at any point, then just let me know. Because
sure,
if
even now you can start within a few minutes. We have received messages from the committee that you can start even now. I mean, as long as you're fine. I mean, your presentation is ready, so you can present without camera even.
Oh, okay. I mean, my presentation is with you, right?
Not with me, maybe with them. I'm just actually a chairperson for the afternoon session. Yeah.
Okay, got it. And I'm sorry about this. Like, this is out of my control.
Like, it's fine, no problem. Yeah.
Yeah. Thank you
Stay
for
safe.
understanding. Thank you so much.
No worries.
Okay, take care. Be safe.
Thank you.
Okay. Are we starting or it'll take some more time?
I received message from them that they can invite everybody now, but I'm not sure whether it is confirmed or not.
Okay. I think
yeah,
they're all gone for some lunch or something.
Yeah,
Here
yeah.
it's evening, I think, but in London, I think it's still the lunchtime.
Yes, right. Yeah, we'll wait for them.
Okay.
Yeah, I will update
I just want
you
to try my
once.
share screen, whether it's working, you know. So I just share.
Yeah, but we can start within 8 minutes.
Yeah, but I just want to see whether it's working, you know.
Yep. Yeah, it's working. I can see your screen. Yep. So Dr. Jaipal, you present after Dr. Lobab if you don't have any problem. So Dr. Lobab Al-Quraishi will be the first presenter.
Are you still able to hear me? Hello?
Yeah, yes, Dr. Lobab. Yep, I can hear you.
Okay, all right, thank you.
So, okay, Dr. Lobab.
Yes.
We don't have your presentation. Can you share to the committee or your presentation? We haven't received your presentation yet.
I sent it by email.
Okay.
Let me try to.
Sure, I received message that they haven't received your presentation. So you can, if you're ready, you can start within 7 minutes from now.
Dr. Ali, do you mind if you let them know that I just forwarded again the presentation?
Okay, Dr. Lubab.
Yeah, can you hear me?
Yes, and they have received your presentation and they will share on behalf of you. So no worries if you want to start in a few minutes.
I appreciate that. Whenever you tell me to start, I will start. Thank you.
Sure. Yeah. So, all right. Okay. So within a minute, we are going to start the afternoon session. Hope you enjoyed your lunch and everybody hopefully ready within a minute to start the sessions. With this, I would like to invite our first keynote speaker for the afternoon session, Dr. Lubab Al-Quraishi from USA. Okay, Dr. Lubab, stage is yours.
Thank you so much. I appreciate that, but I don't see my presentation.
Yeah, has not. It's gonna be shared. Okay.
Yeah, I got it.
Yeah,
I got it. Yeah, thank you so much for this opportunity. My name is Lubab Al-Quraishi. I'm based in New Jersey, USA. I'm a surgical pathologist working at a private oncology lab, Paradigm Diagnostic Informatics. Today, I'm going to talk about part of my work at Paradigm Diagnostic Informatics, which is the PDL1. And I'm pretty sure all of you are familiar with the PDL1. I'm going to cover only the parts that I'm doing. I know there are a lot of clones of PDL1, but I'm going to focus on the clones that I'm doing myself. If you can share my presentation, please. And next slide, please. Yes, I just like a quick presentation. What is PDL1? It's actually the programmed F1. It was initially considered to be a molecule that regulates cell death, but it's now identified as a key immune checkpoint inhibitory receptor, which is expressed on activated tumor-specific CD4 helper and CD8 killer T lymphocytes. Therapeutic antibody-mediated blockade of PD-1 or one of its ligands, PDL1, removes the suppressive effect of PDL1 on cytotoxic T cells with restoration of host immune against the tumor cells. For some patients, this treatment approach can control or eliminate advanced malignant neoplasm, including metastatic melanoma, which has fostered intense research interest. To summarize basically this slide, what we are doing, the pathologists are basically telling the oncologist who are the patients who are eligible for PDL1 and who are not, and if this is a good candidate for the immunotherapy or not. Next slide, please. Programmed death ligand 1 immunohistochemistry is accepted as a predictive biomarker for selection of immune checkpoints inhibitors. So we are assessing the PDL1 with a chief test by immunohistochemistry. And this is a very beneficial because it takes less than 24 hours to give the result for the oncologist and to let them know if the patient is a good candidate for the immunotherapy or not. Next, please. What are the FDA approval for PDL1? I'm going to summarize this. This includes the non-small cell lung cancer. The small cell lung cancers are not FDA approved. The cervical squamous cell carcinoma of the cervix, urothelial carcinoma, and head and neck squamous cell carcinoma, in addition to the gastric or gastroesophageal adenocarcinoma and the triple negative breast cancer. Next, please. Now I'm going to talk about the how do we calculate the PD-L1? This is the common question that I realized as a feedback from the oncologist, from some of my colleague pathologists. So first of all, for the PD-L1, in order for you to estimate the PD-L1, you have to know the primary origin of the tumor. So let us start with the lung. For the lung, we have to estimate the tumor proportion score. Next, please. So the interpretation, so when we do the staining for PD-L1, PD-L1 is going to stain the tumor cells, some of the tumor cells, inflammatory cells, including histiocytes, granulocytes, lymphocytes, and some of the endothelial cells. So for the tumor cells, we are going to, for the lung specifically, we are going to calculate the tumor proportion score. Next. I'm sorry, I'm going a little bit quickly because I'm afraid I'm going to lose the connection with you. So
no problem, Doctor.
Actually, we have two scores. Thank you. We have two scores, the combined score and the tumor proportion score. The combined proportional score is according to the equation, if you can see it. The combined proportional score is the number of PD-L1 positive cells. What do I mean by cells? It means both the tumor cells and the inflammatory cells divided by the total number of PD-L1 positive and negative tumor cells. When I say tumor cells, I mean only the viable. So you should eliminate the necrotic dead cells and then you multiply it by 100. So it's actually the combined scores, it's mainly about both the inflammatory cells and the tumor cells. So how do we calculate this? First of all, we have to look at the H&E and we have to make sure that at least we have a minimum of 100 viable tumor cells. This is an important because if you have less than 100 viable tumor cells, let's say the oncologist or sent you a cell block or fine needle aspirate, for those challenging samples, the tumor cells most likely are less than 100. So in these situation, we do not reject the sample, we do the interpretation, but we put a disclaimer in our report saying that the tumor cells are less than 100, the viable tumor cells are less than 100, so this sample is limited and the interpretation should be done with caution. That what we are trying to say to the oncologist, that the interpretation is not reliable. Next, please. So for the lung cancer, after I assess that I have more than 100 viable tumor cells, I start my calculation. The calculation is by screening the whole slides and the whole areas. At the 40x, I do my calculation. I estimate the number of the tumor cells that are positive for the PD-L1, and they should be viable tumor cells. And then after finishing, I take the average. How many tumor cells are positive? And then I divide it by the total number of the viable tumor cells, and then I multiply it by 100. And then we apply the cutoff. Next, please. So for the cutoff, as you see in the slide, the TPS either less than 1%. When it is less than 1%, that is to say less than 1% of the tumor cells are positive for the PD-L1. This is, we call it negative, and this patient is not eligible or not a good candidate for the immunotherapy. And then we have the second one, the TPS, the tumor proportion score between 1 to 49%. Anything between 1 to 49%, the decision is up to the oncologist. I talked to a lot of oncologists, and most of them, they consider the treatment if the TPS is 20% and above. And then we have the highly eligible candidate where the TPS, the tumor proportion score, is more or equal to 50%. These patients are highly eligible. So Most of these patients are the advanced stage of lung cancer, the non-small cell lung cancer. What's the benefit of the immunotherapy? If they are a good candidate for the immunotherapy, the survival rate is going to be increased up to 18 months. Next, please. For the cervical carcinoma, as I mentioned to you, that the PD-L1 interpretation, it depends on the primary sites. Here we are not estimating or not calculating the tumor proportion score. Here we are calculating the combined proportion score. So what is the combined proportion score? It's the combination of both the tumor and the inflammatory cells. And according to the equation, it's equal to the number of PD-L1 positive cells, tumor viable cells, and inflammatory cells divided by the total number of the viable tumor cells, which should be at least 100 and above, multiplied by 100. And the cutoff, actually, in my slide, according to the references, it says 1, but most of the oncologists, they start the treatment if we give them a combined score of 10. So anything 10 and above, they consider it as a good candidate for the treatment. Next, please. And till now, I'm just talking about the Keytruda, which is the 22/3C PD-L1 clone. We have, I forgot to mention, I'm sorry, that there are several clones of PD-L1 in the lab that I'm working in. We are using the Optivo, the 28.8, the Keytruda 23C, and the SP142 for the triple negative breast cancer. We already talked about this equation, how to calculate the combined proportional score. Next. So this is an example of cervical carcinoma, and you can see the brownish discoloration, which is either membranous or granular cytoplasmic. This is what we accept for the combined score, either membranous for the tumor cells, and for the inflammatory cells, even the granular cytoplasm, in addition to the membranous expression, is considered. So for this case, if I'm looking at just like this field, I can tell, but of course I have to take the average, but I can tell the combined score is above 1. Next, please. For the urothelial carcinoma, the advanced urothelial carcinoma, the criteria for the Keytruda is the same as cervical squamous cell carcinoma. It's the same. We are dealing with the combined proportion score, and the cutoff is 10. Anything below 10 is not eligible for the treatment, and anything above 10 is eligible. Next, please. So you can tell here from this image, I cannot, to be honest, 100% tell you if these are tumor cells or inflammatory cells. It looks like to me as mixed. So I take the expression in both the tumor cells and the inflammatory cells in at least 100 viable tumor cells, and then I take the average in different fields, and then I divide it on the total number of the viable tumor cells multiplied by 100. So if the combined score is above 10, so this is a good candidate of advanced urothelial carcinoma for the PD-L1 Keytruda treatment. Next, please. For the head and neck squamous cell carcinoma, any head and neck squamous cell carcinoma, we calculate the combined score. So if you want to memorize it, because it's really difficult to track and the guidelines continue to update and change every year, I memorize it like this: the gastroesophageal, head and neck, squamous cell carcinoma of the cervix, urothelial. These 4, we usually estimate the combined proportion score, not the tumor proportion score. And the cutoff for the head and neck squamous cell carcinoma is 1. So anything below 1 is considered non-eligible for the Keytruda treatment. Anything above 1 is eligible. Next, please. This is again the criterion. And as you see, I put the combined score above 20. I believe you will not find this in the book, but this is how the oncologist, I mean, even if we deliver the report to them saying the combined score is above 1, they will call back saying, I want the exact number. So if we tell them it is 10 and above, then this patient is eligible. If we tell them it's 20 and above, this is highly, that's the exact candidate for the Keytruda treatment. Next, please. As I mentioned, for the gastric and the gastroesophageal junction adenocarcinoma, this is important because for the esophageal adenocarcinoma, we treated as the gastric, but for the esophageal squamous cell carcinoma, there is no FDA approval. So the FDA is approved for the gastroesophageal junction tumor, whether gastric or esophageal adenocarcinoma. Here, as well as we calculate the combined score, which is both the inflammatory and the tumor cells. And we follow the same equation, and the cutoff is 1, either above 1. And as I mentioned again, we, my connection with the oncologist, they prefer to get the exact number. So I usually elevate the cutoff to 10. I mentioned in the disclaimer that the cutoff is 1, but for this, for example, this exact patient, the expression is more than 10 because I know they are going to treat this patient if we put the number 10. So for, as I mentioned, for the esophageal squamous cell carcinoma, there is no FDA approval and the criteria is different. Next, please. This is again the cutoff for the gastroesophageal adenocarcinoma. Next. This is a gastric adenocarcinoma, and you can see that the tumor is negative while the inflammatory cells are positive. So if I calculate the combined proportion score, definitely it will be more than 1. And this patient is eligible for the treatment. Next, please. For the breast cancer, we divided them into 2 categories, the triple negative breast cancer, which is FDA approved for the Keytruda, and FDA approved for the other clone of PD-L1, which is called the SP142. In this slide, I'm talking about the Keytruda only. So if you have a triple negative breast cancer, ER/PR negative, then we have to do the PD-L1, either the Keytruda or the SP142. For the Keytruda, the cutoff of the combined score, not the tumor proportion score, is 10. So anything above 10 is eligible for the treatment. Anything below 10 is not eligible. Next, please. That's the cutoff that I already mentioned. Next, please. The SP142 is another clone of PD-L1. It is FDA approved for lung cancer, the non-small advanced lung cancer, and for the urothelial carcinoma, and in addition to the triple negative breast cancer. In the place where I work, we use it only for the triple negative breast cancer. And if you ask me why, because the Keytruda is the alternative and the oncologists prefer the Keytruda over the SP142 for the lung and the urothelial carcinoma. But for the triple negative breast cancer, SP142 is the superior. And next, please, to show how we are going to calculate the SP142. Next, please. The interpretation of the SP142 is the same for any kind of tumor. The cutoff is more than or equal to 1% of immune cell. So it's everything is about the immune cell. And what immune cell? The immune cells that are in the close vicinity of the tumor. That is to say, if I have like a slide and I'm looking at the tumor and I found two immune cells that are away from the tumor, I'm going to discard these immune cells. I have to look for immune cells that are invading the tumor cells, reacting against the tumor cells. For the tumor cells, if you see in my slide, I put the word ignore. So do not consider the tumor cells when you are interpreting the SP142. Your goal is only the inflammatory cell. Next, please. So, I'm sorry. So for the triple negative breast cancer, where I use it mostly for the triple negative breast cancer, as I mentioned, the cutoff is 1 immune cell. Anything below is considered as negative, and the treatment, as a feedback from the oncologist, is highly effective. And how do we calculate it? It's the same concept. By at the 40x, you screen all the areas, and then you see how many immune cells are expressed in each area, and then you take the average. And again, we need 100 viable tumor cells, and the immune cells, they should be in the close vicinity of the tumor cells to be considered in the interpretation. Next, please. I'm not going to repeat these concepts because, as I mentioned, the interpretation for all of these tumors is the same, with the same cutoff, which is 1% immune cell. Next, please. So look at this slide. This is a case of triple negative breast cancer, where most of the cells are stained are the tumor cells. Our goal is the immune cells, and I confirm this again and again, and I mention it again. Don't be misled by the tumor cells. It's always the immune cell. Next, please. This is just a quiz for all of you if you would like to go over it maybe later. I don't like to put myself and you under stress, but I'm going to tell you that if you would like to go over it, like let's read it and see how much did you get from my presentation. And I'm sorry, I know all of you are pathologists, and this is just like for my student, to be honest. So which of the following statements regarding PD-L1 SP142 correct? A, in advanced metastatic triple negative breast cancer, scoring is determined by using combined positive score with a positive score cutoff more than 1. Is that true or false? What do you think? This is basically false because we are not estimating the combined score. As I mentioned, we should eliminate the tumor cells. And as you know, the combined score is the combination of both the immune cell and the tumor cell. That's why it's called combined. B, in triple negative breast cancer, while the clinical specimen includes cytology specimen, this is wrong. As I mentioned to you, the challenging specimen in PD-L1, generally speaking, are the cytology specimen, the FNA, small, very limited biopsy, cell blood. It's very challenging. C, in a triple negative breast cancer, scoring is only evaluated in the immune cell component, which is the right answer. D, it is the FDA-approved campaign diagnostic assay for pembrolizumab. I don't know how to pronounce it, to be honest, but this is wrong. The pembrolizumab is the Keytruda. E, result of other PD-L1 IC assay 22C3, which is wrong. We know that the clone is in the question, which is the SP142. Next, please. The third clone, we mentioned the SP142, we mentioned the Keytruda, which is the 23C, and now we are talking about the 28.8, which is called the Optical. The Optical, it is highly used, and there was a lot of research work on the unresectable melanoma, the advanced melanoma. Although we can use it in non-small cell lung cancer, head and neck, renal cell carcinoma, Hodgkin lymphoma. And I'm sorry, I wrote Hodgkin like 2 parts, it should be 1 part. So next, please. So basically the Optivo, you can say it is the same as the tumor proportion score, but the cutoff is different. So we are interpreting the tumor cells only with a cutoff of 1%. So if there is a 1% in above cell that is positive for the Optivo in the melanoma, this is considered as a good candidate for the treatment with the Optivo. Next. This is just for your information, general calculation. And you can see in the table, 1% of the tumor cells. And I didn't talk about the staining. What staining is considered to be positive? Weak partial membranous staining is considered to be positive. Complete membranous staining, whether weak, moderate, or strong. So any staining, whether partial, complete, weak, moderate, or severe staining should be calculated. Next. This is a picture showing multiple clones of PD-L1, and ones that we are using in our lab is the SP142, the upper right corner, 22C3, the lower right corner, 28.8, the lower left corner, and we use the SP263, but the oncologists, they didn't like it because the calculation is a bit complicated and the cutoff is not clear. So it has been withdrawn from the market. And I think this is the end of the lecture. Next, please. Next. Thank you so much, and thank you for helping me to deliver this lecture because I was afraid to lose the connection because of the bad weather. Thank you so much.
Thank you so much, Dr. Lobab. Thank you for the nice presentation in the first place, and thanks for giving us your time a bit of because we are a bit of I think ahead of time, and you had actually great cooperation with us. I think there has been one question in the chat box.
Yes.
Yeah, could you please read that? And
absolutely, sure. Let me just
thank you.
And negative for PD-L1 benefit from the That's a very, very good question, and I appreciate that you delivered this question. Actually, that's true, and I'm in contact with one of the pharmaceutical company, and one of the clinical trials is that they are trying to understand why some of the patients, although the PD-L1 is negative, but are still getting benefit from the treatment. This is still under investigation. And me, myself, I'm tracking this and trying to find the answer. The same thing for the oncologist. And whenever I get like any update.
Okay, Dr. Lobab. Hello. Dr. Lobab, we don't have to. Yeah, disconnected, I think.
Did I lose connection?
Yeah, just now we can hear your voice. Yeah, just for a few seconds.
Did you hear my answer, or should I repeat it?
Just end of your
tell in one line if possible.
Yeah. Well,
yeah. Actually, what I was trying to say that these are just still like under investigation. We don't know really the answer, and me myself am trying to keep myself posted to get the updates, and I'll keep you posted. Thank you so much. Thank you, Dr.
Okay, thank you so much, Dr. Labab. Thanks for the wonderful talk. Interesting topic. Yeah. If we don't have any further questions from the audience, I would like to invite our next speaker. So I think we...
Dr. Jayapal.
Yeah, with Dr. Pramlata Jayapal from India. Yep, okay. Dr. Jayapal. Yep, the stage is yours now.
I'll just share the screen.
Sure.
Can you see the screen?
Yes, now we can see that.
Okay. So actually, this is. Can you hear me?
Yes, we can. Can you just make it bigger?
Oh, okay.
Yes, zoom it. Yeah.
Okay.
At the bottom, you just.
Is this
near
okay?
Zoom. No, near zoom in and zoom out. You just press that button. I mean, at the right corner. We need to maximize it.
Yeah, I just maximized it.
No.
Zoom.
At the bottom, Doctor. There is one. We can see the whole slide in one actually screen.
Yeah, for me it's coming in the top actually. It says.
No, bottom near zoom in and zoom out.
Zoom in and zoom out.
Bottom right corner.
No, this is just a slide that is. I don't know. This is just a slide. I think I can't see the zoom.
We cannot see the whole slide. I mean, we have to see one slide at a time. So you at the bottom, you can see at the bottom near zoom in and zoom out. Just there is one rectangular shape sign, so you can just push that, and then you will see the whole slide. I mean, the first slide will be the whole screen.
No, it says new stop video, participants chat, new share, pause share, annotate, remote control. That's all that I can see here. Can't see zoom in and zoom out, you know. I don't know, it's coming like this. So
okay, actually I cannot see your screen also.
Okay, yeah, I don't know where the thing is.
Okay, yeah, can you just go on, please? Can you start, please?
Okay, I'll just make it bigger. Is this better?
Yeah, better, but still we don't have your. Yeah, you just go on, please.
Okay. Okay, actually, this is a very different kind of presentation. And I think that many of you all speakers gave some great presentation of a very specific topic and focused on a very specific area of research. But I'm just going to take you into a journey that started a few decades ago, starting from my PhD degree. And I've just titled it, so it might be a little poetic. And I think at this time of the evening, it's a little. I hope it's a little relaxing too, and a little different. So actually, the thing is that I've titled this as "The Road Less Traveled," because I don't wish anybody that they would go on this less traveled road, but it's just the circumstances that came along our way that made us have to go through this path, you know. So this journey actually begins with my PhD thesis, which was on the study of epidermal tumorigenesis in the two-step carcinogenic process, you know. So those were the days when the two-step carcinogenic process in animal models was very indicative of the two steps, you know, that is initiation and then tumor promotion. That is, there are some substances that will initiate a tumor, and there are other substances like the tumor promoter, which will promote this initiated cells. So back then, they used to use carcinogenic materials such as DMBA, dimethylbenzoanthracene, in a dose, in a sub-threshold dose that would just initiate a cell, initiate the mouse, but no visible tumor was formed until a tumor promoter such as TPA was added to it. So this was a very convenient model to delineate these two steps. And I'm just going to show how this journey that began a few decades ago is relevant even today when we are talking about cancer initiating cells and stem cell cancer stem cell population and metastasis and relapse, So that was the journey that we had begun. And I just want to also motivate young people, to be very differentiative and very innovative in their approach to understand this cancer problem, so that we don't stay disconnected, and we connect with the other fields as well. So actually this we started, so at that time, when we started, we started with this mouse model, and that was the first time that I had started my work with animals, and it was really scary. I still remember, even to kill a mouse, I used to be so scared those days, and it was, we used to do it by cervical dislocation after we had added the carcinogen and the tumor promoter, and the mice would just jump up and just run around the corridors, and all us students would be pursuing it. So those were those days, when even handling mouse was not so easy. But with time, we learned how to handle them, and soon, we were just conversing with each other and killing mice as if it was just any other, just any other thing, And so just that was what so I'm just going to, since this is a pathology conference, I'm just going to focus a little bit on pathology in the early days, So this was the tumor carcinoma that we got from squamous cells. And you can see how it has infiltrated into the dermis area, So the mouse skin is a very convenient model, You have the epidermis, which is made of the basal cells, the suprabasal cells, and the keratinine cells. And back then, we used to use black and white, and of course the pictures were colorful, but this was like those were like the black and white days, And you can see that the carcinoma, how the infiltration has occurred, So this was after DMBA and TPA, the initiator and the TPA. And then here was the papilloma, just looking like a mushroom, and with well-defined contours, and very much different from the papilloma. So this was the very nice model by which we could differentiate, papilloma and carcinomas, And the question that always lingered was that, could we find something, some marker, that would pinpoint, yes, these are the initiated cells, and these initiated cells are the ones that will form the tumor, And then we could, at a very early stage, begin treatment, but this was a model that we found, and what I just want to impress is this is like 3 time points, 18 and 36 and 48 hours, when after initiation of the mouse skin, and then we added the TPA, and it's not very hyperplastic as just adding TPA, and you can see that this thing is not much difference from adding mesrine, which is not a potent promoter of initiated cells like TPA, So mesrine is not a very initiated, it's a second stage promoter, And this is almost, it looks a little similar till we did an autoradiography, and then you can see the difference. Then the first panel, what we found was that when you add TPA, there's a large number of cells with nuclei, basal cells. So these are the basal cells that are very rapidly synthesizing DNA and inducing the fixation of the initiated cells, you know. And whereas that is not evident in the mesarine treated skin, you know, which explains why TPA is a very potent, you know, promoter of initiated cells. So if you just add DMBA and you don't add TPA, you will never get tumors, you know, and it's only after you add TPA, after you add TPA to DMBA that you get tumors. And this, just wanted to quickly share, this is just a small portion of my work that I had done with, and you know, this is what we saw when we did a comparison of carcinomas. So in the third lane, you can see carcinomas. Then we did the adjoining skin, and then the papilloma and papilloma and papilloma. And there's a big difference, actually. I don't know whether you can really see this, but there are these two bands, you know, these two bands right here. That is the 50K and 52K, which is present in the adjoining cell, but it is totally absent in all of the carcinomas, you know. It's a big difference. So the adjoining skin is very hyperplastic, you know, it has received the same treatment as the tumors, but it's only the certain cells that have been clonally expanded to produce the tumor. So this was a great finding that we found there. Then when you delineate it to different degrees, you know, like adjoining skin or you know, various levels of differentiation and classification, you are going to find a far more important data, you know, than to just massively collect data, you know. Of course, it is all discretionary, you know. You have to apply different criteria to different types of cancers, you know. So after that, of course, after my PhD, you know, like the rest of the gang, because I did my PhD from the Cancer Research Institute in Mumbai in India, which is now ATREC, and it is located in Navi Mumbai. So at that time, you know, after you finish PhD, all of us, you know, went to do our PhD in the US, you know. And that time, technology prowess was the, you know, was the great impetus, you know. So technology prowess, you know. So we were doing a whole lot of, you know, in situ site mutagenesis, promoter bashing, as they used to call those days, you know. That means you cut the promoter into different regions and you try to find which is the important region. And all of this is done in vitro, you know. And I was looking at several transcription factors like the TAT protein and CREB and P300 and NRF2 and CJU. So this was all being done in the in vitro cell cycle, cell lines, you know, and we were totally oblivious to its role in different disease conditions, you know. And very elegant experiments were done, but unfortunately, you know, we were so caught up in the technological wave that was riding at that time that you know, how we could correlate to the progression of a disease, how we correlate to the finding a treatment or coming up with some solutions was a little far-fetched at that time, you know. But anyway, we got a lot of exposure to different technological modalities, you know. So we had a very good handle of what technology can do, you know. But we found that, you know, it had really gone overboard, you know. And at that time, when all of my colleagues had returned to India, I too had returned to my homeland, that is in Chennai, India, you know. And Chennai, as you know, is a very beautiful place, you know. You must have heard about Mahabalipuram near the beach, you know. It's a beautiful, you know, temple cave of the Chola dynasty, you know. And also you must have heard of the Thiruvaruval. It's a beautiful statue that stands near Kanyakumari, near the tip of Tamil Nadu, you know. And Chennai at that time, and that Thiruvaruvar statue stands near the Vivekananda rock, you know. And that was a site of great learning, you know. And Tamilians at that time were known for their great learning capacity, you know. The goddess of learning reigned, and you had Rajaji, who really expounded on many topics, and you had Ramanujan and some very great, fantastic Tamilians, you know. And so when I came back, I had this notion and this to really go into study of a disease, you know. And since I came from a cancer background, you know, since I came from studying cancer process and carcinogenesis, I wanted to really go into translation medicine, you know. And at that time, as soon as I came, so we had this vision, you know, to translate our technological empowerment into the study of a disease. But you know, I had some idea of my homeland, you know, that I could fit the entire, you know, vision into that, and I was not knowing what differences had occurred during, you know, after because I actually I'm a Maharashtrian and I grew up in Maharashtra, you know, but my ancestors and my family, everybody is from Tamil, you know, we are actually basically Tamilians. So when I returned home to my homeland, I felt I didn't know the changes that had occurred, you know, and I really thought that I could, you know, really do achieve some goals in a very short time, you know. But it's been a long road, and what happened was that I set up two biotech labs in Chennai, and I was taking lectures in molecular biology, biotechnology, immunology, and really giving a good foundations of fundamentals, you know. If your fundamentals are strong, your natural inclination to study disease, you know, the progression and what is the cause for it, what is the diagnosis, what are the biomarkers, how do you assess patient recovery and response, you know, all that will fit in, you know. So that's why I chose to have these two biotech labs, and then I started looking at breast cancer. So at that time, I was writing to a lot of people in the US and all around the world also, and getting to know breast cancer, you know, because I really came from a basic science background, and I was getting into breast cancer. But I had a different kind of approach, you know. People were talking about going from, you know, from bench to the clinics, you know, and I was going the other way, you know, from the clinics to the bench and back to the clinic, you know, because I didn't know anything about the clinical picture at all. And so I started learning about, you know, what is lobular, how many % of people suffer from lobular cancer, how many % suffer from invasive ductal carcinomas, you know, the 70% suffer from invasive ductal carcinomas, whereas only about 20% with lobular. And also looking at what is the reasons, you know, because of the entire complete stromal involvement too, you know, there's a lot of involvement of the stroma in the progression of the disease, you know. So we were doing a whole lot of looking at like introspection, as I would say it. And then it hit us hard that when we were looking at all the data that was there, that we, you know, scientists all over the world had churned out in breast cancer alone over 2,000 inhibitors, you know, and while only 4 or 5 are effective in the clinic. So there was a whole gamut of inhibitors, you know, growth factor receptors, growth factors, tyrosine kinase receptors, non-tyrosine kinase receptors, adhesion molecules, matrix melanoproteases, cell adhesion proteins, and so many subgroups, you know, and almost like 2,000 of PI3 kinases and MAP kinases, and there were just a whole bunch of inhibitors, you know, but you know, everybody was just churning out, you know, like a lot of integrin receptors and a whole bunch, almost covering all the molecules in the human cell, I would say, and all sitting in their ivory tower and just turning it out, and therefore it had made the clinical picture look very difficult. We still were only at the early stage. Early treatment was still the sure shot for the breast cancer patient. Once the metastasis had set in, or once it was advanced, every chance of recurrence could occur and relapse could occur. And back then, almost 2 decades ago, metastasis and recurrence, as the as the modalities that have a high rate of mortality, was not recognized to that region. We were looking at cell lines, we were looking at promoter bashing, mutagenesis, next generation sequencing, and all of it. But we were not looking at metastasis as such. That it was claiming a lot of lives. Recurrence and relapse was claiming a lot of lives. And so we started looking at that, and we were looking, actually trying to find out what is the preclinical mouse model. And at that time, I got 2 USA collaborators, and that time the picture was not very clear, which mouse model very closely depicts or copies the human disease scenario, which mouse cell. So MCF7, in xenograft, that MCF7 is a non-invasive cell, and yet there are plenty of papers. People just use MCF7 and do a whole bunch of studies, but it's a non-invasive cell, and it's not going to give the right picture for metastatic and recurrent cells. Of course, MDA MB231 was an important cell line, and that gave metastasis. And then we were looking at orthotropic, where you implant the tumor cell into the mammary gland itself, and then wait for it to progress and metastasize, to the different organs, and then study the process. And in some cases, people were using the tail vein, because they were not getting a proper mammary transplant. And then the tail vein injection, you could go directly, to the different visceral organs, through the bloodstream. And that did not really seem to us as a very potent model. But anyway, we got 2 collaborators, and at that time we also had applied for a DoD grant, but that was like $500 million. And though they were good collaborators, they said that they could not release all of the money, and we were wanting some money to be released, because in India at that time we were not having a very good animal house. And I think they started building an animal house, NCLAs and all that at that time. And then I moved on, that so this at that time also we were looking at the cancer stem cells, because that study was also coming through. So we were looking both at PI3 kinase, Herceptin inhibitors, PI3 kinase, SARC kinase, MAP kinases, all using one common clinical model, so that we could delineate the differences in which kind of a histological picture, or in which kind of a tumor would one inhibitor work better than the other. And of course, there were a lot of genetically modified animals that were there, but that picture was totally not mimicking the human picture, the human mammary tumor picture, because like MYC, when MYC was expressed, transgenic mice that expressed MYC, you got a histological picture that was totally different from that you see in a when you use a cell line, or when you use patient-derived xenografts, and patient-derived xenografts also has now picked up speed. And so that so at that time we were also looking at 2 aspects, and we also started looking at the cancer stem cells, because data was coming in on cancer stem cells, how cancer stem cells could be the rogue cell in metastasis, So the question was not completely answered whether the cancer stem cell is the only stem cell that causes metastasis, or are there other stem cells besides the cancer stem cells that cause metastasis, And because even when you're trying out all these different inhibitors, and we had this, because of the tremendous amount of publications, that was confusing the field, we had taken a stand not to publish, but go for this therapeutics, to produce some therapeutics and to go for patenting and go for a startup company, So that was the vision that we had, and cancer stem cells was slowly data was coming in, but not much data on patient samples. There was some work that was done in Germany which showed that CD24 and CD44 plus and 24 minus and ALDH1 plus were stem cells, that pinpointed cancer stem cells that caused metastasis, but still there were even mesenchymal stem cells and different markers for stem cells, but slowly it seemed that cancer stem cells was an important milestone, because instead of going through all these so many inhibitors, and trying to find which would be the right inhibitor to for the right kind of patient, if we could knock off the cancer stem cells, then that would be a good beginning. So I'll just go through some aspects, that on breast cancer treatments, that we focused on, that understanding what is a breast cancer treatment, the 5 classes, of course, everybody knows, but of course, we molecular biologists, we think of the 5 classes, whereas the surgeon and the physician and the radiologist, they are looking at, locally advanced tumors or large operable tumors or unresectable tumors. And slowly we had to gain all that knowledge, from doctors, talking to doctors, going to clinics and trying to understand what is this progression of this disease and what are the treatment modalities, So at that time, it was surgery, chemotherapy, radiation and hormonal therapy. As you know, tamoxifen was given to estrogen positive patients, and in patients who are postmenopausal, the aromatase inhibitors were used, like fulvestrant and other aromatase inhibitors, and radiation was also given, and then targeted therapy was slowly making its way, So targeted therapy was being used quite often, especially Herceptin, and Herceptin was known to really impact, and there was data that indicated that even with regards to relapse and recurrence, Herceptin in ER positive and HER2 positive and ER negative and HER2 positive was quite effective, But the Herceptin resistance also started making its face known, So actually, when you look at breast tumor classification, you have to go through histopathology, That is benign tumor, adenocarcinomas, ductal carcinomas, lobal carcinomas, medullary, squamous cell, invasive ductal carcinomas, invasive lobular carcinoma, inflammatory ductal carcinomas, and of course the tumor grade, grade 1, grade 2, and grade 3, and the TMN classification, stage 1, stage 2, stage 3, and 4, where the tumor size and the involvement of the node, lymph nodes, how many lymph nodes are getting involved, what is the tumor size, and whether it was metastatic, And of course, you had to also take in whether, in certain cases, they had chest wall involvement, where the tumor stuck to the chest wall, and that was also criteria that had to be taken in, And of course, we had the molecular subtypes, that was luminal A, luminal B, and the HER2 enriched and triple negative A and triple negative B. So there was some data that we were looking at, where we found that patients who were had stage 1 and grade 3 tumors, they had far more aggressive tumors than say stage 2 and grade 1, So tumor grading was also important. And so in this age of AI and deep learning, we must also factor this data in, because it is an important modality along with artificial intelligence. You have to have histopathology, tumor grade, tumor staging, and the estrogen ER positive, HER2 positive, or PR positive, negative. That also has an important role to play. So this is the cancer metastasis model that we were looking at, and that was a normal tissue inside to cancer, and then you have the metastatic cancer and aggressive metastasis. Whereas here you have another model where the normal tissue is there, and you have a precancerous cell, and then you have DNA alterations that leads to the clonal expansion of these precancerous cells, and then metastasis occurs. So metastasis that is already de novo, already present in the early stages, aggressive form of metastatic cell already there, and there is a lot of evidence that very small, in stage 1, 2 mm tumors, they are quite metastatic, and therefore we require a lot of tools, to this. And I think some important in India itself, you had OncoStem that had come up with a tool where that early stage tumors, in ER positive patients, whether they required chemotherapy or radiation or not, they could determine by a set of markers. Most of them were stem cell markers, that were being used. And so that was that. And so here we were, and so we were actually looking at two aspects. One was the Herceptin, tyrosine kinase receptors and biomarkers, cancer stem cells, and the other was innovative therapeutics, that we could have, that we would find to be first in preclinical models to be effective. So actually in the tyrosine kinase, you have the 4 ligands, HER1, HER2, HER3, and HER4, and HER1 is the EGFR receptor, and HER2 is the orphan receptor, which has a strong tyrosine kinase activity, but it's an orphan receptor because it doesn't have any ligand. So it has to dimerize with HER3, when HER3 doesn't have strong tyrosine kinase activity as HER2. And but HER3 has almost 6 binding sites for PI3 kinase, So PI3 kinase can also be activated to because of this HER2, HER3. And you can have different kinds of interaction. You can have EGFR, HER1 and HER2 and HER2 and HER3, HER1 and HER3. And all of this was going to be important to block, because otherwise very soon after 1 year, many patients were getting, where is this? Okay, so many patients were getting resistant to it, So we were looking at transubab, lapatinib, and pertuzumab, and trying to find out markers that would indicate that. And since we were interested in the startup company, and much of this data cannot be given at this point, so we found that in literature, when you look at literature, the vast amount of publication and literature, the Herceptin resistance can occur to many reasons. Truncated HER2, PTEN mutation, P3 kinases, expression of adhesion molecules, growth factor receptors, HER2, EGFR, HER2, PI3 kinase, MAP kinase, STAR kinase, matrix metalloproteases, several driver and passenger mutagenesis, So there are more than 30 factors that will lead to Herceptin receptors. So, it's a very difficult, proponent to actually address how to make your targeted therapy more targeted and more beneficial to the patient, and therefore, now due to clinical trials and due to observational and interventional methods, we are that there is some headway in that area, So we were looking at, we were using a strategy by which we could find out, that how to pick out the patients who would benefit more from, say, Herceptin and any of the drugs that were being used, cisplatin or doxorubicin or lapatinib, and which, how to use pertuzumab too, So that was that, and then of course this cancer stem cells that I was talking about, that just cancer initiating cells, that has really it's an important modality, and I think that once they are targeted, that we would really be able to bring down relapse and recurrence and um, increase the survival rate of patients, So you have your tumors, and then there's this unspecific therapy, surgery, radiation, and chemotherapy, and you have a tumor shrinkage, but then relapse occurs due to this conventional therapy, So we were looking at some photothermal ablation using nanoparticles that would target the cancer stem cells and allow the tumor shrinkage and tumor regression, So so then we were also seeing, the stromal involvement that occurs. And then if you look at the many drug trials that are used, Cleopatra and Atlas and Hercules drug trials, using Herceptin, advanced stage and in metastatic you're not getting more than 15 months, maximum you get 15 months of increasing the patient survival rate, and not beyond it, So we were really in innovative therapeutics. We said, we have to cross that line, because so many drugs were coming into the market, which were giving something like, 2 months increase in survival rate, 2-3 months increase in survival rate, to 6 months increase in survival rate, and not anything substantial, and so this is just for how stromal cells are also involved. So some of these drug trials also looked at the infiltrating cells into tumors, like epithelial cells and the stromal involvement that were there, So no longer can you look at a cell in a cell line, and say, that is going to be your model for adding, you can start it as a first step to test any cytotoxic drug, but definitely you got to go more deeper study into preclinical models, and also, into the which find ways to and strategies to address the question of which patients will respond to which therapy, and so this was the time in 2012 when our work actually, it achieved some critical mass, because we had started synthesizing these nanoparticles, and we were in collaboration with the Indian Institute of Science in Bangalore, and this was the synthesis that we were doing, and we had got our ethical clearances, which is a very difficult thing in India, and it's a big thing in India, that nobody wants to give you ethical clearance, now they just want your work, and then they want to shove you off, but getting ethical clearances, and then we got permission to use the animal house, we got permission to use the patient samples, and the collaboration with the Indian Institute of Science, and we had the scientific committee which approved our work, and we got new PhD students, and all the doctoral committee and every other regulatory thing was achieved, and our work had actually achieved critical mass, and we were really going ahead with this, and just at that time, this bureaucracy just swept in, and that was the time I just understood that, my homeland had not been what I had thought. It had gone the other way, that, this, there was a lot of this, at the non-scientific people, like in commerce and maths or political science and other kind of history and this, they sat in inquiry committees that evaluated work. They didn't know one thing about cancer. They didn't know one thing about, breast cancer, what is cancer therapy and what is the patient response, nothing. They just don't know anything about anything scientific, but they stood in the way of our collaboration with the Indian Institute of Science. And that was a very terrible time for me in 2012, that this kind of a bureaucracy came, and even the scientific community couldn't do anything. It was like 3 people or 4 people who controlled the whole thing, and it was something that was unanticipated, and I didn't know the culture at that time, so I just was caught unaware of it, and that was, and because we were invested in it, a lot of hard work and so many years input had gone into it, and I didn't know about it. Otherwise, I would have run to these people, and as they say in Chennai, putting the ice, that is, you butter the person, and you have to take care of it. I didn't know that, and otherwise I would have done that, and I would have spent more time with these people and less time with the scientific group and the scientific community. And I was really caught unaware, and therefore, because of all the investment that we had done, we had to litigate, and because of this litigation, it was really great that in 2015, the Supreme Court of India, came forward in a landmark judgment, that, deemed universities, they are answerable. They are accountable, because education and scientific research is an important arm of the university. And such corruption and such other things, cannot be tolerated, so that was a big win for us. But still, in terms of money, we still were not getting. So actually, I don't know whether I should pat myself in the back that I indeed became the first woman in India to win a landmark judgment in 2015. But still, it was a lot of work, and it was the money still, we had to find. And therefore, I founded the Dr. Jayapal Cancer Foundation Trust. But you see, I don't come from a business background, my family comes from education, we all came through the grit and grind and the dust of education, and if it wasn't for education, we would be nowhere, and of course, the whole, I think the whole landscape of Chennai had changed, where wealth, acquiring wealth was the fundamental reason, and you just did it, irrespective of everything, and I was not knowing about that culture, but slowly I did know. But still, I feel that we were strong enough, and so this became a platform to contact other cancer hospitals and units, but it still, this is a still a work in progress, so we are still very much committed to have the startup. Had things gone well in 2012, by now, we would be 100 crore or 150 crore startup, with breast cancer therapeutics and with this biomarker work, but we have got a provisional patent, and we are looking to get some more patents, and it's going to take more work, and so 2012 also was the year when the government of India, it started BIRAC, so in BIRAC, the government of India started an interface between university and industry, so that was an interface where if you wanted your work to have an application in industry, or you wanted to apply your work either in patients or in any form of startup, then there was this provision. So there were a lot of labs that came up through this initiative called BIRAC from Government of India in 2012, and where you can come out of the university and have have your own lab till you find investors and money and all the rest of it to get your product moving, you know. So yes, we are in a work of progress, and many things have changed. You know, I thought I will this thing, you know, this matter would be sorted out, and it was just you know, this thing, you know. So I don't want to tell you know, youngsters anything. I mean, don't be startled by any of this, but I just want to this, you know, that we must be aware, you know, of all the other items also, you know, that you know, like they say, maska polish karna padta hai, you know, means like you got to you know, put the butter on the persons. They are totally unconnected with the work. You got to take care of it and know of that aspect also, to get ahead, you know, and have a strong group, you know. So of course, that dream is, you know, I have to, it will be a work that will be passed on to young people, you know, and but we are, we want to start this work, and it will be started soon. So that's all I can say. And so here, this was the photograph we used to use when we did our PhD, you know, the woods are lovely, dark and deep. I have promises to keep and miles to go. And so I'm saying that substitute the I with the we, you know, that we have promises to keep and miles to go, you know. And it's going to be an interesting journey for the youngsters also, you know, that, you know, if you can apply your pathology to you know, patient study, patient treatment, you know, definitely you have a strong this in hand, you know. You have something very valuable in your hand, you know. You have a strong gem in your hand, and that's all that I can say right now. And let's see how it goes now. So thank you very much. I hope I did not put all of you all to sleep, and looking forward to taking your questions.
Thank you so much, Doctor. Thanks for the wonderful talk, and actually your journey was quite interesting. So yeah, I would like to invite our audience if there's any question for.
Was it? I hope it was.
Hello. Yeah. Any question for Dr. Pramlata Jayapal?
Yeah, I can take any question.
You can send your questions always in the chat box, okay, anytime.
Yeah.
So if we cannot answer your question now, let's say we will discuss later on, maybe within half an hour or after the next speaker.
Okay.
Okay, thank you so much, Doctor, again. Thanks for the wonderful presentation. And for now, I would like to...
Thank you so much. For
no worries, thank you. For now, I would like to invite our next speaker, Mrs. Sorry. Yeah, Miss Ayça Nur Demir from Turkey.
Hello, Dr. Ali.
Ayça.
Hello, Dr. Ali. Can you hear me?
Yes, yes, yes. Could you please share your presentation? Thank you.
Sure. I can share my screen. Okay. Can you see my screen?
Yes, yes, we can.
Okay. Hello, my name is Ayça Nur Demir. I'm studying in Afyonkarahisar Health Sciences University, Faculty of Medicine. I'm 6th grade student. My teacher is Nuray Varol. She's from Ankara, and she works as a genetic specialist at Gazi University. Since my mentor is working on cancer, we decided to go through breast cancer. We looked at the studies carried out in the world. In general, we had the opportunity to examine new drugs. Now, what is the breast cancer? A breast cancer is a type of the cancer that starts in breast cells. After lung cancer, it's the most common type of cancer in the world. It's reported that 1 out of every 8 women will get breast cancer at a certain time in their life. Although it's also seen in men, female cases are 100 times more common than male cases. Its incidence in North American and European countries is higher than in other parts of the world, because this increase is attributed to the modern Western lifestyle. There are many types of breast. The most common ductal carcinoma starts in the milk ducts of the breast. When breast cancer spreads outside the breast, lymphatic nodules in the armpit are the most common sites of spread. Cancer cells can spread to other lymph nodes of the breast, bone, liver, and lung. Every woman has a risk of developing breast cancer. The risk factors for most women who actually develop breast cancer are unknown. Now, when we look at breast cancer diagnosis, early detection methods in breast cancer vary according to the risk factors of the patient. Age comes first among these factors. Although it can be seen at young age, this risk increases in older age groups. For this reason, the precautions to be taken for early diagnosis in advanced age groups are different from those in early age groups. First, 20-year-olds should be examining themselves at a certain time of each month. During this control is to investigate whether there is a difference in the breast tissue. If swelling or a lump-like change is detected, a physician should be consulted immediately. Even if no change is detected, they should be examined by a physician once every 2 years. Second, 4-year-olds are required to be examined by a physician once a year in addition to their own periodic examination. In addition, mammograms are every year or at least 2 years apart. Third, for 50-year-old women should continue their periodic self-examination and a doctor's examination once a year and have a mammogram every year. Now, treatment methods and new drug trials. First, surgical options. Breast conserving surgery is performed in which the tumor is removed with a clean, safe surgical margin, and axillary dissection is performed only in the presence of metastasis with sentinel lymph node sampling. If safe surgery will not be possible in larger tumors and a cosmetically acceptable breast is not possible, a surgical method called mastectomy, in which the entire breast is removed, is applied. In sometime patients with advanced breast cancer, preoperative neoadjuvant therapy, local and systemic control is provided by oncology with medical treatment, and then surgery is performed. Second, chemotherapy is one of the most commonly used drug treatment methods in breast cancer. This treatment, cancerous cells are tried to be destroyed with the help of chemical drugs. Thirdly, hormonal therapy is a treatment method applied in the form of suppression of hormones that are effective in the growth and proliferation of cancer cells. It's a form of treatment used in hormone-sensitive tumors. Now, researchers have proven for several years that CDK enzymes have a significant effect on increasing the growth of breast cancer cells. Some substances in the body effective enzymes promoting the proliferation of cancer cells. Cancer cells then spread uncontrollably. It's thought that a new active ingredient called abemaciclib can prevent this activation. Cancer patients take the drug by mouth as a tablet twice a day to treat this new enzyme inhibitor, abemaciclib. Chemotherapy is not needed during treatment. Although the drug has not yet received FDA approval, studies have shown that treatment is quite successful. For this reason, the FDA is working to speed up the approval process. Now, PARP inhibitors. It was developed as a group of drugs targeting cancers caused by BRCA mutations. This drug has shown promise in clinical trials of treatments for breast, ovarian, and prostate cancer that have spread and are resistant to other treatments. Larger studies are underway to understand whether this drug can also be used in patients without BRCA mutations. Targeted therapies. These therapies are a new group of drugs that take advantage of gene change, especially in cancer-causing cells. Drug targeting HER2. There are currently a number of drug targets, such as trastuzumab, pertuzumab, adutrastuzumab, emtansalapatinib. Other drugs are development and testing. Anti-angiogenesis drugs. For cancer to process, blood vessels need to develop and feed these cancer cells. This process is called angiogenesis. Prognosis can be predicted by looking at angiogenesis in breast cancer samples. Some studies have found that vessels that are surrounded by new, small blood vessels tend to be more aggressive. More research is needed to confirm this. First, drugs. Bevacizumab, or other name Avastin, is an example of an anti-angiogenesis drug. Although it has been seen that it is not very useful in the treatment of advanced breast cancer, it can still be said that this method is useful in the treatment of breast cancer. A number of other anti-angiogenesis drugs are also being tested in clinical trials. Other target therapy drugs, everolimus, or other name Afinitor, is a target therapy drug that helps hormone therapy work better. It's approved for use in combination with adenosine in the advanced receptor breast in postmenopausal women. It's also being studied for use with other hormone therapy drugs and in the treatment of early-stage breast cancer. One study revealed that letrozole and everolimus performed better than letrozole alone in reducing breast tumor preoperatively. Everolimus is also being studied in combination with chemotherapy and the target drug trastuzumab. Studies are underway on other drugs such as everolimus. Capecitabine is an orally available antimetabolic chemotherapy, a prodrug converted to fluorouracil. Multiple trials have explored adding capecitabine to standard chemotherapy regimens with the goal of improving existing options. One approach has given capecitabine extra support over standard anthracycline, alkylator, and taxane-based chemotherapy regimens. In triple-negative breast cancer, the addition of capecitabine with standard chemotherapy has been shown to reduce the risk of recurrence, but significantly increase treatment toxicity without consistent improvements in overall survival. Now, when we look at integrins, integrins are cell adhesion receptors, which are typically transmembrane glycoproteins that connect to the extracellular matrix. One of the major events in integrin signaling is integrin binding to extracellular ligands. Another event is distinct signaling that gathers chemical signals from outside of the cell and transmits the signal upon cell adhesion to the inside of the cell. In normal breast tissue, integrins function as checkpoints to monitor effects on cell proliferation, while in cancer tissue, these functions altered. The exosomal integrins promote the growth of metastatic cells. Expression of certain integrins is associated with increased metastasis and decreased prognosis in cancer. Targeted specific integrins and integrin binding proteins may provide new therapeutic approach for breast cancer therapies. Progranulin as a multifunctional growth factor is overexpressed in multiple tumors. After being treated with progranulin, the expression of M2 markers and programmed dead ligands of macrophage increased significantly. Signal transducer and activator of transcription tree, signaling pathway inhibitor, static significantly inhibited the expression of programmed death ligand 1 and M2 related markers introduced by progranulin. Now looking at the results, it seems that progranulin supports M2 polarization and PD-L1 expression by activating the STAT3 signaling pathway. Studies on progranulin continue. There are also different articles in PubMed or Google Scholar. Bisphosphonates used to reduce the risk of fracture and strengthen bones in weakened bones due to metastatic breast cancer. These include pamidronate and zoledronic acid. Some studies have indicated that zoledronic acid may help other systemic therapies, such as hormone therapy and chemo work better. In a study in which women were treated with chemo before surgery, tumors in women who received zoledronic acid in combination with chemo showed faster shrinkage than tumors in women treated with chemo alone. While some studies suggest that this practice reduces the risk of cancer recurrence, some disagree. Results of one study have linked the use of these drugs in combination with adjuvant chemo with an increased risk of breast cancer recurrence in younger women. Overall, the available data do not support the use of bisphosphonates as standard therapy for early stage breast cancer. Other drug, denosumab. Denosumab can also be used to stretch bone weakened by metastatic breast cancer and reduce the risk of fractures. It's still being studied whether in use together with adjuvant treatments will give more effective results. And then vitamin D. A new study has shown that women with early stage breast cancer who are deficient in vitamin D have a higher risk of the cancer recurring in a distant part of their body and have a worse outlook. More research is needed to support this finding. It's not yet clear whether taking vitamin D supplements is also beneficial. You can still ask your doctor to determine your vitamin D level to see if it's in the healthy range. Now, results. When we look at the studies in general, it seems that the old methods are gradually abound in cancer treatments, and a transition is made towards more drug or molecular level treatment. So, as these studies continue, we predict that personalized treatments in cancer treatment will become a widespread in the future. Thank you very much for listening to me. This is my references. I stopped my share.
Okay, thank you very much, Aisha, for the wonderful talk and presentation. That's quite interesting topic. If there is any question from the audience or any comments. I think there is no chat box for now. Okay. Thanks again, Aisha.
Thank you so much
for your time and the presentation. All right. Without further ado, I would like to invite our next speaker, Dr. Sailuja Maharjan from Nepal. Dr. Sailuja, the stage is yours.
Thank you. Am I audible?
Yes, you are.
And is my screen visible?
Yes, yes. Yeah, you can go on, please.
Give warm greetings to all the delegates and speakers. My name is Dr. Sailuza Moharjan, and I am from Nepal. And at first, I would like to thank the UCG conference for giving me this opportunity to deliver a speech. And my topic is an original research article, and the title of my talk is Role of FNAC in Breast Lesions and its correlation with histopathology. So as we all know that fine needle aspiration cytology is very important in diagnosis of palpable lesions of breast, as it is simple, easy, reliable, rapid, and minimally invasive technique. It has minimal complication and it obviates the need for surgery. The benefits of FNAC lie in that it is highly accurate in experienced hand, cost effective, and it may be used for small lesions not amenable to core biopsy, and it is considered complementary to core biopsy practice. Okay.
Doctor, can you just make it bigger? You know how to maximize the slides. Right, bottom right corner. So near zoom out. Okay.
Is it okay now?
Yeah, but just make it bigger. I mean, just push that button. Right bottom corner near a minus sign.
Okay, is it okay?
Yes.
Okay, so there is a significant role of FNAC in preoperative diagnosis of breast lesions, and FNAC in conjunction with clinical assessment and radiological evaluation is known as triple assessment, which has a very high index of diagnostic accuracy. So over the years, the use of core needle biopsy has increased for various reasons, and there has been a recent paradigm shift towards performing core needle biopsy than FNAC. However, there are not any proper demarcation between these two techniques. A recent study that was conducted by Varma et al. In Acta Cytologica 2021 mentioned that core needle biopsy cannot replace FNAC, and both are taken complementary to each other. And in resource limited settings, and in developing country like ours, Nepal, with the help of triple assessment, judicious use of FNAC is preferable, especially in palpable lesions of breast. So the aims and objective of this study is to evaluate the role of FNAC in breast lump and to correlate it with histopathology wherever possible, and to determine the sensitivity, specificity, positive predictive value, negative predictive value of FNAC in diagnosis of breast lesions. So this is a retrospective study that was conducted in Department of Pathology, BNB Hospital, over the duration of 3 years. And all the patients who had FNAC of breast lump during this time period were included in the study. And those cases who were already diagnosed as breast cancer, or those on treatment, or with history of recurrent breast carcinoma were excluded from this study. So FNAC was performed by a pathologist, and the smears were fixed in alcohol and air dried and stained with Giemsa and Papanicolaou stain, and then screened. And they were categorized as 5 categories: C1, C2, C3, C4, and C5. C1 categorized as inadequate, in which the smears are acellular or too sparsely cellular, or where there is presence of blood only. And in inadequate cases, biopsy evaluation was advised. And C2 cases were categorized as benign, characterized by the presence of three-dimensional clusters, cohesive clusters of cells, benign-looking flat monolayer sheets of cells with well-spaced cells, and features in which features of malignancy were not seen. And in benign cases, the entities included are fibroadenoma, fibrocystic change, benign cystic lesions, and inflammatory pathologies like granulomatous mastitis, suppurative mastitis, breast abscess, etc. And C3 was categorized as atypia, in which the findings were predominantly of benign lesions, but some features of atypia are also present, like nuclear crowding, nuclear overlapping, anisokaryosis. And in C3 cases also, biopsy evaluation was advised. And C4 was categorized as suspicious, in which there were features suggestive of malignancy, but falling short in terms of number to definitely categorize as malignant. And biopsy was advised in C4 cases for confirmation. And finally, C5 case, in which there are unequivocal features of malignancy and was categorized as malignant. So the results of the study are the total number of patients were 90. Among them, 88 were female patients and 2 were male patients. And breast lesions was more common in 4th decade of life. Left-sided breast lesion was more common than right-sided lesions. And majority of the breast lesions were located in upper and outer quadrant of left breast. So among the 90 patients, tissue biopsy was done in 49 cases, giving a biopsy rate of 54.4%. And the most common cytological diagnosis was benign, comprising of 55% of the total cases, followed by malignant, comprising of 39% of total cases. So under C1 category, there were 2 cases, and while evaluating on biopsy, both were found to be benign. In C2 category, the most common lesion was fibroadenoma, which was commonly seen in age group 21 to 30 years. The other entities in benign category included found in this study are granulomatous mastitis, suppurative mastitis, fibrocystic disease, benign breast disease, benign cystic disease, and gynecomastia. So in C3 cases, atypical cases, there were 2 cases, and in suspicious for malignancy, there were 2 cases. And since C3 and C4 are the gray zones in the diagnosis of breast lesions on FNAC, biopsy was advised in all these cases, and all these cases turned out to be malignant on biopsy. Next is C5 cases, that is malignant cases. So in malignant category, there was no false positive case. That is, all the cases that were diagnosed as malignant on FNAC were found to be malignant on biopsy as well. And there was a single case of male breast carcinoma. So among the various malignant lesions, the most common histological subtype was invasive breast carcinoma, no special type, comprising of majority of the malignant lesions. And other histological types encountered were mixed IBC, NST, and micropapillary carcinoma, IBC, NST with medullary pattern, metaplastic carcinoma, micropapillary carcinoma, mixed IBC, NST, and cribriform carcinoma, mucinous carcinoma, lobular carcinoma, and non-Hodgkin lymphoma. So in this study, there were 3 cases with cytohistological discrepancy, and I will be talking about these cases in detail. So the first case was a 50-year-old female with a small lump in left breast, and there was history of breast cancer in the first degree relative, which is a risk factor for breast cancer. And radiology revealed uniform hyperechoic lesion measuring 1.5 by 1 centimeter with regular margins, with features suggestive of benign lesion. So FNAC showed smears showing clusters and sheets of cells which appeared uniform with bland nuclear chromatin, and there were no features of malignancy. So on FNAC, this case was categorized as C2 benign. Now, in view of family history of cancer in the patient, core needle biopsy was done to completely rule out malignancy, and it revealed tumor cells arranged in sheets and cords, exhibiting mild degree of nuclear pleomorphism with round to oval nuclei and moderate amount of cytoplasm. Indian file pattern was also seen in some areas. So the overall histological features were suggestive of lobular carcinoma. So what we have to keep in our mind is that in cases in low-grade tumors like globular carcinoma, the diagnosis may be missed on FNAC, and biopsy evaluation must be done in suspicious cases. So second case is a 20-year-old female with a tender breast lump for 2 months. There were no other systemic complaints in this patient, and radiology was done, which revealed a round breast cyst measuring 5 by 4 centimeter with hypoechoic content, well-defined border, and posterior acoustic enhancement with features suggestive of breast abscess. Now, previous FNAC was already done in this patient at other center, and it was diagnosed as breast abscess. And the patient was given antibiotics for some duration, but the lesion did not regress after the course of treatment. So repeat FNAC was done in our center, and repeat FNAC revealed 0.5 ml blood mixed pus-like material. And the smear showed predominantly of neutrophil and its debris in a dirty background. And we did a culture and sensitivity to rule out if there is presence of any bacterial infection, but there was no growth. And special stain for acid-fast bacilli was also done in keeping in mind the possibility of tuberculosis in background of endemicity in developing country like ours, Nepal. But the special stain for acid-fast bacilli was negative. So the overall features were suggestive of suppurative mastitis, that is category C2 benign. But however, the patient had a long history of lump and it did not regress after a course of antibiotics. So biopsy evaluation was advised. And then we received a lumpectomy specimen, and it measured approximately 6 by 6 centimeter. And the cut surface shows a cavity-like lesion containing friable, somewhat pus-like material with a thickened wall. So on microscopy, it showed large areas of necrosis and suppuration. Also seen were sheets of monotonous atypical cells infiltrating the breast parenchyma. Going further on high power, the tumor cells exhibited high NC ratio, vesicular chromatin, and brisk mitotic activity. So the overall histomorphological features were suggestive of non-Hodgkin lymphoma of breast. Now, since breast is a very uncommon site for lymphoma, detailed clinical evaluation and other radiological evaluation of the patient was done to see if there is presence of any other lesion or lump in any other parts of the body, but it did not reveal any significant finding. Furthermore, immunohistochemistry was done, and it revealed the CD3 positivity, CD7 positivity, whereas cytokeratin was negative, CD10 negative, CD20, CD15, CD138 were negative. Additionally, CD30 was done, which revealed diffuse positivity in tumor cells, and ALK staining was also done, and it revealed diffuse positivity in the tumor cells. So finally, this case was diagnosed as anaplastic large cell lymphoma, ALK positive, with primary involvement of breast. Now talking about lymphomas of breast, breast is a very uncommon site of lymphoma, which is attributed to paucity of lymphoid tissue in breast. And the most common postulated hypothesis is that it is originated from intramammary lymph nodes, and it comprises of 2.2% of all extranodal lymphomas and less than 0.6% of breast malignancies. So lymphomas of breast are classified as primary breast lymphoma and secondary breast lymphoma. In primary breast lymphoma, breast is the principal site of involvement with absence of previously identified extramammary lymphoma, whereas in secondary breast secondary breast lymphoma, there is breast involvement in a previously diagnosed case of lymphoma. So the prospective diagnosis in case of breast lymphomas may be difficult as they share similar clinical and imaging features with benign entities or carcinomas of breast. And talking about the behavior of primary breast lymphoma, it is aggressive and it has poor outcome as compared to extranodal lymphomas of alternate site. So the majority of lymphomas of breast are of B cell phenotype, the most common subtype being diffuse large B cell lymphoma. And our case, anaplastic large cell lymphoma, which is a subtype of T cell, which is a category of T cell type, is extremely rare in breast. And majority of cases of anaplastic large cell lymphomas of breast are associated with breast implant, and anaplastic large cell lymphoma arising de novo without association with breast implants are very rare, and there are approximately 27 cases reported in literature. And our case also falls under this category of anaplastic large cell lymphoma arising de novo, and it was without association with breast implant. So we went back to the literature and we did some study, and we found out that neutrophil-rich anaplastic large cell lymphoma can mimic abscess on cytology and may possess diagnostic confusion. Similarly, other studies also reported the same. Hefferman et al. Reported a case of nodal anaplastic large cell lymphoma, which was misdiagnosed as abscessified metastatic carcinoma on cytology. Likewise, other studies also have mentioned that suppurative anaplastic large cell lymphoma can cytologically mimic a wide spectrum of conditions ranging from benign entities like lymphadenitis to malignant conditions like anaplastic carcinoma, melanoma, or Hodgkin lymphoma. Therefore, anaplastic large cell lymphoma should also be kept in differential diagnosis of abscessified lesions while performing FNAC, even though it is a very rarely encountered condition. So my third case is a 40-year-old female with history of lump in left breast for 1 month, measuring 3 by 3 centimeter. And in this patient, there was a finding of nipple retraction, due to which there was a clinical suspicion of malignancy. And radiology revealed areas of thickening of breast parenchyma with patchy increase in echogenicity and clustered tiny cyst suggestive of benign fibrocystic lesion. So FNAC was performed and it showed smears showing cyst macrophages engulfing debris, and also benign clusters of ductal epithelial cells with uniform nuclei and bland chromatin were also seen. There's tightly cohesive clusters of ductal epithelial cells. And in this case, features of malignancy were not seen, so this was categorized as C2, fibrocystic lesion. And since there was a clinical suspicion of malignancy, coordinatal biopsy was done, but it did not reveal any features of malignancy. Therefore, excisional biopsy was planned in this patient in order to completely exclude malignancy. So we received a lumpectomy specimen showing multiple cysts, some containing clear material and some filled with hemorrhagic material. And adjacent to these cystic lesions were some solid areas which were gray-white in color and were firm in consistency. And this is the biopsy showing multiple cysts corresponding to the cystic areas in the gross specimen, multiple cystic lesions. And adjacent to these cystic areas were seen small atypical glands infiltrating into the stroma. So on high power, these are the cystic areas, and there is invasion of the tumor into the fatty tissue. So this case was diagnosed as invasive carcinoma of no special type. So on FNAC, this case was diagnosed as benign lesion, but on excisional biopsy, it turned out to be malignant, and misinterpretation in this case on FNAC could be attributed to cystic lesion of the breast, and breast lesions with many overlapping features may be one of the reasons for false negativity on FNAC. So the general problems encountered in diagnosing breast lesions in FNAC are small size of the tumor, cystic nature of the lesion, histologic tumors with low nuclear grades like invasive lobular carcinoma, tubular carcinoma, and papillary carcinoma, inadequate sampling, hypocellularity due to desmoplastic reaction could be other reasons. So the potential pitfalls of FNAC should not be overlooked while diagnosing breast lesions, and whenever there is discrepancy or discordance between the triple assessment, like if the features are not matching with FNAC and clinical or radiological picture, then biopsy evaluation must be done in order to rule out malignancy. So now coming part to the statistical analysis, our study found the sensitivity of FNAC in diagnosing breast lesions 90.6%, specificity of 100%, positive predictive value of 100%, and negative predictive value of 78.57%. And according to literature, the sensitivity of FNAC in breast lesions, it ranges from 80 to 98%, and specificity may be reached up to 100%. A meta-analytical study conducted by Axel et al. Noted 72 to 90% diagnostic accuracy of FNAC in breast lesions. So the conclusions of my talk are: FNAC helps to maximize the preoperative diagnosis, and it guides the clinicians in planning accurate management. However, the potential pitfall of FNAC must always be considered, and it always has to be correlated with clinical and radiological findings. And whenever there is discrepancy between the FNAC finding and clinical or radiological picture, in such cases, biopsy evaluation is mandatory to completely rule out malignancy. So these are my references. And I'd like to thank all of you for a patient listening. Thank you.
Thank you so much, Dr. Sailuja. It was very practical and interesting topic, actually, and I really enjoyed. Yeah, before we move on to the next speaker, any question from Dr. Sailuja? Any question about this interesting topic and discussions? And also your cases also were quite interesting, lymphoma of the breast. Yeah, as you said, it's not that common, it's totally uncommon, I can say. And yeah, thanks for sharing with us. Thank you.
Thank you so much.
All right, there is, I think there is no more question for now. Okay, if you have any question, please post into your chat box and we will discuss later. Okay, thank you so much again, Doctor. And with that, we move on to our last speaker for today, our keynote speaker. I'm honored to introduce our keynote speaker, Dr. Michael Retzky from USA. Dr. Retzky, the stage is yours.
Yes, thank you. Is my slide visible?
Not yet, Doctor. Can you please share with us, share a screen? Use the share screen button. Yes. Yeah, just please, yeah, maximize. Yeah. Just could you please zoom in? At the bottom right corner, there is just close to the minus sign. Just there is one rectangular shape. Just push that button. Left side of the minus.
Okay.
Yes, yes. Yeah, perfect.
Okay, thank you. It's a pleasure to speak to this organization. I certainly appreciate being invited. I am an honorary associate professor at University College London, and discussion is going to be on breast cancer and the perioperative window. This project was funded by NIH and a Komen Foundation, no other conflicts to report. A book was published in 1962 by Thomas Kuhn. This came to be very influential. Kuhn discussed the structure of scientific revolutions. And he said there are 4 phases. First, when a science is just starting out, it's called a pre-paradigmic phase. There's not a lot of consensus among the researchers, and they're doing a lot of experiments. This could go on for a while. And then when it gets to the point where people seem to agree on mechanisms and methods to do research, and they start publishing books and educating our new scientists. This is called normal science, and they say this is when you have a paradigm. Once in a while, though, this could go on for a while. That normal science could go on for a very long time, but occasionally you run across an anomalous situation. You find data that don't agree with the normal science, and this is called a crisis. And a crisis could result in going back up to normal science. If someone is smarter than the other guys and can figure out a way to say that this crisis is not really an anomaly, we can explain it with normal science if you look at it in such and such a way. Then you go back to normal science. But if no one comes up with a mechanism that can say the anomaly is normal science, then you have to talk about a paradigm shift. This is called a scientific revolution. I edited a book that was published in 2017 by Springer Nature. I am editor and Romano Demichelli is co-editor. This ended up being shown on the front page of the New York Times as an advertisement, and I was so impressed I took a picture of it. The foreword to that book was written by Robert Weinberg, who is a well-known cancer biologist. He's at MIT. He said two things that he said that I think are really important. He thinks this is going to be unlikely to be accepted by many in the clinical oncology community. And the idea is that primary tumor resection does not always provide a benefit to the breast cancer patient in terms of long-term survival. The other thing that Weinberg said, that this is likely to profoundly influence future surgical oncology and post-surgical treatment protocols. And I must say that this is coming to be true. This project started a long time ago. In 1993, I was attending a breast cancer conference in Europe. I forgot what city it was. And out in the hallway outside there, I saw a poster being presented by Romano Demichelli discussing relapse data on 1,173 early stage breast cancer patients with long-term follow-up treated by surgery only. I'll show you this in much more detail later on, but just as an overview, there was a sharp peak at about 18 months, a minimum at about 50 months after surgery, and then it started up again. There was a broad peak, shallow peak at about 60 or 70 months, with a long tail extending to over 10 years. And this general pattern has now been identified in over 21 databases from US, Europe, and Asia. There are more than 21, but I stopped counting them. And then I walked into the lecture hall, And Michael Baum was speaking. Michael Baum was a surgeon from UK, and he was speaking about a bimodal relapse pattern in data from UK. So the three of us got together afterwards and decided that they were talking about the same thing. And Dema Kelly and I decided to collaborate. These are the Milan data. This is from data from Milan provided by Dema Kelly. And these are for the postmenopausal patients. Relapse hazard is the probability of a patient entering a window 3 months wide in this case, enters that window relapse free, and then undergoes a relapse during that period. And you can see that in about 18 months, there seems to be a sharp peak, and then this broad peak at 60, 70 months, going out to over 10 years. That small peak at about 100 months is, we're not sure what that is. It could be important, it could be noise. At any rate, that was for the postmenopausal patients. And then if you look at the next figure, it talks about the premenopausal patients. And there's a difference in that that first peak seems to show some structure. There is a 10-month, a sharp 10-month event and a sharp 30-month event. We still see that 50, 60-month late relapse and that shallow noise at about 100-month. Dema Kelly and I decided to collaborate. Well, these are the Milan data in the more traditional disease-free survival format. At time zero, all patients are disease-free. By definition, only patients who are disease-free are considered in this report. And there is a sharp drop-off in those patients who are disease-free. And it sort of reaches a plateau at about 5 years, and then it starts to fall off again. And that's not a anomaly. That actually is in the data. That ski jump area at about 5 years corresponds to that difference between those early relapses and the later relapses. Something is going on here. And this was presented in the New England Journal. Gianna Bonadonna, the late Bonadonna, who died some 10 years ago, was the clinician. He was the first person to use multiple drugs in adjuvant therapy in breast cancer and is very well known in the world of breast cancer. Pinuccia Valagusa has been the database manager since this project started. And I have a lot of confidence in these data, and much of that is due to the presence of Pinuccia Valagusa. She is a very competent project manager, data manager. This was another figure from Bernie Fisher et al. Fisher was a very important, he died about a couple years ago at age 100. He was very important in the world of breast cancer. He was the first person to use a lumpectomy, and a well-known person. He always had done good work. He was always a plenary speaker at a conference. And these are data from Fisher. These are patients also without chemotherapy, just surgery. And these are disease-free survival grouped by the number of nodes positive. Nodes positive is the most important prognostic factor for breast cancer patients. The curve on the top is for 0 node population, and the curve on the bottom is for more than 12 nodes. And this is very important. Let me show you what I see in that top curve in the 0 node case. First of all, just simply removing the tumor, removing the primary tumor, cures 80% of the patients. They will not relapse. They will live a long time until something else happens. But as far as breast cancer, 80% are cured by simple removal of the primary tumor. But of the 20% that relapse, about 10% of them relapse in that first 3-year period. And then there's a series of few years where nothing happens. There are no relapses. And then it starts up again at about 70 months with a small gradual change until about 10 years. Looking down at the lowest curve, the smallest curve, the curve on the bottom, more than 12 nodes positive. First of all, removing the primary tumor, eventually all the patients relapse and they all die. It's a very poor prognosis, especially before the use of chemotherapy, which is when these patients were treated. But of those 100 patients that relapse, about 80%, maybe 85% of them relapse in that same 3-year period. You can draw a line from the 0 node patients straight down at 3 years to the more than 12 node patients. And something very similar is happening to those two groups, but it's far more numerically significant for the more than 12 node patients. Again, for the more than 12 node patients is a period with very few relapses until about 70 months. Then it starts up again, it drops off until about 96 months when we get to the point where all the patients have relapsed. This is telling us a story. We'll come back to this information later on. In general, I could say that this double peaked relapse pattern was not explainable with the continuous growth model that for a very long time has guided breast cancer early detection and therapy. Kelly and I decided to collaborate. And my background is not in biology, in medicine, into cancer research in about 1982. So for 40 years, so I've been doing this research. The specialty is computer simulation to study tumor growth. I became very proficient at using computer simulation in studying. We'll see more of that later on. At any rate, this triangle describes our collaboration. We decided, Kelly and I decided, was that I was going to use computer simulation to study the Milan data, the Adenoma data, and use a model that Kelly proposed. Kelly is an MD PhD. He did a lot of work studying animal model growth before he became a physician. And he said the simplest growth model, the simplest growth model is a single cell starts off in a dormant state. It can remain that way for a variable length of time. Once it starts to divide, it gets to be an avascular micrometastasis, about 1 millimeter in size, and it can stay at that state for a variable period of time. Angiogenesis kicks in, and it gets to be a detectable size tumor, and the lethal size are collaboration. This is the result of computer simulation of the Milan data using Kelly's model. This was the premenopausal patients. First of all, that relapse event at about 10 months corresponds to dormant avascular metastases that are in genesis by the something happens at or about to induce, and they show up as relapses 10 months after surgery. At 30-month peaks, seeing cancer cells that were induced into division by something about the time of surgery, and they undergo angio on a stochastic basis, showed up as relapses at about 30 months. And then those relapses starting at 50, 60 months, that's more or less the natural history of the disease. It's not, those relapses are not surgery, apparently not synchronized to surgery. And that time at about 50, 60 months, That's when you first see the benefit of surgery to remove metastatic relapse. Everything prior to that are iatrogenic events. They are induced by something that happens at the time of surgery. Okay, well, I'm sure you're wondering how I figured out that these are surgery-induced angiogenesis and surgery-induced single-cell activity. I gotta go back a few years. In 1989, I was visiting professor at the University of Texas, San Antonio, in the Bill McGuire's laboratory. McGuire is the person who first figured out that bones are features for relapse and for treatment for breast cancer. He died in 1999, I think. At any rate, McGuire asked me to come to San Antonio to see if I could take the computer simulation I had previously done, and if I could figure out what is the effect, what is the quantitative effect of estrogen and progesterone markers in breast cancer patients. And they had a very large database, several thousand patients. And I was given a 10-month period, a week, 10 months to come to San Antonio, and we're trying to develop this computer simulation that includes estrogen and progesterone markers. Anyway, project didn't, about 4 months, 4 or 6 months, whatever it was, ended up at the point where it's just not working. It was a failure. We get it to work. We had to use a Cray supercomputer because the number of patients was so large. And it just, we never got good answers. I ended up going to McGuire saying, hey, I give up, something's wrong, we failed. So McGuire brought in the person who the database for the San Antonio database. And it turns out that one of the columns I was gifts of a patient actually was the date that the patient last saw the physician. So no surprise that the results didn't come out. So McGuire said, well, okay, there's not enough time to finish the project. You have the 4 months left, do whatever you want. So I ended up spending the time in the library. They had a beautiful library. This was before the time of computers where you had a database, no actual books anymore. You had papers that were stored in on databases, and it was a situation where it was a very good place to do research on literature search. In data showing how cancer cells grow. This was a period of time when physicians often left cancer patients sit there for a while. They didn't react. They didn't do surgery right away. They just would watch the disease for a while. And as a result, there were a lot of papers published where there were data on untreated patients. And this is one that really caught my eye. It was published by Smithers in 1968. This was the case of a 16-year-old boy who was diagnosed with osteosarcoma. And what Smithers did, he did 7 months, except take x-rays of the lungs. Osteosarcoma relapses typically to the lungs, so that's where we expected to see metastasis show up in the lungs. But for the first 7 months, they took 4 x-rays, absolutely nothing in the lungs. And then all of a sudden, the next time they looked, there was something that showed up. And then for the next year, he again did nothing other than take x-rays, and he saw the tumor grow in size. The remark of these data was the time when first metastasis show up correspond when they amputated the leg. And the remarkable thing was that never seemed to respond that metastasis formed. I spent hours looking at this figure, studying it. What is this figure telling us? Did the Asian cause the metastasis to form, or is that just coincidence? I had a hard time believing that's a coincidence. I mean, this was a over a year process, and all of a sudden, just when the amputation, the metastasis showed up. So I said, no, this says that amputation can cause the metastasis to happen. It doesn't say how often it happens. Does it happen 1 out of 100 times or 99 out of 100 times? But it does happen. That's quite clear. This is something you'll never see again. For 7 months, except take x-rays, and then for the next year, do nothing other than take more x-rays. They're going to operate and treat right away. So you'll never see this again. This is one of a kind. I ended up coming to the conclusion that, yeah, surgery can cause a relapse. Don't know how often it happens, but yes, it does. So I was able to use surgery-induced activity to, going back to this figure, I was able to show that surgery-induced angiogenesis caused that 10-month peak. That peak was too sharp to be explained by any other not any other method for a cancer to start growing. It was just too sharp. I couldn't do this unless I had a surgery-induced angiogenesis. And then 10 months later, they showed up as relapses. So that's what I found. Putting it all in a quantitative fashion, that early peak, the dominant peak, composed of 2 previously unreported relapse modes that were surgery correlated. And that 10-month peak, of course, was really mostly strong for the premenopausal node positive patients. It was quite sharp. 20% of those premenopausal node positive patients underwent this relapse. It was 5-to-1 node positive to node negative, and 2-to-1 premenopausal to postmenopausal. And then those previously inactive single cells were induced to division and stochastically vascularized. That's a 30-month peak. And it turns out those 2 previously unreported surgery correlated relapse modes correspond to 50 to 80% of all relapses in those patients. This is not a small effect. This is a very large effect. And that late peak is more or less the natural history of disease, and the benefit of surgery to reduce metastasis first appears at 5 or 6 years. Okay, I've looked at a lot of other cancers, and now that my eye was trained to see a bimodal relapse pattern, you can see it in every cancer patient, every cancer that I've looked at. And I've looked at a lot of them. This is just a sample of the ones I looked at. These are either case reports or large databases. The pancreatic was a case report. Melanoma was a case was a large database. Lung cancer, it shows up, prostate, osteosarcoma, and so on. And I happened to be looking at a book published in 1994, a historical review of breast cancer treatment. This was in a book, Breast Cancer Controversies in Management. The author of this chapter was Irving Ariel. And this was just a random case that I happened to be looking at this chapter. I wasn't looking for it, but it struck me really interesting. It turns out that Ariel looked at comments written by Celsus and Galen, ancient Greek and Roman physicians and researchers 2,000 years ago, and reading what they had written, it seems to me that they knew all about this. Let me tell you what Celsus wrote. Well, first of all, these comments have been translated probably several times, so I don't guarantee the accuracy of each word, but this is the general interpretation. Celsus, first there's the cacoethes. Cacoethes is a term that's no longer used, but hundreds of years ago, it referred to a small but apparent lump. Tumor, it didn't have to be cancer, it just was a lump. First, there's a cacoethes and carcinoma without ulceration, then the fungating ulcer. Well, that's more or less a staging criteria. None could be removed, but the cacoethes, the rest are irritated by every method of cure. The more violent the operation, the more angry they grow. You occasionally hear physicians talking about cancers as being angry. It acts like they're angry. After excision recurs, bringing with it the cause of death, whereas by using no extirpation, you can protract the lives, notwithstanding the disorder, to an extreme old age. That sounds very much like they're reading my papers. Gallon said something similar. They have often cured this disease in the early stage, but after it has grown to a noticeable size, no one has cured it with surgery. Well, remarkable. This stuff was really remarkable. They knew all about this thing I've been talking about just a few minutes ago. We are latecomers to a 2,000-year-old problem. And the other thing that interested me was that without benefit of infection control or pain control, they were actually able to cure patients. That was remarkable. Okay, this is such a large effect that I wondered, can this explain important clinical observations? And it's such a big effect that it should show up if you know what to look for. And I'm listing 4 things here that can be explained that way. First of all, adjuvant chemotherapy works really well for premenopausal node-positive patients. And published a paper with Bonadonna, who was like Bonadonna, who was the first person to use multiple drugs in treatment of breast cancer. And he spent 30 years developing that. And Judah Folkman, I was on Folkman's staff at the time. Folkman was the person who, after 30 years of work, he had developed the science of angiogenesis. Kelly is there, Bill Reshevsky. Bill Reshevsky is a medical oncologist. It turns out I was diagnosed with stage 3C colon cancer in about 1994. And Reshevsky was my medical oncologist. And it turns out I was the first person that was treated with metronomic chemotherapy. That's low dose, long-term therapy. And Valagusa was the database manager of the Milan database. Published a paper saying that this could explain why chemotherapy works really well for premenopausal node-positive patients, because with that surgery-induced angiogenesis, that's very intensive growth right after the time of surgery. That's when Bonadonna found out that's the best time to give chemotherapy, right after surgery. And the chemotherapy is more effective on rapidly growing cancer. So this is no surprise. And Demichelli, Folkman, Reshevsky, Valagusa, and Bonadonna all agreed this is a reasonable hypothesis. So that was published in 2004. And it turns out that mammography works better for women aged 50 to 59 than 40 to 49. Published a number of papers on this. We could quantitatively explain why mammography works better for the ones who are postmenopausal than premenopausal, because they don't have that surgery-induced angiogenesis. Published a lot of papers. That one paper in 2005 was important. I happened to be sitting in one of the Folkman lab meetings and happened to be sitting next to a Wall Street Journal reporter, Amy Marcus, who was a Pulitzer Prize winning reporter from the Wall Street Journal. And Amy just asked me, what are you working on? I said, well, I'm working on this paper about that's going to report on the surgery, that surgery causes angiogenesis and early relapse in premenopausal patients. That explains why mammography doesn't work so well for those. Well, Amy was a premenopausal woman, and she never heard about this. And she talked to her editor at Wall Street Journal, and she was a premenopausal person who never heard about this either. So they decided that they're going to have Amy write up a little report. Actually, it turned out to be a 1,200-word report published in the Wall Street Journal on the same day that the paper was published, and also Harvard issued a press release on that same day. Well, as you might imagine, it's got plenty of attention. A number of got television and newspaper reporters constantly asking me for interviews, but I decided not to get involved in that. At any rate, letters came in, and one letter in particular changed the way we were doing research. It was from Isaac Gukas. Isaac Gukas is a native Nigerian. He was, at the time, he was a surgeon working in UK, one of the universities there. And being in Nigeria, he practiced oncology there for about 10 or 15 years. And he said in this letter, this could explain what happens in Nigeria. In Nigeria, when a woman finds a breast lump, they don't go to a surgeon. They go to an herbalist to get some soothing ointments. And then they go back to their village where with these ointments, they live a relatively comfortable life until they die from untreated breast cancer. This was fascinating to me. Something is going on in the Nigerian patients. Turns out that I've been to Nigeria 3 times in the past few years, trying to understand what's going on. I found out that Isaac Gukas was correct, that women in Nigeria just don't go to a surgeon when they first see a lump in their breast. Something is going on differently in Nigeria. And then there's a racial disparity in outcome. In the US, there is about a 1.5-fold excess mortality for African Americans compared to European Americans if the African Americans are diagnosed less than age 57. But there's an inversion at age 57. If they're diagnosed over age 57, there's an advantage, a mortality advantage. So it's hard to relate this to a reduced access to quality medical care because they're African Americans. It's got to be biologically driven rather than socioeconomic. I mean, we thought that was probably a benefit because it'd be much easier to solve a biological problem than a socioeconomic problem. Published a number of papers, and Gukas was one of our co-authors. This Jatoy paper talked about the inversion at age 57. And then this fourth item is that it's common that breast cancer in young women is referred to as aggressive by the surgeons. They see it as aggressive. They remove a primary tumor and within a year you get a relapse. Well, that may seem aggressive to them, but for my perspective, our perspective, it's more or less than the clockwork relapse 10 months after surgery. So at this point, to summarize, the most important finding, something happens at or around the time of surgery to precipitate these early relapses that account for 50 to 80% of all breast cancer relapses. These are in patients who were treated with surgery only. And surgery apparently causes something that induces angiogenesis of dormant avascular micromets and starts growth from single dormant cancer cells. And this may be a general effect, not just limited to breast cancer. June 2010, this unexpected paper came out, Patrice Forget et al. Forget is now in Scotland, but at this time he was at Brussels in Belgium, and this is a teaching hospital, so they had to expose the residents in anesthesiology to all the drugs given in anesthesiology. So they had data on patients that were treated with all the drugs available to them at that time. So what Forget did, and he and his colleagues, they did a retrospective study to see what was the outcome of those patients, and they were grouped by what drug was given at anesthesia. And it turns out that one drug, ketorolac, was by far superior to every other drug. Ketorolac is an NSAID. There are 3 NSAIDs that are available by IV, and ketorolac was the only one that they had at that time at that hospital. So there was a big difference. It looks like ketorolac seemed to block those early relapses. So Kelly and I went to Brussels and we gave presentations and they gave presentations. We totally believed their data. Kelly got a updated data, and it turns out that there was a 5-fold reduction in those relapses from 9 to 18 months. And there were 300 and some odd patients involved, so this was significant information. So at this point, we knew that some intervention at the time of surgery or before the time of surgery would be needed to stop these early relapses. But we didn't know what mechanism could explain that Forget data. And here's a quote from Hiller Brodner from 2013. The perioperative period can be considered a perfect storm of immunosuppression and inflammation in the presence of residual or circulating tumor cells. That's pretty important. If you want to take home one single sentence, that's a pretty good one. What we did is we did a survey. We're trying to look at these very large, complex fields, looking for correlations among them. Surgery, inflammation. Well, after surgery, inflammation shows up as an excess signal in IL-6 for about a week after surgery. Angiogenesis might play a role. Platelets actively sequester angioactive factors and they degranulate in the presence of inflammation, and VEGF increases for that 1 week. There are circulating tumor cells. That's pretty common in cancer patients. The immune system is compromised. As we know that there is immune system can sometimes keep cancer at bay. Cancer dormancy is well known in cancer, especially breast cancer. Neutrophils seem to show up in this. A comment from Balkwell, Mantovani, inflammation is not the spark that causes the genetic damage, but it's the fuel that feeds the flame. Igawa et al. In 2013 showed that capillary permeability increases from the presence of inflammation, whereas before that it can cause 30 to 70 kilodaltons to escape the capillaries. Now this goes at 2,000 kilodaltons in the presence of inflammation. Okay, there are several mechanisms that we think could be active in this. First of all, neutrophils respond to inflammatory signals, and they sometimes form web-like projections called nets, neutrophil extracellular traps. These nets are able to enhance metastasis because they bind circulating tumor cells and they can extravasate into distant organs. After reading that chapter 4, Hiller et al., I would be surprised if surgery didn't cause cancer to spread. This was a paper written by Creel et al. He's part of Bob Weinberg's group at MIT. Published a paper in 2018, Science Translational Medicine. They developed an animal model, a mouse model, where they can inject cancer cells into the mouse, and if the immune system was intact, these cancer cells would go into a dormant state, but only if the immune system was intact. But then they could do an experiment. They could operate on any part of the mouse, and you can get tumor growth at any other place. And they could control this with a perioperative NSAID. So that certainly makes a little sense. That could explain those data. This was chapter 8 in that Springer Nature book. This is a Danish mark, Marie-Louise Bonnelike Berntz et al. They had a zebrafish model where they were able to color code neutrophils, and they would wound this zebrafish Zebrafish is a semi-transparent fish, and they can actually watch these neutrophils, and they get directed to the sites of the wounding, but then they get diverted to pre-neoplastic cells that then start to divide. So this is another possible mechanism. As I mentioned before, platelets actively sequester angioactive factors and then degranulate in the presence of inflammation. And data show platelets decrease by 10% for about a week, and VEGF increases similarly for about a week. Another interesting paper here. This is from a Harvard group, Panagrahi, Deepak Panagrahi. I happen to know about 3 of these authors. This is a very high level group. I know particularly the last author, Vikas Sukhatme, who was Dean of Medicine at Emory University, very smart guy. He was a co-author on one of our papers. The first sentence in their paper talks about cancer treatment as a double-edged sword. They say that surgery, which includes biopsy, chemotherapy, and radiation, can induce escape, tumor dormancy escape, and subsequent metastatic outgrowth by impairing some tumor-specific immunity by inflammation processes. Inflammation causes these growth signals and loss of resolution of inflammation. This is a pretty controversial comment, but I'm telling you, I have a high confidence in this group. Okay, after all this attention, there turned out to be 3 kinds of responses that I was collecting on the internet: emotional, official, and scientific. Emotional, this is from a PhD level cancer patient. Yikes, can surgery spread cancer? The second one is from NIH. The chance that surgery will cause cancer to spread to other parts of the body is extremely low. But then that Creel paper was reviewed by Komarov in the New England Journal. And the comment was, clinical lore says that resection of a primary tumor can cause previously inapparent metastatic deposits to flare. Well, there's a lot that could be said about these 3 items on this page, but I will spare this audience my comments, but I guarantee that I can talk for a long time about this. Conclusions. First of all, we're talking about an unsolved 2,000-year-old problem in oncology. And these early relapses, especially in breast cancer, which we've studied in extensive area, which comprise the majority of relapses, are surges of angiogenesis and activation of single cells. These events are triggered by primary surgery that causes systemic inflammation for about a week. And systemic inflammation causes dormant cancer cells and deposits to exit dormancy, resulting in relapses by a number of those mechanisms I mentioned. I don't know, 5 or 6 of them. Data suggests transient systemic inflammation is the precipitating factor that results in angiogenesis and single cell growth from dormancy. And the Forget data suggests that perioperative NSAID ketorolac reduces early relapses 5-fold. This has not yet been confirmed in a retrospective controlled clinical trial. We have calculated, though, that this should reduce breast cancer mortality by 25 to 50% at low cost and toxicity. Low cost, this is a $5 drug given at the time of surgery. That's all there is. Chemotherapy might not be needed, whatever, that's to be seen. But we think this is going to result in a 25 to 50% reduction in mortality. Another thing, this is not going to solve the cancer problem. There's still going to be need for immunology field. So this is not, I'm not in competition with the remarkable work done in immunology. Both what I'm talking about here and the immunology work together may make a big dent in the cancer problem. And breast cancer runs its course in over a decade, but it appears that most of the events that lead to relapse seem to occur in that 1 week post-surgery, suggesting that metastatic progression is amplified 100-fold during that post-surgery week. And judging from the Fisher data I showed you before, it looks like 1/10 of patients with node 0 and 85% of patients with more than 12 nodes have surgery-induced relapse. This may explain the value of mammography, because mammography is designed to find more patients with N0 and very few patients with N more than 12 or N positive in general. So if we could solve the early relapse problem, this might make mammography a little bit less needed, but still be valuable. There was a retrospective study, a second retrospective study of perioperative NSAID, ketorolac, that was reported by Desmond Demakeli et al. In the Journal of the National Cancer Institute, 2018. This is accompanied by an editorial by Ben Eliyahu and Golan. As a general comment, the surgeon and the anesthesiologist should do their best to control inflammation at and after the time of surgery. At Beth Israel Deaconess Medical Center, that's one of the Harvard hospitals, ketorolac is given to all breast cancer patients just after surgery. The patient is still on the table and probably still under the anesthesia, and they inject the ketorolac. So it's within an hour of surgery. There is a clinical trial underway in Japan for non-small cell lung cancer. They're not using ketorolac, they're using some other NSAID that's more common in Japan. And there have been a number of retrospective studies for a variety of cancers. One example is that esophageal cancer. I've seen ovarian, I've seen colon cancer, I've seen a number of cancers, must have been at least five cancers. And the last comment, a crisis is apparent. Okay, these are my co-authors. My co-authors include 3 surgeons, 2 medical oncologists, and 1 anesthesiologist. That's in a paper I published in 2020. This big picture on the left, I'm standing behind Rick Rogers, Pat Wood, Bill Rashevsky. Pat Wood died of cancer a couple of years ago. She was a medical oncologist and married to Bill Rashevsky, who was my medical oncologist. And then that's Romano Demakeli sitting next to Bill Rashevsky. And above above Demakeli is Pinuccia Valagusa and Gianna Bonadonna from Milan. Upper right is Patrice Forget. Beneath Patrice Forget on the right side is Osaro Erhabor. He is my main contact in Nigeria. Good friend of mine. He's been a co-author of these papers. This is Vikas Sakatmi, who was the co-author of that paper talking about surgery and biopsy and radiation can cause tumor growth. And below Osaro is Judah Folkman. I was on Folkman's staff at the time. And in the center picture on the bottom, Mike Baum, Isaac Gukas, and myself. Mike Baum is a retired UK surgeon. Isaac Gukas. At this meeting, this is a meeting at the Royal Medical Society in London, and Isaac was telling us a story of how when he was in Nigeria, there was a televised debate between him and an herbalist on how was the best way to treat breast cancer. If you can imagine something like that happening in this US, that would be really strange. And lower left, the picture lower left is Ted James. He was the co-author of the paper, that 2020 paper, and he is the person who in charge of the surgery, breast cancer surgery at Beth Israel Deaconess Medical Center. Picture in the center, myself, Romano Demicheli, Jayant Vieta, who is a UK surgeon, and that's Isaac Gukas. I think I've covered everybody. Next, these are a few of my friends from Nigeria. And just to summarize, recent, recent references, published a paper in 2020, Retzky et al., Demicheli, Baum, Ted James, Bill Rashevsky, J.N. Vieta, Nelson Osaro Nelson, Patrice Forget, Breast Cancer in a Black Swan. That's available for free on PubMed. eCancer 2020. Just do Retzky author, and 2020, this paper will show up. Another paper was published in 2020 where the Black Swan paper explains how to prevent the early relapses. The second 2020 explains how to prevent the late relapses. And I will discuss that in a minute. And there, I'm going to be citing a paper from Delekas Demicheli et al. They did a reconstruction pattern. They followed delayed breast cancer reconstruction after mastectomy. These were variable periods of reconstruction for a number of years. It could be, normally right now, reconstruction is done right after mastectomy, but in those periods, in that time, in that country, somewhere in Europe, it was 2 and 3 years after surgery that they did the reconstruction. And these two links on the bottom, they're describing my work. Where are the low-cost cancer treatments? That discusses my use of metronomic chemotherapy. And that one, IIT EDU, that's from my alma mater, discusses how I became a cancer researcher from doing physics research. So this is, pardon me, this is a figure from that paper where they did the delayed reconstruction. They looked at these patients who had delayed reconstruction, and they set time 0 equal to the time of surgery. That's the blue curve, or black in this case. And there's a bimodal relapse pattern. There's a much bigger late relapse period than the early relapse. But then they set time equal to 0 for the reconstruction. So this was, they also got a bimodal relapse pattern. That first peak was by far larger than the second peak. This says two very important things. First of all, it says that it's not cancer surgery that causes this to happen, but it says that anyone who is planning a surgery for some cosmetic reason, like these people were doing surgery for a cosmetic reason, or they could be doing surgery for some medical reason. I don't know, something's going on and their doctor wants to give some sort of a surgery. These people should probably have perioperative ketorolac, the same as if it was a primary breast cancer surgery. Well, thanks for your attention. I hope this was interesting to you. I can be reached at michael.retzky@gmail.com if you have any questions.
Thank you so much, Dr. Retzky. As usual, I always actually enjoy your presentations, and it was quite interesting. So any questions or comments from audience for Dr. Retzky?
Oh, by the way, I think I mentioned before, but the work I'm talking about is going to reduce the breast cancer problem and the cancer problem, but it's not going to eliminate it. So the need for the immunotherapy still exists. And I'm thinking that the combination of what I'm talking about plus the immunology will really make a big dent in the cancer field and all the cancers.
Perfect. Thank you, Dr. Retzky. Thanks again. Okay, so any questions, any comments? All right. Wow, we finished another wonderful conference under utilitarian conference gathering. And thank you everybody for joining us and making this conference a great success. So all those who contributed to the conference, thank you for all your excellent work. It is fair to conclude that the conference was a great success. So many people have contributed in so many ways to turn this event into a smoothly running meeting with many very interesting presentations and very good atmosphere for discussion and networking. Thank you again. And by the way, the certification will be provided for 2 days on Monday. So day 2 speeches will be uploaded once we received it from groups of speakers from a few countries. So you can get later. So the certification will be for 2 days. Thank you again, and thanks. Could you please give us any feedback or comments in general about the conduction of this one-day conference so far?
Okay. Thank you.
Any comments? We'll be happy to have your comments, your suggestions.
I would like to express my gratitude to all the participants from various parts of the country. And this was a wonderful platform to exchange ideas from people in different parts of the world. I learned a lot from this academic session. I'd like to thank the organizing committee for providing me this opportunity to chair the session and to deliver a talk. And I look forward to attending such conferences in future again. Thank you.
I agree with that. Thank you.
Thank you so much, Dr. Saluja. Thank you, everybody.